We put the leg outside the bed and she was good.
Okay.
Is it?
Perfect. So, Sophie, I am going to take care of you for the next few hours and we are going to remove the tube. Are you happy? So you are going to be able to speak again and we can hear your voice again.
Okay.
Perfect.
So, see you tomorrow.
See you. You're free to go, Alessandro.
Bye.
Bye.
Sophia, we're going to take the tube out now. Just breathe normally. It can be a little bit uncomfortable when I do the suctioning. Just breathe normally. Breathe normally. Okay, ready?
Ready?
On 3. 1, 2, 3. Perfect. Breathe normally. Everything fine? Perfect.
Yes.
So, Massimiliano, what can you tell me about Sophie?
Lady Sophie, she was extubated today because her condition has been improved in the last 2 days. Her septic shock is completely resolved and she is not anymore on most of the effective drugs. So she has been improving in the last days.
So, there's no organ insufficiency, so all organs are working normal, we have no organ support.
Yeah, exactly.
Okay.
The cardiac function is completely restored and also the kidney function is going well.
Okay, perfect. Did she started eating already?
Yes, she started eating today and also she has been mobilized out of bed in a chair.
Okay, perfect. Looks good. So she can be discharged tomorrow, right?
Yeah, the program is that one. If everything is like this tomorrow, she will be discharged in the ward.
Okay, okay. Good, perfect. Thanks. In the afternoon, we do a handover from the day shift to the night shift. Important information will be exchanged so that I can take care for the patients during the night.
In our ICUs, you will see the interprofessional team. You will see doctors, nurses, health nurses, physiotherapists, you will see social workers, and many people working in the ICU from other specialties like the consultants, or sometimes you can see people who are helping ICU patients for different things. We are an interprofessional team. The teamwork is important because any outcome in the ICU is the result of how we work together and how we are structured and able to deliver the best critical care for our patients.
Hi, Silvia. How are you?
Fine, thank you. How are you?
Fine, thanks. And she is Sophia. Do you remember Sophia?
Yes, from yesterday.
Sophia, she is Silvia. She's the nurse who is going to take care of you for tonight.
Hi.
You could see she is really improving. We were able to stop her medications, inotropes vasopressor. We were able this morning to reduce ventilatory support and then this afternoon to stop ventilatory support and remove the tube. And she is also able to swallow. We try with water and then with food. So we were able to remove her nasogastric tube. So she is really, I think, feeling better.
Yes. So tonight, it seems to be a quiet night. You will be able to have some rest. I will put the lights a little bit off and the sounds, the less sound of possible, so you can have some rest. And tomorrow you will be able perhaps to go out from the intensive care unit. Okay, if ever you need something, you call me, I will be there.
Okay, thank you very much. Perfect, I leave you in really good hands. See you tomorrow. See you tomorrow. Bye.
Bye.
During clinical rounds, we assess whether patients have symptoms that we need to control. We usually do that with doctors and nurses as well as all the professionals during clinical rounds. We are very much paying attention to whether patients are painful. We not only assess pain intensity and pain distress, but also response to pain therapy as to be sure that pain is controlled. Other symptoms like distress, anxiety, hunger, and thirst are also symptoms to which we pay attention, and we are making our best to control these symptoms several times a day.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Good morning. Good morning, Sophie. Hello. It's 7:30 now, and it's time for me to talk to my colleague about what happened to you this night. So I'm going to tell about you and about everything around you. Is that okay? Okay. This is Alessandro, and he will take care
Hi,
for
Sophie.
you in this day. Okay. Well, Alessandro, this is Sophie. She came in here 3 days ago with a septic shock, and overall she is doing well. If we look, you see she's still intubated. It's in her lungs, yes, you can see. But I managed to build it down this night. So she's not on the pressure controlled, she is more doing for herself in the breathing. So I think that she can further go on today. So maybe you can manage to let her breathe for herself.
Okay, she goes better, yeah.
Yeah, and I think that will be a very good step forward for her that she can work on. Furthermore, the blood pressure that is stable, and this night we lowered down the medication to keep it stable. So I think in this morning you could stop it.
Okay, well, so you decrease the ventilator and the medication support.
Yes.
Okay.
And well, that was because she was also a little bit agitated, so that gave her the push and to give her the stability to push forward. So I think she also needs your support today to be calm and to have enough comfort.
Okay. And did she receive the visit of her family member?
Yeah, yesterday they came. Her mother comes, and she has a friend, and he also comes. And I talked to her mother on the phone this morning, and well, she told me that of course she is worried, but she's not communicating well enough with her boyfriend.
Okay.
So it might so be that you could consult the social worker, so that the social worker can arrange, well, maybe a discussion or maybe talk to the mother and have reassurance for the mother.
Okay, later. Okay.
Yeah, I think that will do for her very good. For the rest, I think it would be nice for her to get out of the bed, and she needs that to get out, and that will be a good point.
Yeah, okay, I think so.
Have you any questions for me?
No, it's okay. Thank you.
Okay. What we have done is to turn over my shift in the night to the day shift. And what is needed, that I tell what happened this night to Sophie, to my colleague, so that he can take very good care for Sophie with all the machines around Sophie.
It is very important to share this information with every team members of the intensive care unit for the best care of Sophie.
For the third time for the What to Do Today session, and I will discuss with you what you can do today. Well, I'm confident you have had a very interesting day yesterday, and we are heading now already the third and last day of the Congress. Well, why not have a nice cup of coffee or tea and watch the third groundbreaking release session? But there is also at 9:15 there is a special event made by NEXT and the Education and Training Committee. It is the Critical Care Cup at Channel 5. That sounds very interesting. But if your interest is especially on research, do not miss the best oral presentation at Channel 1 with the big variation in very interesting subjects. I've had a look at it, and please do so. But if you are also very much interested in pediatric ICU, the choice to make will be even more difficult. At Channel 2, a roundtable on pediatric intensive care is starting at 9:15 as well. At 10 o'clock, again, the breaking news update by the President and the President-elect. And a little bit earlier than you are used to, at 10:30, I will have the interview with the section leaders. And this time I will speak with Mette Berger on metabolism, endocrinology and nutrition, and with Jordi Manfebo on respiratory failure, and with Christian Jung on health services and outcome, and Arne Veldhuizer on anesthesia and perioperative medicine. So that is very interesting for you to know. The situation in the not-so-rich countries is given major attention in a roundtable debate at 11:15. Colleagues who know what they are talking about from the practice will discuss best care in a situation of limited resources. Very interesting subject, very important subject, I think. And this will be at Channel 5. At the end of today, we will have the grand finale of the groundbreaking session and hot topics. And this Congress as such
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. Good morning, good afternoon, hello wherever you are. Day 3 of our Lives digital conference. A very exciting day with a lot of research presented here from the TV studio. A pleasure again to be here with the Editor-in-Chief of ICM Experimental, Nicole Uferman.
Good morning.
How are you, Nicole?
Oh, I'm looking forward to another day full of great research and new data.
Fantastic.
Yeah.
And Giuseppe Citterio, Editor-in-Chief of Intensive Care Medicine.
Good morning, everyone. Good morning, Maurizio. Good morning, Nicole. And I think today we will have other release of paper from the Society Journal, but also from other big journals. So it will be an exciting day today.
Indeed. So stay tuned. And without losing any more time, let's go straight to the paper presentation. So a pleasure to invite to present the study Dr. Mahesh Ramanan from Brisbane. Is an intensivist with an interest in clinical trials, methodologies, fluids in critical care, and integration of digital technology into clinical research. So Mahesh, the stage is yours.
My name is Mahesh Ramanan. I'm an intensivist from Brisbane, Australia. I will be presenting the results of the sodium chloride or plasmolite 148 evaluation in severe diabetic ketoacidosis, or SCOPE-DKA trial, a cluster crossover randomized control trial. I have no conflicts of interest or other declarations to make. Diabetic ketoacidosis is a life-threatening emergency that can occur in patients with both type 1 and type 2 diabetes, and it's one of the most common first presentations of type 1 diabetes. It is a syndrome caused by absolute or relative insulin deficiency with concomitant elevation in counter-regulatory hormones such as glucagon. This results in hyperglycemia and excessive lipolysis. The free fatty acids produced by lipolysis are converted to ketone bodies, causing hyperketonemia. Both hyperglycemia and hyperketonemia contribute to the hyperosmolar state seen in DKA. The ketone bodies, acetoacetate, beta-hydroxybutyrate, and acetone are weak acids and cause a high anion gap metabolic acidosis. There is subsequent glycosuria and ketonuria, which leads to osmotic diuresis. This causes obligatory electrolyte and water losses, leading to severe intra- and extracellular dehydration and electrolyte derangements. Vomiting often accompanies DKA and accentuates dehydration. The average fluid deficit in patients with DKA is typically around 3 to 5 litres. DKA is treated with fluid therapy, electrolyte replacement, and insulin replacement. While there is broad consensus agreement on insulin replacement in DKA, and electrolyte replacement is guided by serum concentrations, optimum fluid therapy is a matter of significant uncertainty and debate. Saline, or 0.9% sodium chloride, is the most widely recommended fluid for DKA patients worldwide, including in major national guidelines published by relevant societies in the USA and the UK. As a consequence, saline is the most commonly used fluid in patients with DKA, despite the lack of strong randomized trial evidence to guide this choice. Plasmolite 148 may be a better alternative in DKA patients. It is isoosmolar to human plasma in health and slightly hypoosmolar to the plasma of a patient with DKA. It has a physiological fluoride concentration, thereby avoiding the hyperchloremia frequently seen with saline use, and contains acetate and gluconate anions as buffers, which contribute to its alkalizing effect. However, acetate is a precursor to acetoacetate, one of the 3 ketone bodies implicated in DKA. Plasmolite 148 contains acetate anions at a concentration of 27 millimoles per liter. Clinically significant ketogenesis due to acetoacetate production from acetate is known to occur in hemodialysis patients. Whether a similar clinically significant metabolic step occurs in DKA with plasmolite therapy is currently not known. We designed the SCOPE DKA trial to test whether plasmolite is a better alternative to saline in DKA and whether its use leads to ketogenesis. Specifically, we hypothesized that in critically ill patients with severe diabetic ketoacidosis, fluid therapy using plasmolite 148 compared to saline will result in faster resolution of diabetic ketoacidosis and will not lead to increased ketone generation. SCOPE DKA was a cluster randomized crossover open label phase 2 trial of plasmolite versus saline as fluid therapy for patients with severe DKA. It was conducted at 7 regional and rural ICUs in the state of Queensland, Australia. All participating hospitals had closed model, mixed general medical, general surgical, intensive care units. This is a flow diagram depicting study timelines. After identification of sites and local ethics and governance requirements were satisfied, the participating ICUs were randomized to either plasmolite or saline for 6 months, from September 2019 to February 2020. There was a 1-month washout period during which the Data Safety Monitoring Committee review occurred. The sites then crossed over to the other fluid from April 2020 to September 2020 for a total of 12 months of recruitment time. We included patients who were aged 16 or above, had severe DKA diagnosed as presenting blood glucose greater than 14 millimoles per liter, and either arterial pH less than 7.25 or bicarbonate concentration less than 15 millimoles per liter, and ICU admission was thought to be necessary as judged by the treating clinician, usually the attending doctor in the emergency department. Patients under the age of 16 were excluded, as were patients who had already participated in the trial and those who had an admitting diagnosis of hypoglycemic hypoosmolar state. The participating sites used the study-allocated fluid for all patients with severe DKA. The fluid was used for both resuscitation and maintenance purposes. The volume and rate of fluid infused and endpoints for fluid administration were determined by the treating physician. Drug dilution and infusions were prepared as per local protocols. This was due to potential incompatibilities with using plasmolite as a diluent. The study-allocated fluid was commenced as early as possible in the emergency department and continued in the ICU for 48 hours or until ICU discharge, whichever occurred earlier. The fluid choice after ICU discharge was at the discretion of the treating physician. Other aspects of DKA care and management, including insulin and electrolytes, were as per local protocols. Given that this was an exploratory phase 2 trial, we used a fixed recruitment time and fixed number of clusters, that is ICUs, rather than a priori sample size calculations. Ethics approval was obtained for all participating sites from the relevant institutional review board. A full waiver of consent was granted due to the low-risk nature of the trial. There was no specific funding for this trial. It was performed using in-kind funding from investigators and clinicians at participating ICUs. The primary outcome we selected for this trial was resolution of DKA at 48 hours. Resolution was defined as recovery of base excess to greater than or equal to -3 milliequivalents per litre. Sensitivity analysis were conducted using, as outcome, resolution of DKA at 24 hours and resolution as per the American Diabetes Association criteria. These criteria were a plasma glucose less than 11.1 millimoles per litre and 2 out of bicarbonate greater than 15 millimoles per litre, pH greater than 7.3, or anion gap less than or equal to 12 milliequivalents per litre. A variety of secondary outcomes were assessed, including length of stay in the ICU and hospital, and ketone concentrations at the listed time points. Mixed effects models were used for all analyses, with site as a random effect and patients nested within sites. Group allocation was used as a fixed effect. Let's now have a look at some of the results. This is the consort diagram detailing flow of participants. 7 out of 12 ICUs that were invited to participated. 3 ICUs were allocated to saline first and 4 to plasmolite first. After the first 6 months and the 1-month washout period, these ICUs crossed over to the other fluid for 6 months. There were 93 patients recruited at the 7 ICUs from a total of 100 eligible patients. 3 patients had missing data for the primary outcome. This left us with 90 patients, 42 in the saline group and 48 in the plasmolite group for the modified intention to treat analysis. This is a table of baseline patient characteristics. The patients in the two groups were broadly similar in terms of demographics, clinical signs at presentation, and biochemical disturbances. The plasmolite group had a slightly higher proportion of patients with type 1 diabetes, had a higher median respiratory rate, and more patients with base excess less than -24.1. This is a table showing fluid administration details up to 48 hours in the ICU. The average volume of fluid administered was approximately 6.8 litres in the plasmolite group and 6.6 litres in the saline group. Compliance, defined as the proportion of fluid received by a patient which was consistent with the group allocation, was higher in the saline group, with a median of 100% and interquartile range of 75 to 100%. There was little plasmolite used in the saline allocated patients, though there was some compound sodium lactate used in this group. In contrast, there was an average of 2.4 litres of saline used per patient in the plasmolite group. The median compliance in the plasmolite group was 66%, with interquartile range of 38 to 85%. Let's examine the metabolic course of the patients in the two groups. Firstly, ketones. It can be seen that the changes in ketone concentrations are very similar, almost identical, between the saline group in blue and the plasmolite group in red. Glycemic control. Similarly, we can see that glucose control was very similar between the two groups. Resolution of acidosis. The plasmolite group had higher base excess and pH from 6 hours onwards. There was significantly higher base excess at 24 and 48 hours in the plasmolite group compared to saline. Changes in electrolytes. While the sodium concentrations were similar between the two groups, there was a clear and significant separation in chloride concentrations within the first 24 hours, with higher chloride concentrations seen in the saline group. This is a table of outcomes. The primary outcome, recovery of base excess to greater than -3 milliequivalents per litre at 48 hours, was attained in 96% of plasmolite treated patients and 86% of saline group patients, with a p-value of 0.11. At 24 hours, the proportion of patients who had DKA resolution was 69% in the plasmolite group and 36% in the saline group, a highly significant result with a p-value of 0.002. There were also non-significant trends towards shorter ICU and hospital length of stay in the plasmolite group. These are better depicted on these Kaplan-Meier curves, ICU discharge on the left and hospital discharge on the right. The The separation in ICU discharge appears at approximately 12 hours and persists for 48 hours. The separation in hospital discharge appears at approximately the 72-hour mark. The SCOPE-DKA phase 2 trial has demonstrated that there is faster resolution of metabolic acidosis in patients with severe DKA when treated with plasmolite compared to saline as fluid therapy. Additionally, the serum chloride concentrations were lower with plasmolite therapy, and importantly, we observed no increase in ketogenesis with plasmolite. There were also non-significant trends towards shorter ICU and hospital length of stay with plasmolite. Our results are consistent with the broader critical care literature on the comparison between balanced salt solutions and saline. The biochemical outcomes appear to be better with plasmolite compared to saline, as suggested from previous non-randomized studies in DKA patients and small randomized studies of less severely ill patients. However, a larger trial powered to detect meaningful changes in patient-centered outcomes as well as health economic outcomes is required. The other major implication from our results is that the clearance of ketones in patients with DKA appears to be very similar between plasmolite and saline-treated patients. The adverse effects observed were also similar between the two groups. Strengths of this study include the severely ill patient cohort that was recruited with a baseline pH of around 7.0 and the near complete follow-up with minimal missing data. The main limitation was that this was an exploratory phase 2 trial which was not powered to detect significant changes in patient-centered outcomes. The fluids were not blinded. There was also relatively lower adherence in the plasmolite group, though some of this was explained by the use of saline for drug dilution. Additionally, the greater use of saline in the plasmolite group, as opposed to the reverse situation, would have tended to bias the results towards not detecting a true effect, that is, a type 2 error, rather than falsely detecting a non-existent effect or a type 1 error. In conclusion, in patients with severe DKA, fluid therapy with plasmolite compared to saline results in faster resolution of metabolic acidosis with a similar adverse effect profile and does not increase ketogenesis. A confirmatory phase 3 trial with patient-centered outcomes is necessary. I would like to sincerely thank my co-investigators, the SCOPE-DKA collaborators, and the Queensland Critical Care Research Network for their support in the conduct of this trial. Thank you.
Thank you very much, Mahesh, and congratulations, first of all, on this study, and welcome. We have lots of questions for you to answer now. Maybe I would like to ask, however, Giuseppe Citerio, the Editor-in-Chief of Intensive Care Medicine, to make a comment.
Thank you, Maurizio. I would like to say also that if you want to post your question, you can do it on the web, and we can read your question to the author. Hi, Mahesh. I think the first discussion we have in the journal when we received your paper was a phase 2 study, so we were worried about taking it because I think the implication for clinicians today are not so strong, even if there is a signal in the trial. And we were surprised looking back at the guidelines we have on AKI that there is not so much evidence, so we went in favor of having your article, your manuscript coming in the process, and we try to work with you for improving it a little bit. And I think that one of the considerations we have to think in this phase 2 trial, which are the implications today, because I think you demonstrate a signal in a faster resolution of severe DKI, but at the end, do you think that this is enough today for changing our practice? And the second question is, did you take in account all the possible complications? I know that the numbers are not so high, like AKI, like brain edema, and other potential complications of the treatment in the two groups. They are different, please.
Yes, so to answer the first question, first of all, thank you very much for the opportunity, both to have our paper published in the journal as well as to speak at the meeting today. In terms of the implications for clinical practice, the starting point for us was that the evidence to guide fluid choices in diabetic ketoacidosis is very limited. And considering that this is a condition where large volumes of fluid are used, it's probably one of the few indications in intensive care still, where we use large volumes of fluid. We felt that clearly that the evidence base requires this sort of a trial program. Because of the uncertainties around plasma-lyte and its acetate content, we made the decision to start initially with a phase 2 trial and look at some biochemical outcomes. And so I suppose that our intention was with this trial was never really to have a major impact on clinical practice. We wanted to firstly test the biochemical outcomes and make sure that the signals are consistent with what we would hypothesize, and also to look at ketone generation with the acetate content of plasma-lyte. I think from the perspective of this trial, we sort of answered the questions that we set out to answer. We believe that there are strong enough signals to pursue this further and to do a larger trial to look for changes in, look for significant, meaningful changes in patient-centered outcomes, particularly around ICU and hospital length of stay that would have importance for both patients and for healthcare systems, particularly in terms of being able to get these patients out of hospital faster. With regards to the second question regarding adverse effects, with a sample size of around 90, I think it's fair to say that any sort of uncommon or rare side effect may not have occurred in that sample. So can we be definitive about adverse effects? No, I think we would require a much larger sample to be able to say that. However, the main thing that we were interested in was particularly the ketone clearance, and I think very reassuringly, the clearance of ketones in both the saline and plasma-lyte group appeared to be very, very similar, with the curves, as you saw, almost superimposed on each other. But as for the other adverse effects, look, I completely agree with your point that we may not have the power to definitively say that that there was absolutely no difference in the adverse effects between the two fluids.
Mahesh, we're receiving a lot of questions about the plausibility of the research question and, in a way, also the clinical relevance. The questions, we can summarize. Why with plasma-lyte and not other balanced crystalloids like Ringer lactate or Harman's, which I understand also in Australia are used more widely?
Yes, so there have been concerns raised about the lactate content in Hartmann's or in Ringer's lactate contributing to gluconeogenesis and impairing glycemic control in patients with diabetes. I suppose there may be a regional flavor to this. But there are certainly institutions out there where Hartmann solution is not used in diabetic patients for that reason. And so it was largely a practical decision around acceptability. Secondly, plasma-lyte does have some theoretical advantages in that its osmolarity is closer to plasma. It's got a larger strong ion difference, hence a greater alkalizing effect, which is very relevant in the patient with diabetic ketoacidosis. And thirdly, it's also got a slightly lower chloride concentration than Hartmann's solution, which again is of relevance in these patients that are very prone to get a hyperchloremic metabolic acidosis in the resolution phase.
Okay, thank you. And then we have a question about where were these patients managed? Because often these patients usually they come at the door of the hospital in the emergency department, and so the treatment, the exposure to the treatments, was it occurring mainly in the emergency department, and who was handling the treatment?
Great question. So all of these patients would have presented through the emergency department, and so the initial part of the treatment would have been directed by the admitting physician in the emergency department. So typically that is, in Australia, that would be a specialist trained emergency physician. All of these patients, so we selected patients that required ICU admission. So we wanted the sickest of sick diabetic ketoacidosis patients. So all of these patients were then managed either in an intensive care unit or managed as ICU patients in an emergency department. So the management at some stage would have been transferred to a specialist intensive care physician. Now, in terms of where the interventions occurred, if we look at fluid volumes, for example, in the first, so up to the 48-hour point in ICU, the mean fluid received was approximately 6.7, 6.8 litres. And of that, the first 2.5 litres were received in the emergency department, and the next 4 litres in the ICU over the 48-hour period. I haven't, I mean, that roughly gives you an idea of where the treatment occurred.
Thank you.
Hi, Manesh. Congratulations with a successful trial. We're talking about methodology here, and I was just wondering, you noted an adherence to the protocol of 66% in your intervention group. And I was just wondering, how did the trial go? Was it easy to do? Are you happy with this number? Do you think it can go better? Can you elaborate?
Yes, certainly. So clearly this could be improved. Clearly there is room for improvement. The historical, I suppose, the important thing to recognize here is that saline has been the recommended fluid for DKA in our state. In the public health system. And so the majority of emergency physicians, and probably fair to say the majority of ICU physicians, are used to using saline. And certainly, when junior doctors, trainees, etc., see these patients, they would refer to the local guidelines and be confronted with saline. So it's historical practice. So we were expecting that compliance in the saline group would be very good. We did embark on education for the sites, and we were hoping that we would have reasonable compliance with the plasma light. We had a sort of a cluster design where sites knew at least a week in advance of the fluid that they were to use for these patients, and so we certainly hoped for better compliance with plasma light, but that wasn't the case. Since then, we have gone back and had an investigators meeting and spoken to all the sites, and a lot of the sites feel that there are different approaches they could take at a local level to improve compliance if we were to try and run a larger phase 3 trial with this sort of methodology. But look, I take that as a very fair criticism that that there was not as much plasma light used in the plasma light group as we would have liked.
And you informed that would the adherence be higher, the type 2 error, chances of type 2 error finding no difference would increase. So that really begs the question, I guess, of how are you planning to take this forward?
Yes, look, again, yes, that's a very valid question. I think the first thing to say is that we now have at least a core group of experienced sites that have done this and that are, sort of aware of the results. And, we're going to go through and look at the data at a site level and feedback, individual data to the sites. First of all, I think if we were to, as we go further, we do need to look at a more rigorous education program. We hopefully with some funding, we'll be able to have research coordinators that are dedicated for a period of a couple of months in advance to actually to prepare the sites and to have sites better educated on board. So I think there are some things that we can do, and some of the site investigators have some specific ideas about what might work at their site, and where the where the drop in compliance was in their particular circumstances. So look, I think there are things that we can do to improve.
Mahesh, we have some other questions. Lots of questions actually are coming up. I mean, you referred to the osmolarity before between the solutions. Did you look at osmolarity changes, if there were any differences in the groups?
Look, osmolarity specifically, no. So we did not, we did not require sites to measure osmolarity. We could go back and look at calculated osmolarity, but no, we do not have that data.
Okay, and then we have practical questions, which I know probably you don't want to answer since we're talking about a research study and future research, but considering what you've shown today, are you still using saline in these patients, or have you switched already to Plasma-Lyte?
Look, our practice here has, has largely been guided, as I said, by our local state guidelines, which still recommend saline. I don't think that the evidence that we've shown with this trial would be sufficient to overturn that and to change the recommendation to Plasma-Lyte. However, if you're asking me personally, I think I would prefer to use Plasma-Lyte in these patients.
Yeah, we are asking you personally.
Oh yes, look, personally, I would use Plasma-Lyte.
Giuseppe.
Thank you very much. I think we are waiting for the next step of this trial, in which we will see if the infusion is linked to more sensible outcome for the patient. But in the meantime, I think we need also to think about some other point along with the quality of infusion, the speed of infusion and the volume, because you reported the volume that has been infused, but also these two questions still need to be addressed a little bit in a trial, probably. Don't you think so?
Yes, look, I completely agree. I completely agree. This is a sort of a unique group of patients who do come in with a large fluid deficit. So I think there's plenty of scope to investigate, how much fluid should be given, how quickly, and how that fluid is spaced out in terms of how much fluid in the first few hours in the emergency department and then in the ICU. So yes, I think there's still lots of unanswered questions about fluid therapy in DKA.
Very good. Mahesh, thank you very much for this study. Congratulations to you and to your research team, and also good luck on the next phase of this research field that you're now exploring. So I would like to thank you. I also would like to thank my co-host, Giuseppe, but also in particular Nicole, because we have another session about groundbreaking releases later, but Nicole will not be with us because she's leaving, but it's been fantastic to have you here. And
it has been great to be here, and be sure to tune in on 12:15 for the ICMX session.
Exactly. So, thank you all.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, And we will do this by fostering research and education for our global intensive care community.
Good morning, everyone. I am Roundtables from Paris, France, and I will moderate this session with Stefan Schaller for Berlin, Germany. And this session is a best oral presentation number 5. And so we have some nice presentations. And the first one is dedicated to how to say, finding, association of deranged cerebrovascular autoregulation with brain injury following cardiac arrest, a post-hoc analysis of the COMA-CARE trial. And Dr. Laurie Kala will present this presentation. If Dr. Laurie Kala is ready, we can hear her.
I would like to thank the organizers for giving me the chance to present our data about the association of deranged cerebrovascular reactivity with brain injury following cardiac arrest. My name is Johanna Laurikkala and I have no conflicts of interest. The COMA-CARE study included 120 survivors of out-of-hospital cardiac arrest. All patients were monitored with a near-infrared spectroscopy NIRS device with 2 skin sensors. Here is one example of the relationship between tissue oximetry index TOX and mean arterial pressure. The dashed line showed the derivation of optimal TOX from the minimum Y value on the curve and the optimal map from the corresponding X value. In this figure, lower LLA and upper limits of autoregulation correspond to TOX 0.3, and the range of intact autoregulation is the difference between the limits. Of the included 108 ORCA patients, 32 had intact and 76 had impaired CVR. Baseline characteristics are presented here. Patients with chronic hypertension were more likely to have impaired CVR, 57 versus 31%. In a multivariable model including age, gender, and time to ROSC, chronic hypertension was the only independent predictor of impaired CVR. The primary outcome variable, mean TOX, was higher in patients with poor functional outcome when analyzed with mixed linear analysis, p-value 0.004. We also analyzed opt-TOX, opt-MAP, upper and lower MAP bounds and MAP range for maintained CVR in patients for 3 time periods. Patients with poor neurological function had a decreased upper MAP bound for maintained CVR compared to patients with good outcome in all time intervals. Also, the MAP range of maintained CVR was narrower in patients with poor outcomes. We also analyzed the concentrations of biomarkers of brain injury, NSC, S100P, and NFL 48 hours after cardiac arrest. The NFL concentration was higher in patients with impaired CVR, 43 micrograms per liter versus 20 micrograms per liter. A mixed linear model of NFL levels over time in patients with maintained or impaired CVR showed a statistically significant difference. No significant differences in the median serum concentrations of NSC or S100P were found. We conclude that impaired CVR was common after cardiac arrest and occurred especially in patients with chronic hypertension. The TOX was higher in patients with poor neurological outcome. A decreased MAP bound and a narrower MAP range for maintained CVR was associated with poor neurological outcomes. Impaired CVR was associated with higher levels of NFL, a novel marker of axonal brain injury. Last, I would like to thank all my co-authors. In addition, I would like to thank you for your attention.
Thank you very much for this presentation. Hello. So you are here. We can ask questions. Finally, you have 3 messages in your study. The first one is that there is an impaired autoregulation. Second, in cardiac arrest and after cardiac arrest. Second, it is more frequent in patients with previous chronic hypertension. And also, you can have an idea of this by a biological marker, right? This is your messages?
Yes.
Yes. But can you develop about the use of NIRS to assess this autoregulation? Can you develop about this? Is it a valid method?
Well, of course, it has its limitations. We all know that it measures only a very small area of deeper brain vessels. It can also be confounded by scalp vessels, so it might not be pure. On the other hand, it has been widely used, for example, during cardiac surgery.
Yes, Stefan. Yeah, yes, it's true that it is used by cardiac surgery, but if it is used normally, it's not a pure value which is used, but the change over time. But in your study, you use precise time points and use the measurements there. So I see. So how can you conclude that this is then an appropriate measurement? Because in my opinion, in my experience, a value and not the change is not really reliable in NIRS.
Yeah, that's true. It is one measure we can use. I think it is still very important. And
I have a last question. I have a last question. Blood flow depends on the upstream pressure, which is more or less reflected by the mean arterial pressure, and also depends on the downstream pressure, which is sometimes difficult to assess because it could be the CVP sometimes, but in some conditions of brain injury or something like this could be the intracranial pressure. Did you try to assess this or not?
No, we didn't have any ICP measurement on anything like that in out of hospital cardiac arrest patients. Those are not routinely used. Yeah.
Okay, thank you very much for your presentation. Thank you very much again.
Thank you. And now we're coming to our next presentation, using proenkephalin as novel biomarker to estimate glomerular filtration rate by Remy Benders from Nijmegen. Welcome, and we're looking forward to the presentation.
Hello, I am Remy Benders, physician and PhD candidate in the Radboud UMC, the Netherlands. Today I will speak about our project to develop a new equation to better predict GFR using proenkephalin or PENK. I have received a travel reimbursement. As creatinine is a late and insensitive marker of changes in GFR, new developments to determine GFR are necessary. We developed an equation using a cohort of 1,354 patients with gold standard GFR measurements from stable to ICU patients. The best variables were selected and an optimal model to estimate GFR was created in a data-driven fashion. In the cohort, 57% was male, the median GFR was 61, and almost 200 patients had a non-steady state kidney function on the ICU. To develop the equation, the relation as shown here between PENK and GFR was strengthened by adding covariates. On the right, the root mean square error is depicted of the model when adding more covariates, starting with PENK. After adding creatinine and age, no further improvement was seen, especially not with sex and race. The optimal model included logarithmic PENK, creatinine, and age. The PENK-CR equation was built. Now the performance of the equation. Here is a Bland-Altman plot showing the difference of the estimated and the true GFR over the range of low to high GFRs in the validation cohort. There is no bias of relevance. There is some dispersion, but let's compare this to the commonly used CKD API and MDRD equations. We see that using the PENK-CR equation, bias is less and standard deviation is narrower. Another way to test the performance of estimations is accuracy, the proportion of estimations that is within a 30% range of the true GFR. The accuracy is better compared to conventional equations. Also the case in patients on the ICU, the accuracy is better compared to conventional equations. To conclude, we developed an equation to estimate GFR using PANC, creatinine, and age, which improves accuracy, reduces bias, and reduces standard error. These results warrant a validation in an external cohort. I want to thank the investigators of the Mayo Clinic, Svingotech, and my colleagues in the Radboud UMC that contributed to this project. Thank you all for listening. I am happy to answer questions in the Q&A.
Thank you, Remy. 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 Did I get it right? Population you studied was intensive care patients only, or was it a general population?
It was a general population, including patients on the ICU, including patients with chronic kidney disease, and including patients with healthy patients that will donate a kidney or another organ.
Okay. In your introduction, you criticized the creatinine, with its shortcomings, but at the end, your equation again uses creatinine. So my critical question would be, why would a clinician use an additional marker now to creatinine, although knowing the shortcomings, which would be additional costs, and would there really a clinical benefit? Because you showed really nice the differences between the various methods, but are they really clinically relevant?
Yes, I understand that it seems strange, but at first the rationale is that creatinine has limitations, especially in patients that are admitted to hospitals for longer periods of time. For example, on the ICU. So that was the rationale of starting this project. However, we selected from all covariates that are known in our cohort using a data-driven way, which covariates should be included in the project, in the equation. And it appeared that creatinine still had additional value. So even though it has no limitations, I will not say that creatinine should not be used at all. So in conclusion, using the data-driven way, we saw that proencaphalin and creatinine combined has better results.
I understand. And then, so now you have to convince me, why would I then, add, creatinine is measured every day on the ICU typically, why would I add now another biomarker and additional costs? What would be my benefit then?
I think that the benefits will be in patients that are in a non-steady state situation, patients, for example, on the ICU, where we know that using creatinine, we are experiencing a lag time between changes in GFR and in the actual measurements of creatinine. So if you have a patient that is post-operative or in a non-steady state situation, critically ill, then it will have a benefit to know if what the actual kidney function is. For example, to dose clinically extruded drugs. So the benefit will be not in every patient, that I will agree with, but most importantly for patients that are critically ill or during surgery or surgery.
So I assume that you're going to do these studies and show us this clinical benefit, and then I will really believe you. Thank you very much.
I will happily do these studies.
Thank you.
Thank you too.
So we move on to the next presentation by Dr. Premraj from Brisbane, but it is an international study about stroke in ECMO patients with COVID-19. So we go back to COVID-19. An analysis of the COVID-19 Critical Care Consortium International Multi-Center Observational Study. So many authors and many patients. So Dr. Premraj, we are listening to your presentation.
Good evening, everyone. Thank you for the opportunity to present the abstract Stroke in ECMO patients with COVID-19. Today I'm presenting on behalf of the neurological sub-study of the COVID-19 Critical Care Consortium and the authors listed below. There are no relevant disclosures for this presentation. Neurological complications of COVID-19 are associated with increased morbidity and mortality, especially in the critically ill. Due to their complexity and coagulation status, cerebrovascular complications are of special concern in patients receiving ECMO therapy. As many COVID-19 patients admitted to the intensive care unit require ECMO, it is pertinent to understand the prevalence, risk factors, and outcomes of ECMO-associated strokes in COVID-19. The CCCC is an international prospective observational database that enrolls adults requiring ICU admission for COVID-19. We considered patients enrolled from January 1st through to December 21st of 2020. Primarily, we looked at the prevalence of stroke occurring as a complication of COVID-19 in patients that required ECMO. We also looked at risk factors for stroke in COVID-19 ECMO patients, as well as their outcomes such as death, discharge, and continued hospitalization. Moving to the results of the study, 284 patients out of the 2,715 required ECMO support. The majority of these patients required veno-venous ECMO. These rates are similar to those reported early on in the pandemic from Wuhan, China. Overall stroke prevalence in ECMO patients was 7.7%. Cho et al. Report 1.4% stroke prevalence in non-ECMO patients. Importantly, literature reports that there is a higher frequency of stroke in COVID-19 patients compared to non-COVID-19 patients. Patient characteristics included 70% of ECMO patients were male, the mean age was lower in the ECMO cohort, and the distribution of comorbidities and ethnicities was similar between ECMO and non-ECMO patients. ECMO patients were notably sicker with higher SOFA and Apache scores. We can see the breakdown of stroke types in ECMO and non-ECMO patients in Table 1. Cannulation. Cannulation site was not associated with stroke. Neither was the use of double versus single lumen cannulas. This replicates other findings in veno-venous ECMO studies. Acute change in partial pressure of carbon dioxide or oxygen was not associated with stroke. Notably, in non-COVID-19 patients, early change in PCO2 is associated with neurological complications. This suggests COVID-19 stroke may have a different etiology. Anticoagulation use was more common among the ECMO cohort than among the non-ECMO cohort. Unfractionated heparin was most common in ECMO patients. We also ran a multivariate survival model, which found cumulative probabilities for hemorrhagic stroke and ischemic stroke at 90 days was higher in ECMO patients compared to non-ECMO patients. ECMO use increased instantaneous hazard and cumulative hazard of death. It is important to note that in this study, 7.7% of patients received ECMO developed stroke. As patients who received ECMO treatment had significantly higher risk of hemorrhagic stroke, over 10 times that of non-ECMO patients, systematic and protocolized neurological monitoring is warranted.
Thank you very much for this nice presentation. I noticed that you included patients from the 1st January of 2020. So did you include patients from China? Because in my opinion, in my memory, there are not so many patients outside of China on the 1st January 2020.
Yeah, so I think we did not have a center in China, and the time frame is simply indicating the time at which we started collecting data for the actual COVID patients. I guess an important note here is that the patients are either clinically diagnosed with COVID-19 or SARS-CoV-2 positive. So it is not that we are looking at just non-COVID patients.
Yes, but for the COVID-19 patients, you include them after the 1st January, maybe February or March, something like this. Okay, I was a little bit confused. About the anticoagulants, you said that, of course, ECMO patients receive more anticoagulants than the other ones. This is totally understandable, of course, but regarding the complications, regarding the stroke, hemorrhagic stroke, did you notice high dose of anticoagulants or too large dose of anticoagulants compared to non-stroke or compared to ischemic stroke?
Yeah, so although I can't be sure of the exact specifics, there are two points here. Firstly, the different types of anticoagulation used in ECMO versus non-ECMO patients. So as I presented, unfractionated heparin is much more frequent in ECMO patients, and obviously non-ECMO patients low molecular weight heparin. But in terms of dosage, I believe we were unable to make this distinction between stuff like prophylactic and therapeutic doses of anticoagulation. And so that was not included in the study. However, that is an important consideration that we'll be looking into, especially with future studies evaluating ECMO and COVID-19.
And in terms of mortality, maybe I missed something, but 7% finally stroke. It's huge, but not so much finally, because these patients are very severe by definition. What was the mortality of stroke patients and non-stroke patients with ECMO?
Hello?
Could you hear the question?
Yes. Okay. Yes, regarding mortality. So we can see here, again, numbers not quite sure, but we can see in the last slide of the presentation that we can see, the probability of death. And so what I will say is that when patients were on ECMO, cumulative probability of death was significantly higher as compared to probability of death for patients that were not in ECMO. But when patients were moved to the ICU, the probability of death is actually quite similar to the patients who were put on ECMO. So mortality was 34% for patients on ECMO, and I'm not sure the number for patients not on ECMO.
Yeah, but I think this is an important question. So the question was, people on ECMO with and without stroke, is there a difference in mortality? And also for your cumulative mortality rates you showed, is it adjusted for severity because the patients on ECMO are more severe?
Yeah. So the first thing I'll say is that hemorrhagic stroke was significantly more associated with death, and so the mortality rate for patients with stroke was obviously higher. Again, the figure I don't have, but in terms of the response to adjustment, I don't think there was an adjustment made in terms of, and I think that's also why we didn't present the raw number for the mortality. But if you look at the cumulative probability graph, we did, the instantaneous probability gives better indication of severity and mortality associated with that.
Okay, thank you very much. And we are going on with our next presentation. Is a simple bedside mobility score a useful predictor of long-term outcome for patients admitted to critical care with COVID-19 infection? From David McWilliams, Coventry, United Kingdom. Looking forward to your presentation.
Hello, my name is David McWilliams, and I'm going to present my project looking at whether a simple bedside mobility score is a useful predictor of long-term outcome for patients admitted to ICU with COVID-19. So we know that patients with severe COVID-19 infection often require prolonged periods of mechanical ventilation and associated prolonged stays in the intensive care unit. And this is associated with a high incidence of ICU-acquired weakness and significant ongoing rehabilitation needs, both within the hospital and following hospital discharge. But due to the novel nature of the virus, there's been an urgent need to identify those patients who are most at risk and would benefit from targeted rehabilitation services. I think we know there's so many of these patients coming through. Any opportunity to stratify people early in terms of who we can direct the available resource to is going to be a benefit. The Manchester Mobility Score that we use in our trust is a simple bedside tool that we use to assess mobility level and rehabilitation progress within critical care. So this project really aimed to look at how useful the mobility score might be in predicting outcomes from the point of patients being discharged from ICU. Could it tell us what would happen to them in the longer term? So it's a prospective observational cohort study incorporating two large UK-based university hospitals. And we included all patients with a confirmed diagnosis of COVID-19 surviving to critical care discharge between the 1st of March 2020 and the 31st of March 2021. Mobility level was determined by the highest Manchester Mobility Score achieved before step down to the ward, so by the point of intensive care discharge. Our primary outcome being post-ICU length of stay and discharge location, categorised according to home with rehabilitation or for inpatient rehabilitation. 413 patients were included, They had an average of 21 days in the intensive care unit and 81% of them were mechanically ventilated. And you can see in terms of rehabilitation status, it took on average 2 weeks, so it's 14 days before patients first mobilised, and the median MMS score was a 4 at ICU discharge. But with the MMS actually was significantly associated with length of stay, following a near linear relationship. And certainly patients who are able to achieve an MMS score of 4 or more, that's the ability to stand within critical care, were less likely to be discharged home with any rehabilitation needs and much less likely to have inpatient rehabilitation needs. So much more likely to go home independently. So the MMS showed excellent predictive value with higher scores associated with reduced ICU length of stay. The ability to stand before ward step down was associated with an increased likelihood of being discharged home. And these results could help us to inform decision making for supportive rehabilitation. So we know that if somebody leaves intensive care unable to stand, headbound, hoisting, sitting on the edge of the bed, for example, that they're going to have more significant ongoing rehabilitation needs in the ward, and they're much more likely to need rehabilitation following hospital discharge. And that could help to inform practice.
Thank you, David. My first question to you, David, is this is an univariate association you show us, right? So you have not adjusted, for example, for severity of disease. So wouldn't that be an important and necessary confounder?
Yeah, I think some of our previous work, we've had a look at various different factors which could have affected rehabilitation needs and ongoing length of stay. And I think we found that other than increased BMI delaying rehabilitation and those with comorbidities or older patients being much more likely to need ongoing rehabilitation needs, once patients got to about 2 weeks, the illness severity of original admission didn't seem to be impacting on outcomes. But we're obviously doing a more in-depth analysis of this data and tying in with some new interventions that we've provided, which will hopefully provide a bit more of a picture on this.
My second question would be, since we have always the problem in rehabilitation studies that we have so much different scores, why would I use the MMS compared, for example, to the Bartle score, which is much older and I would say more typically used? So why should I use yours?
Okay, I think I would put a disclaimer and say there are a number of mobility scores on the market. I think the importance for me is to actually have something so we are measuring rehabilitation. The MMS is a very simple score. It gives the patient one number. It's quick to fill in, which means compliance within the unit is a lot better. And certainly we've used that quite significantly to track time to first mobilise, highest level achieved. And as I say, that figure of 4 really does seem to be quite important. So we have a specific post-critical care follow-up team, and we now know who to target, which patients are going to be most at need and most at high risk as they leave the critical care unit. But there are other scores on the market.
Perhaps you can show in your study that you're better than the, for example, Bartle score. I think that would be really interesting and also a good thing to show, to be honest. And you also actually started to answer my next question, the clinical implication. So can you elaborate a little bit more? We have a little bit of time left. So you said you have you tailor your therapy after ICU based on this MMS. This I find really interesting. Can you tell me a little bit more?
Yeah, so we know we have a high volume of patients leaving critical care with a prolonged length of stay, particularly during the COVID pandemic, and we have a small rehabilitation team that can provide an ongoing service to support the wards. What we do now is target those patients who are struggling to stand or less, and then we will provide 2 weeks of ongoing outreach therapy to support the ward staff. We know that once these patients go to the ward as complex rehabilitation cases, they're not a new admission, they're not going home, they're not an unstable respiratory patient, so they're the lowest priority for the ward staff. So what we're able to do is provide a much more consistent rehabilitation service for that first 2 weeks of step down, which we believe will improve outcomes and shorten hospital stay, but ultimately get people home more independent. But we're looking at that at the moment.
Yeah, congratulations. I really think this is a very good process, and I can only congratulate you to start it. I'm really looking forward to the data from that as well. So thank you very much, and we are going to our next one.
Okay, thank you. So the next one is about the long-term effects of the COVID-19 pandemic on burnout symptoms in ICU professionals. Results from a 9-month follow-up longitudinal cohort study by a group of from Netherlands, and Dr. Kok is a presenter of this study.
My name is Nick Kok. I am a PhD student in clinical ethics at the Radboud University Medical Center, Department of Intensive Care in Nijmegen, the Netherlands. Before and during the COVID-19 pandemic, we have surveyed ICU professionals about burnout and moral distress in 2 hospitals in Nijmegen. We started measuring burnout in December 2019, which was 3 months prior to the start of the COVID-19 pandemic in the Netherlands. At that point in time, 23% of ICU professionals showed symptoms of burnout. 6 months later, in June 2020, we measured again. This was 3 months after the onset of the pandemic in the Netherlands, and now 36% of ICU professionals showed symptoms of burnout. In December 2020, this prevalence dropped to 31%. If we look at the graph on the right side of this slide, we see the separate burnout symptoms prevalence of 3 distinct types of ICU professionals. The pink highest graph represents prevalence of burnout symptoms among ICU nurses. The purple graph represents this prevalence among ICU residents. While lastly, the dark blue graph, which is the lowest one, plots the development of burnout prevalence among intensivists. There were significant differences between ICU nurses and residents on the one hand, and intensivists on the other hand. Among intensivists, burnout prevalence was lower than among nurses and residents. Earlier this year, we published an article in Critical Care Medicine, which showed that after adjusting for confounding variables such as personality, culture, and work-home balance, specific moral issues were associated with the odds of developing burnout symptoms. From December 2019 until June 2020, moral distress due to scarcity of time, resources, and personnel increased the odds of developing burnout symptoms. Another moral distressor was having to work with colleagues which were considered unsafe. This may be due to the fact that the ICU had to call on personnel which was not primarily qualified to work on an ICU. However, our latest measurement of December 2020 shows that different moral issues are associated with burnout symptoms during different phases of the pandemic. The experience of unsafe colleagues now is no longer a significant moral distressor, while scarcity, continuing treatment of patients without a prospect, and lack of continuity of caregivers significantly increase the odds of burnout symptoms. Because burnout symptoms prevalence remains at a higher level compared to what it was prior to the pandemic, ICU departments should constantly and keenly monitor the potential moral distressors and, if possible, act on them. Constant monitoring will help ICU leaders to prevent moral distress from becoming endemic and to mitigate the more harmful consequences of moral distress, such as development of burnout, in a timely manner. Thank you for your attention.
Thank you very much for this presentation. I have some questions. First, why did you perform a survey in December 19 before the COVID? You have it was for another purpose, I guess.
That's true. We're conducting a trial on our ICU into the effect of moral case deliberation on burnout. So it was a happenstance that we had this data, which is really a coincidence. And then COVID struck, and well, our idea was to follow up on our measurements. So that's the reason.
Okay. Another question, maybe I missed some points. Did you interview or the respondents of this survey were always the same people, or they changed? Because you have 250, 230. Did you interview the same persons or different persons?
So we conducted the survey on the same ICU, and it's an open cohort actually. So it's possible that different people on different time points filled in the questionnaire. But we know, at least we can track which people filled in the questionnaire at multiple points in time. So there is a large amount. There's a large amount of respondents who responded to each of the surveys, but to some surveys there are different respondents. Yeah.
Because I noticed that the intensivist had less symptoms compared to the residents, for example. And maybe you have not the same residents after 6 months or after 9 months compared to the beginning of the study, because the residents rotate and the intensivists rotate less than the residents. This is why I asked the question. So maybe you have less symptoms after 9 months because you are maybe more intensivists and less residents, or they are not the same residents. I don't know.
No, that's a valid point. The residents, they regularly shift, and the intensivists are a relatively stable group on our ICU. So that's a valid point. Yes.
Yes, Stefan.
Yeah, so you could argue that the residents who were there during the pandemic, of course, had a higher risk of this, while the others are less if they're not the same. But we have also a question from the audience, and I have a similar one. So what are the reasons, do you think, that the intensivists in the non-pandemic time have such a low frequency while the others are much higher? So do you have any reasons for that? Or, and this is the question from the audience, are doctors less accurate at self-reporting?
That's a good question. It would be speculation as to what the reason for this would be. But one might think that, which is a thing which is often said in the literature, is that residents and ICU nurses have more intensive contacts with patients, while intensivists, they see a lot of patients throughout the day. So that might be one of the explanations, but it's speculation. And another point might be that intensivists have a lot of experience, and from their experience, they have built better coping mechanisms, for instance.
But I think this is important. If you study this, I think it's an important one because it's so much less, so you have to find out if there is something you can then transfer to the other ones to also decrease it.
Yeah, thank you.
Okay, thank you very much. We have to close this session, which was very nice. Thank you, Stefan, for this co-moderation, and good Congress, good end of Congress today.
Goodbye. As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. So good morning, good afternoon, hello, wherever you are. Our last breaking news with the President, myself, Maurizio Cecconi, and Elia Zule, President-elect of the Society.
Good morning, everyone. Very happy to be with you.
How are you, Eli? Third day?
Wonderful. I think that we have two very busy and interesting days, a lot of shared session, a lot of information, a lot of new information showed at the conference. At the same time, we have them released in our journals or in other journals. And the other thing is that even if we are not in a face-to-face meeting like we will have next year, we have had a lot of delegates, a lot of attendance, and a lot of feedback. So that was a very, very good surprise.
Yeah, I think the latest figures were more than 6,000 delegates. And then I remind everyone that our sessions on research papers and everything that is streamed from Channel 1 on the studio is actually being sent out on the media, on Facebook, on YouTube. So that actually we are connecting with more people. So no, it's really great.
Good information this time.
It is.
I like also how diverse were the topics that were addressed. Of course, we have acute respiratory failure, septic shock, acute kidney injury, but also many other things about communication skills, about how the COVID-19 has actually the impact of COVID-19 on our teams and on the ICU organization, on the number of ICU beds. I know that you're a fan of what is an ICU bed. Maybe it's not a furniture, it's not something we can buy in a store.
I often used to say that, and I still think that a ventilator is not an ICU bed. An ICU bed is about the ICU team, first of all. And I think there has been so much confusion during the pandemic on that. It seems like media channels, sometimes governments, we have to say, they were presenting data. We're opening 500 extra ICU beds because they bought 500 extra ventilators. And we know that it's very difficult to open 2 extra ICU beds. You need nurses, doctors, physiotherapists, all sorts of professionals for the team, and that has been a major challenge. I think that confusion there has not helped also the population in understanding what is the situation really in hospitals and in ICU when there is a surge, and why it is so important really to get the vaccination, to try to do everything, not to get so many COVID cases.
I really agree. I think that it has a name that is infodemia. Infodemia is when you receive information that seems very easy to understand, but provides fake information. And this is typical. Just for you to know, if your patient-to-nurse ratio is 1:3, for 1 ICU bed or for 1 to 2 ICU beds, you need 6 nurses because you need the day and the night shift, you need the team and the other team over the weekend. So I think that people also need to have more information, maybe at school, and maybe we should know more about how an ICU and how healthcare is delivered maybe very early in life.
And there were some very funny statistics, and they still are sometimes. When I read about 10% of ICU beds are full, those maybe are the COVID patients occupying the 10% of ICU beds, but we normally know that even before COVID, our ICUs in winter especially, they were completely full. So it means that teams really have been stretched to very high levels.
And along this line, unfortunately, we are not yet in the time where we can measure the impact of COVID-19 on non-COVID-19 patients. We did not only delay surgery, but we also delayed medical management of plenty of chronic disease.
Absolutely, that's been the real problem. The impact of COVID in our ICUs and hospitals has not been just on the COVID patients, but on many other things that we had to stop or delay because of that. So the message that we want to give really is to the outside world is really vaccinate, and vaccination is really the most important tool that we have now to control the pandemic. If you are privileged to be in an area where you can get access to vaccinations, I heard some news yesterday, in most countries in the world, less than 10% of the population received a vaccination, which is just not acceptable, I find, and I really think also as scientific societies we need to do more to ask for fair access to vaccines.
Absolutely agree, and this is one of the examples that has been very obvious where the only solution is a global solution. We will not get of it if we are not having a global solution of having everyone, every country with more than 90% people vaccinated. And of course we know that it will take time to organize, but we need to promote that not only as ICU specialists, as healthcare providers, but also as a teaching society.
Yes, absolutely. And it may seem strange that intensivists are talking so much about vaccinations, but we really see the end effect of when actually the pandemic is not controlled, and really global vaccination is key. First of all, it's fair to do so for healthcare workers working there, but also for the population. And also it's the only way out of the pandemic. If we don't vaccinate the whole world, there will be more variants, and then these variants can actually go back to places where it was these, we thought that the virus could be eradicated already.
Of course.
And in these places where we have access to vaccines, I think we have a duty as physicians to fight all the disinformation that has been out there for the last 15 months. Unfortunately, sometimes even with colleagues, passing very confusing information there.
And when we say vaccine, it's very likely that we are going to receive the third shot along with the flu vaccine in the next weeks. So I think that we need to keep it as a very important highlight for all of us.
Yeah.
Maurizio, I have a question. This was the conference where has been released a very important paper that is a common effort with our colleagues and friends from the USA, CCM, that are the surviving sepsis guidelines. Maybe
it's probably the most important quality improvement project on sepsis and septic shock, a long-term collaboration with our friends and partners from America, the Society of Critical Care Medicine indeed. And we have plenty of data that shows that if you adhere to these guidelines, and the guidelines have changed over the years, and that's what you expect when new evidence comes, if you adhere to the guidelines, you have better outcomes in your hospitals. And indeed, it was the first time probably, even the previous guideline was referring to, but the first time that there is a strong recommendation really about putting a protocol, a performance management in place about making sure that you have a way to recognize sepsis, first of all, and to treat sepsis in a very timely fashion.
I liked very much when the paper was released, and we have this session with the two experts leading this manuscript, Laura Evans and Andy Rhodes. When we asked to Laura Evans, what would you put forward, and she said screening sepsis.
Yep.
And I think that we need to increase our awareness about sepsis diagnostic. And this is true for doctors. This is also true for nurses.
And it's true also that we need to increase this awareness in the population, because to make sure that you don't miss the window to recognize sepsis early, we need to teach and to make the population aware of what sepsis is. Unfortunately, I have the feeling that with the pandemic, we've lost a little bit of the work that was done before. COVID-19, in a way, is a form of sepsis when it leads to organ failure. We never talked about this. Media don't talk about sepsis this way, and I think it's very important that even when the pandemic is finished, we don't forget that there will be sepsis from other, viruses or bacteria.
And it's very important and to get in mind that if we are adjusting on many confounders, it's very likely that the outcomes in patients with COVID-19 would be the same than with flu or with other source of pneumonia. It's just the surge and the way we have been flooded by the demand that has made a difference in outcome, at least at the beginning, of course, much less today.
And indeed, we published with the Society of Critical Care Medicine and the Global Sepsis Alliance a paper on intensive care medicine about the legacy of COVID-19, really saying that we need to do more about sepsis in the future. And yesterday in a session, again with SCCM, we were talking, for instance, how intensive care will be in 2050. And we talked a lot about post-ICU syndromes, how we could prevent it, how we could treat it, how we can work on it. And again, we talk about long COVID a lot, but long COVID is a post-ICU syndrome for patients that came to the ICU, and that was existing before COVID.
Of course, it has been described since the end of the 80s. There's a post-ICU syndrome in patients that is not only including symptoms, physical symptoms that can be very easily detected with the 6-minute walking test, and there are all the rehab programs, and I think over the last 2 decades, wonderful advances have been made. But there is also emotional, social, psychosocial symptoms that need to be detected, and in a close future we will generalize something that has started, that is the management of those patients, those ICU survivors and their family members, and we know that ESICM has invested a lot on the topic on family members, and I believe that we are together going to increase our knowledge and find ways to again improve long-term outcomes in patients and in family members.
And again, as often when you look at quality of care for patients and for families, it is the right thing to do so, but it's the right thing for societies where we live really to fund these programs as well, because we know that unfortunately, if you don't deal with this properly, that could be problems in returning to work for the patients, but also the family as a burden on that as well.
Mauricio, we discussed a lot on something on which you're a worldwide specialist, is fluid expansion in patients with sepsis, and how we can get from a basic recommendation that we can apply to the global numbers, the big numbers, towards something that is more personalized. So let's take the 30 milliliter per kilo of fluid expansion in patients with shock, and how can we get more to what is a personalized approach?
So, that's always a question that raises so many eyebrows, lots of controversies there as well. I love physiology, I love personalized physiology, but at the same time I have to tell you that if you look at the evidence out there, for the first 30 milliliters per kilogram that you give to patients when they come to the emergency department, the reality, the signal of harm, which often is referred to, is not really there. It is usually in day 2, 3, 4, that's when we start to accumulate very positive fluid balances. Of course, it does not mean that you cannot do more sophisticated things if you know how to do them. But I would say the important thing is not to lose time thinking about doing too sophisticated things. Sepsis is a time-dependent pathology. Giving the antibiotics very early when you think that there is an infection there, especially in patients with shock, is incredibly important. And fluids and vasopressors together, they have to be started very early. Now, if you have an echo machine, and we hear these days that everyone should be proficient, or at least know how to use echo basically, then of course you can do better than that. But I'm not so scared about starting with these 30 milliliters per kilo in the very first phase of sepsis.
You said echo? I heard that the ESICM has prepared something on echography?
Well, we are doing a lot of activities on echocardiography. With one of our past presidents, Daniel De Backer, we set up also European diploma on echocardiography in intensive care. This is actually now a standard committee within our education, and Philippe Vignon now is taking care of that. And also it's plenty of sessions with the cardiovascular dynamic sections. We have a lot of work on echo, and very soon today there will also be something not just on echocardiography, echocardiography, but on ultrasound in general, we're very happy to release a consensus that was led by Chiara Robba and Antoine Viaro-Baron, with a lot of experts from the European Society of Intensive Care. It will soon be published in our journal in intensive care medicine, so stay tuned, because in just a little bit of time from now, we will stream that.
I agree, and I'm very proud that these worldwide experts and all the group has made, who is really prolific and have an incredible track record of publication, has made the effort for increasing the ESICM brand, so we can only be proud.
We can be proud, but also it's not just about being proud, it's about providing bedside clinicians with practical tools. Guidelines are so important in this sense, and we have a new guideline committee that started to promote and to have new guidelines on the pipeline. And if you as a member of our community think, I think this is really missing at the bedside, I need to have more information about this, send us an email, we will evaluate this and see if it's worth starting a new guideline.
Maurizio, this is the breaking news number 3, and unfortunately tomorrow we will be in our ICUs, in our departments. You will be in Milan, I will be in Paris, but in 22 we will be face-to-face. So what are the plans?
So 2022 is going to be a year where we will restart face-to-face meetings. However, don't worry if you cannot travel for whatever reason. The Society will not stop all the great activities that we've done in the last 12 months. So we will be present on the internet, we will have master classes, we will have ways to be interactive with you from your home or from your hospital. But of course, I'm very excited to suddenly see some of you face-to-face. And the first meeting for us will be in Madrid. It will be an occasion also to celebrate the 40th birthday of our society. So I think it's from the 11th to the 13th of May, if I'm not mistaken. That's the Lives event for the 40th birthday of the society.
And you say something very important, because a webinar is a very good way to transfer knowledge to many. And what I liked in these webinars, of course I miss the face-to-face, and I really hope that we are going to see each other very soon. But in the webinars, you can also put it in a room where there are many people, many residents and fellows. You can discuss, you can raise controversies, and I think that the knowledge transfer is different, and we will not abandon that for the years to come.
No, we will not. We will carry on, and we will provide more and more ways to access, to have a big network, because at the end of the day, as we often say, together we are intensive care.
Thank you very much, and I wish you a very happy third day of this Live 2021, and we see each other very soon.
Bye-bye.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
Well, a very welcome again for this third time that we'll discuss the highlights with the chairs of these sections. And the sections we have not talked to today, we will meet now. And I'm very happy to see my friends from the sections. I see Mette Berger, I see Jordi Mancebo, I see Christian Jung and Anne Feldheiser. So welcome to you all and thank you for being with us. What we are going to do is to discuss a little bit your point of view from the point of view of the section. And what the audience wants to know is what you consider as one of the most important highlights that happened over the last 1 to 2 years, and how this is reflected in the Congress and from your point of view as a chair of the section. And I would like to start with Mette Berger, who is the chair of the section Metabolism, Endocrinology and Nutrition. Good morning, Mette, tell us.
Good morning to all. It's been really great attending this Congress. It's been much, much better than last year. Our session was not very much present actually because it was essentially on VOD. There were no live sessions, so I have to tell a little bit about what has happened and which is reflected in the VODs. Actually, things have changed in metabolism and nutrition of a critically ill patient. And this appeared already in 2019 in the guidelines of ESPEN regarding nutrition of the critical care patient. It's very new. There is a timing issue. We know the patient is not having same needs and problems during the first 48 hours of acute illness or later. And we have to adapt. And many of the trials which have produced controversial results as to energy and proteins have actually enabled us clarifying what happened. There is a period of catabolism where there is a high endogenous energy production, which puts patients at risk of being overfed if you try to full feed them then. And then there is later an increase of requirements and a decrease of this endogenous production, which makes indirect calorimetry a tool to address what is required. Much has also been worked on in our section on micronutrients and electrolytes. So we have been producing systematic reviews on phosphate, on renal, and actually trying to put together bits and pieces that come from all over. And this is reflected by several VODs which show what has changed. So I really encourage you to go and do that. Micronutrients are getting more important, and there are several good papers and presentations on that. I'm trying to present a summary of that in a VOD that I myself produced on good, bad, and ugly things of micronutrients. In the LIVE program, we were present on the obesity case-based fundamentals, and that was a very good and interactive session. There were lots of questions. This way to teach works very well because it gives you an integrative view of the patient, not only section-based. And this is really great progress. Clearly, these sessions are something to promote, to continue. And I'm really grateful to Frankie Duska for having set up this system. It's a very good teaching tool. And if I have in the LIVE program today, there was a very interesting release from ICM, breaking news actually, coming from Australia by Mahesh Ramashan, presenting the trial results of the multicentric testing of plasmolite versus sodium chloride in diabetic ketoacidosis, and showing that by just manipulating the solution, you obtain better blood control of acid base, which is one of the main topics we had addressed in our section. So there are bits and pieces, but we were little present. And as metabolic support of the patient is essential to make other therapies work, I do encourage people after the Congress also to go and look at those on indirect calorimetry, on acid base, on non-invasive ventilation patient management, and on micronutrients, of course. So there are bits and pieces to all of us, but you have to look for it.
If I may also, Mette, because we had, of course, the pandemics this year of COVID, and that is where obesitas and nutrition and COVID comes together. Are there specific aspects in the COVID patients with respect to your section's fields that were present in the COVID patients? Can you say something about that?
Well, you know well, all of you, that obesity is a risk factor for COVID. And these patients are difficult to manage as to their requirements. But as to the rest, they work well. And the papers we've had and who have been presented here show that these patients should be actually addressed the same way. There are not much more trouble with the intestine. It's working pretty well. Our own dose data show that. But they are often depleted. And this is the paradox of obesity. They look plethoric, but they often are sarcopenic. And this can be addressed by bioimpedance. And they often have micronutrient deficiencies, to come back to my favorite topic. So these patients need to be addressed in a structured, simple way. We realized that you could just intubate them and start feeding enterally, and that the needs were, as for the others, to be addressed in a reasonable way during the first week, and then increased.
Okay, so what you say is there are no special aspects in these patients with COVID compared to the patients you were used to, that we were used to in the intensive care with obesity?
Rather easier to manage as to enteral feeding, but they are the long-term patients. They are persistent, critically ill, most of them. So you have to go in early on to prevent trouble. And we will have to look at long-term issues in these patients as for the others.
Yeah. Okay, well, thank you very much, Mette, for this expose. We will now turn to Spain, to Jordi Mancebo. Well, Jordi, you're the chair of the acute respiratory failure, so I suppose that the past 18 months, 2 years was really heaven for research and experience with a lot of mechanical ventilation in all the patients we've had. Can you indicate a little bit what is for you the highlights, what are the new developments that we have learned over the past 1-2 years?
Sure. Thank you very much, Armand. Good morning or good afternoon, everybody. It's a great pleasure to share this time with you today and to address the question raised by Armand. In the last 2 years, we have been clearly dominated by the pandemic of COVID-19. And last year, we were obviously overwhelmed by a new disease with plenty of unknowns. And we showed a great, altogether, the community showed altogether a great capability to adapt. And I think that for instance, the management of, to go to your point, the management of patients with COVID-19, mainly pneumonia and IRDS, they benefited from all the previous knowledge that we had acquired in the previous years, in the sense that, or mainly,
Well, there seems to be a little bit of a problem with the connection with Spain. So what Jordi is telling us that we were well prepared, in fact, with all the knowledge that we obtained.
Protecting the lungs.
You were interrupted a little bit, Jordi.
The bad connection?
Now it's I hear you.
All right. So I said that now in this current year, we have moved forward, and we try to better individualize the treatment that we deliver to our patients, in the sense not only of trying to protect the lungs, but also to protect the respiratory muscles, and also to try to individualize treatments according to different phenotypes. For instance, you can have phenotypes according to morphology or anatomy, and this can be analyzed with CT scan, maybe with electric impedance tomography. You can phenotype your patients according to recruitment, and we have now tools at the bedside that allow to better estimate recruitment, and thus treat with the patients who are more likely to recruit, and to use low PIB levels in patients who do not have recruitable lungs. And also, for sure, in the next future, I guess that we will be able to phenotype our patients, for instance, in terms of certain inflammatory markers, which has been showed that this is crucial, at least for to understand the response to a certain number of treatments, and possibly also useful to individualize pharmacological treatment. And last but not least, in the last year, we have seen, say, a renaissance of non-invasive support, and this is the awake proning, in patients with COVID-19, and also the new technique, the known techniques of non-invasive respiratory support, such as the CPAP, such as the high-flow nasal cannula, non-invasive ventilation delivered with the helmet. And here I think that we are now seeing extremely good papers, and some that will appear soon, regarding the precise place where to indicate this non-invasive respiratory support techniques.
Well, thank you, Yuri. Well, you mentioned of the techniques that we can use in COVID, CT scan and impedance measurements. You did not measure ultrasonography, echo of the lungs. In fact, we use it in our unit a lot, and we published also about the use of echo by Peter Tuinman, of the use of echo in patients with COVID. Can you comment on that?
Sure. I think that echography, not only echocardiography, but lung echography and echography of the diaphragm are extremely important to understand what's going on in these very sick lungs. And the great advantage is that it's relatively easy to do. The technique is available at the bedside, and you can do very frequent measurements in the way that allow you to titrate the treatment you deliver to your patients. And of course, you avoid invasiveness and transportation of the patients to the CT scan room, which is always cumbersome and maybe risky for a number of patients. So I think that this is a great point. I think that ultrasounds are here to stay. And again, we will see, in brackets, a revolution of this non-invasive technique, not only in the area of respiratory, but also in other areas of the body.
Okay, well, thank you very much, Jordi, for these highlights that you gave to us. And we will now switch to the section of health services, research and outcome, and we go to Germany, to Christian Jung. Welcome, Christian. Very nice to see you. Can you give us a point of view of your perspective?
Yes, glad to be here. Thank you, Armand, and good morning, everybody. So the HSRO section, Health Services Research and Outcome, had one focus on very old intensive care patients in the recent years, and a lot of centers and people of the section contributed to it, and it enabled us to include more than 10,000 patients in the VIP project, which consists of the VIP1, the VIP2, and the co-VIP study. And within the section, we had a vivid interaction, and this has grown over the last 2 years, which you might find surprising. So we were not able to meet physically, but had very frequent Zoom meetings, and I can emphasize that everybody is invited to join these sessions. So one focus was to better describe the role of frailty in these patients, and I would like to highlight the talk by Susanna Lever from London yesterday that you can review in the program. And in summary, frailty assessment is helpful, and the cooperation with the geriatrician can improve treatment quality in these patients. So, and this has also been emphasized by the pandemic, the importance of older patients, looking at the high mortality rates. And for example, in the co-VIP study, it was able to show that only 45% of the patients were alive after 90 days in this multi-center study. So Armand, if you would like to know, and everybody, how can you find this in this year's program? And I'm really happy that the Congress covers these topics a lot. For example, if you type the term frailty in the search mask in the poster session, you will find more than 30 very interesting posters. And I would like to pick one by Dr. Pollock from Poland, who analyzed the timing of tracheostomy in older and partly frail patients, showing that early tracheostomy was not associated with good outcomes as we practiced in the beginning of the pandemic. And for example, another interesting poster about frailty biomarkers, it's from Portugal. Type in biomarkers and frailty. It's really a tricky but interesting and helpful question. So they focused on standard laboratory parameters. It's not completely surprising, but it's important to know that hemoglobin and albumin are really useful biomarkers.
Well, thank you, Christian. So what would interest, I think, the audience is what does this mean, these findings that you do specifically for the elderly patient, and what are the consequences in practice and for the treatment of these elderly patients, especially when we also look at the longer outcome. So that means the outcome after the ICU admission, and let's say 1 or 2 years thereafter. Can you say something about that?
I totally agree. And I mean, this is, as you know, as an experienced intensivist, this is a multidimensional thing. But I would like to refer to 2 aspects. And while I do also recommendations for the program, first is about if you, for example, have a planned surgery, if you have a planned ICU admission after intervention, you need to look at these things at the frailty assessment and on the geriatric assessment before you do the intervention to plan a better care during the ICU stay and also thereafter. And I would like to highlight the video on demand talk by Claudia Spies, who exactly answers you how to optimally do that. That is one aspect. The other one in the acute setting is, of course, that if you do such a global geriatric assessment, you need to do that during the ICU stay, but for example, especially in the beginning, to plan special care, how to support the patient's care on the ICU stay, but also thereafter to really plan interactively and with other disciplines, for example, with the geriatrician, the care after the ICU stay. These are just 2 dimensions, and we can list a lot more, but maybe this highlights what what you can also find in the program. Please have a look at the video on demand sessions as well.
Christian, this is the European Society, but although we have our field, of course, in the total of the world. But can you tell us also a little bit about the differences in approaches? And I refer now mainly to the rich countries, or we would focus, for instance, only on Europe. Are there big differences in the attitude towards admission of elderly patients in the ICU within Europe? Are there differences between different countries, for instance?
Yes, there are really big differences. I mean, not only how to evaluate patients before patients get admitted to the ICU, how treatment limitations are handled. This is, of course, very heterogeneous, and I've seen that also the ethics section is covering this with very interesting talks. For example, we also compared the different healthcare systems in the outcome of treatment of elderly or older patients during the pandemic, and it was good to see that there's no difference regarding the healthcare systems, which is also reflected in the poster session. But of course, there are very big cultural differences. But you're right, this difference differs between countries. But we all know that this also differs between hospitals on the local level. But this is a topic that also our section want to deep more into in the next years.
Okay, thank you, Christian. So we now will switch to Arne Veldhuizer, who is the chair of anesthesia and perioperative medicine. And I think, well, a very, very important section and a very important field, especially after the COVID period, because a lot of people have waited longer for an operation. Their risk has increased for operations, and of course we want to reduce the risk as much as possible. So it makes your fields of interest even more important after this pandemic. Can you tell us a little bit about what you see as most important points from your perspective, Arne?
Dear Armand, thank you very much, and I welcome you all. You're exactly right, and Christian is completely right. I personally think that we have a change of perioperative thinking in the last 2 years. It's nothing new, but the things are more emphasized, that we are more aware of the limited resources of surgical programs, of intensive care capacities. And this pandemic massively highlighted this issue, that we have to be aware of this limited resources. But according to that, always crisis is a chance, and perhaps we have to find out the issues, how to tackle this crisis and how to advance with improving care. And one issue might be that we do not just do the operation, that we reconsider, is this operation necessary? Is the timing right? Can we do something prior to surgery? Is the patient adequately involved? We had a case-based fundamental session on Monday. It was great. We had a huge discussion about preoperative assessment and pre-op shared decision-making. And these things are not new, but they are exactly emphasized by the pandemic, that they are very, very, very important. And we have to assess these patients. And this is something we have to know exactly how to do it. And another point is rising is that, I personally think that anesthesiology and intensive care medicine recognized more of their responsibility within the holistic treatment pathways. And I always think of pathways, then from the point on the patient is scheduled for surgery up to the, let's say, follow-up months later. This is the whole pathway where anesthesiology and intensive care has to be integrated. And my personal thinking is, some years ago, it was impossible that an intensivist might be a part of a cancer board to evaluate the surgical procedures or the therapies, but perhaps this might be a future. And this is opened up by the pandemic. This is opened up in the mind of the responsible stakeholders of perioperative care.
Well, I think there are also hospitals where it was already common. In my hospital and also in the previous hospitals I worked, it was completely common that you were involved in the care of the perioperative patient. But it's good that it spreads and that you highlighted the importance also in the session that you mentioned, where I also saw that a nutritionist explained the importance of preparing a patient before the operation by supplying good nutrition. So is there anything that has changed over the past 2 years? I remember the old stories, the old studies from David Bennett, about that you should give a lot of fluids to the patients before the operation. And has there been any change in this field?
I wouldn't state that there's a very relevant publication to change the fluid management in 2020-21. The last thing is the multi-center study based on ODM that could reduce within eras the complication rates. But even coming back to this crucial issue of perioperative care, if you look at enhanced recovery after surgery programs, they were very with exciting results over the last 2 decades. And they emphasize that we have to focus on all the issues in the perioperative care. It starts with the pre-op feeding, with the carbohydrate loading, with optimizing the pre-op fluid balance, then do the right volumes at the right time, guided by the right monitoring device in the right patients. And this is something really, really important. And when we come together, this is like a house of cards. Perhaps not every measure is shown by a multi-center RCT and New England Journal, but they all sum up to improve care. And this is shown by the ERAS elements very well. And you need an implementation rate. And one main pillars of care are the handling of the perioperative fluid issue. I personally think that 1 liter of crystallate for perioperative patients is perhaps the most dangerous drug we have. And there are data that with every liter of excess fluid, we increase postoperative complications by 20 to 40%. And this is something, it's a drug, it has to be indicated. And if there are problems with the indications, we need a certain approach, a goal-directed approach, and the goal-directed approach is part of a monitoring device or a measurement of physiological advanced parameter. And this is something we have to rely on to improve care. We have to do all the small things right to avoid long-term pathologies and long-term stays in our ICU. That's my opinion.
Well, thank you very much. I couldn't agree more. In intensive care, you should do everything right, isn't it? So we have time for a very short message, a 10-second, 20-second message, what you could give to the audience. Mette, if I may start with you, what message would you give in a very short time?
Very short. Nutrition has become, with metabolism, something measurable. We have bioimpedance, phase angle, calorie, ultrasound. This should attract more attention and make it hard science.
Thank you. Jordi.
Do not miss the upcoming session, Roundtable, now in 15 minutes on ventilation strategies on COVID-19. I'm very much looking forward to it. And of course, I would strongly recommend that people attend the groundbreaking grand finale and the hot topics grand finale before the Congress closes. And after this, look carefully at all the videos on demand that there you'll find plenty of very, very good stuff.
Thank you. And then Christian, very short.
Take care of yourself and take care of your colleagues.
That is a good one. Arne, if I may ask you.
Please have a look at the round-the-table discussion we had yesterday with masterminds of perioperative care, do frailty assessment, and do all the small things perioperatively right to take care of our patients.
Okay, well, I thank you all very much for your contribution and have a nice day and enjoy the rest of the Congress. See you later.
Thank you.
Bye. Take care.
Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
Well, good morning, good afternoon to everybody. Thank you for being with us during this Congress. And we are going to have a fantastic session on ventilation strategies, a roundtable. And I'm very pleased to know that we have 4 world experts to discuss with. And that is Lise Picchio from Switzerland. We have Luigi Camporotta from London, Giacomo Grasselli from Milano, and Leo Heunks from the Netherlands, Amsterdam. Welcome. I do not think that you need further introduction. And we will have almost 45 minutes to discuss a very big field. And I will do that together with my co-chairman, Joseph Kesoshoglu, and I'm very happy to do this together with him. We worked together a lot when he was the president of the European Society and I the chair of the Division of Scientific Affairs. So I think that makes us a good couple to discuss this very important subject. There are a lot of aspects that we will discuss, and if I just may give a very short start, is that what I tell my fellows in the intensive care is that mechanical ventilation is in fact very simple. You just should keep the patient alive and harm as little as possible. Would you agree that it is as simple as that, or is it more complicated? Who will take this challenge?
Well, I might start with a challenge, just saying hello to everyone listening. It's a real honor and pleasure to be here today. I think you might be right. It's just the question is how to do as little harm as possible. That's the complicated part. And I think we will discuss together today a little bit in the next 45 minutes. But I think that is the combination of science and art, and hopefully some of the data will come through in the discussion, and hopefully we can just share some of the experience around the table and with the listeners. So thank you.
Lisa, would you comment on that?
Yes, during the past 18 months, I think that we have probably rediscovered that AIDS is very, very heterogeneous, and that we have things that we can apply to nearly everyone to harm as little as possible, but we also have to consider each patient with his or her own characteristics to try to apply the best ventilation from a more individualized aspect. And I think that this is our goal or aim for the next years, to better characterize each patient.
Giacomo?
Yeah, I completely agree with Liz and Luigi. I would say that whenever you set the ventilator, you have to keep in mind that there is always a difficult balance between the effect you want, which is improving gas exchange, of course, because more or less it's why you start mechanical ventilation, and not harming the lung, so being protective, and sometimes these two goals do not go very well together. And also, you should never also forget the effect on hemodynamics. I see too many people who like playing with PEEP and air pressure and respiratory rate and so on. And sometimes you ask them, okay, what is the value of, let's say, mixed venous saturation, or at least central venous saturation, or so on, and you don't have an answer. many people on invasive ventilation, even very bad COVID-19 patients without any form of, let's say, hemodynamic monitoring. So it's also, it's good to make things simple, but there are many aspects to consider. And of course, that of phenotypic heterogeneity is very important. I agree with this.
Yeah, well, very good for you. Very good that you highlight the fact that we are not ventilating the lungs, but that we are treating a patient with mechanical ventilation, for instance. Leo, can you say something on that?
Yeah, sure. And I think you're completely right. We should harm as little as we can. And I think at the start of the pandemic, I'm not saying we're confused, but we were a little bit hesitant on how to ventilate these patients. We didn't have any randomized clinical trials, which are coming up now. But looking back, and what is always important in the field of mechanical ventilation is understanding respiratory physiology. I mean, perhaps tomorrow or next year we have another virus, we have another bacteria, but we have to go back to provide the best ventilation in understanding the respiratory physiology. And I'm sure we're going into some more detail later on, but in a very compliant lung, it doesn't make sense to provide very high PEEP, I guess. And then, now we start to realize that it doesn't matter whether it is COVID or whether it's an other disease, it's just the understanding of the physiology. So I think that is, from my perspective, that is an important insight.
Well, you raise already a very important point, is what people wonder, I think. Is there a difference in ventilation strategies in patients with COVID-19 compared to, if I may say so, which is also wrong, in fact, other patients? Is it different than in the previous ARDS patients? Are there different strategies necessary?
Armand, can I maybe expand that a little bit? That I would perhaps say, are there any pathophysiologic differences between the ARDS that we have seen so far and ARDS which is caused by COVID-19, which brings us to the different ventilation strategies? And maybe Lisa can say something about it, because you were talking about the heterogeneity with your experience on that.
Yeah, basically, I would say that we should apply the same strategies in COVID-19 and non-COVID-19 patients. At least we should apply low tidal volumes for sure, and low plateau pressure for sure, and also try to have the lower driving pressure as it is possible. But there are some differences between COVID-19, at least some of the COVID-19 patients and the other ones. And one of those differences is that some COVID-19 patients have relatively high dead space and are very sensitive to high PEEP levels with a clear risk of hyperinflation. And as Leo told just before, those patients are mainly, at least in my experience, patients who have a relatively normal compliance. And with those patients, we must be very careful when we titrate PEEP. But this does not mean that we should use very low PEEPs. That means that we should be aware that very high PEEP can lead to overdistension. And at least if we have poor gas exchanges and or lower compliance with higher PEEP, we should get back and reduce PEEP again. And this is, in my opinion, the main difference between COVID-19, at least some of those patients, and other ARDS.
Lisa, since you mention PEEP, you talk about low PEEP, high PEEP. What I try to make understand to others is that the PEEP should just be enough. And enough means, in fact, as low as possible and not too high. Would you agree that the PEEP should just be enough? And then, of course, comes the question, what is enough? But it is another starting point than saying that it should be low or high.
Basically, I agree.
There is a question coming related to this, and Uriel Trachtenberg is asking, we don't really know what ARDS is. It's a syndrome, so talking about pathophysiology is problematic, which is true. Both usual ARDS and COVID-19 ARDS are ARDS, a syndrome, and the heterogeneity exists in both of them because they are the same syndrome. Well, I thought always in my mind that COVID-19 was more a disease rather than a syndrome, which makes it more special than the rest of the ARDSs, but maybe one of you could comment on that.
If maybe...
I don't know, maybe I can start with Giacomo.
I don't know.
Oh. Okay, maybe I can say, I think Thebe is completely right. I mean, COVID-19 is a disease, which that particular disease might be part of the spectrum of the syndrome, like pneumococcal pneumonia. So if we compare the etiologies to maybe two different etiologies that give the syndrome ARDS. So for example, a bacterial pneumonia or a COVID-19 pneumonia. What was very different in COVID-19 pneumonia was two things. One, there was the hypoxemia, which was just out of proportion of the anatomical shunt. So the amount of hypoxemia was more compared to what could be predicted by the degree of consolidation. So if we apply the same rules, for example, for PEEP, in the early stages of COVID-19, where the anatomical shunt is not so elevated, then we take some decisions that might not be appropriate for that particular patient. The other thing was that there are anatomical changes within the pulmonary vasculature, which are several-fold more frequent than other pathologies, for example, H1N1 viral pneumonia. And that does change the type of treatment that we give. So, for example, microthrombosis is 10 times more frequent, new vascularization 3-5 times more frequent. And as a consequence of that, the amount of lung that might be recruitable at the beginning of the disease is much less than it would be for patients with a similar hypoxemia with other etiologies. So I think although I agree that you should consider COVID-19 within the spectrum of ARDS, but essentially patients who have got a similar phenotype, or at least mechanical phenotype as COVID-19, are very infrequent in the mixed population. I mean, in the LungSafe trial, only 12% of patients had a preserved lung volume and the same degree of ARDS phenotype. So I know that Giacomo has done a lot of work on that, but I would think that that particular phenotype that we've seen very prevalent in COVID-19 is certainly quantitatively much less predominant in the general ARDS population.
Any other comments? Because this was quite explanatory, I think, considering the question.
Joseph, if I might just add a little bit. I mean, I remember at some point during the pandemic, when we had in our hospital a lot of these COVID patients, I decided to take from every patient one slide of the CAT scan and put them all into one slide. And what was quite intriguing, that I saw very different patterns. In some of the patients, there was only, and they were all ventilated, invasively ventilated. And some of the patients, they only had some ground glass appearance. Some patients had a combination of ground glass and consolidation. And in other patients, there was very severe consolidation. So I agree with Luigi that there are differences with perhaps the classical ARDS, but despite the fact that it is a specific disease, the phases, how it expresses in the lung, can be very different, again, from just maintaining lung volume with just some ground glass appearance to very severe consolidations. And I think that is the essence that has the impact on the way we should ventilate these patients.
And then actually, I would like to come back with a lot of fear to call the names as L-type and H-type, because it creates a lot of discussions. But there is a certain difference, and we know that we cannot approach both of these types with high compliance, low elastance, and vice versa with the same approach. I mean, even if we are not agreeing with the terminology, I think, in my opinion, we still are faced with basically, I mean, I can't say there are only two types, but basically there are two different things happening there. Do you want to comment on that, Giacomo, maybe?
Yeah. Yes. Well, I think that this takes us back to what Liz was saying anyway, and this applies not only to COVID-19, but I would say to any patients with ARDS. I mean, our goal is to try to understand the pathophysiology of the single patient and then to adjust, to tailor the ventilation setting to that patient. So ideally, in any ARDS patient, you should have, I don't know, for example, for us, a CT scan or some other way to study the potential for lung recruitment. And then when you have an idea of the potential for lung recruitment, then you have respiratory mechanics, and then you have hemodynamic monitoring, then you can understand which is the ideal, the optimal, for example, PEEP level that should be applied. I mean, even in what was called, let's say, classical ARDS, there are still patients, probably a lower proportion, that tend to have high compliance and a degree of hypoxemia, which is out of proportion of the degree of consolidation. In those patients, exactly as in COVID-19, it's probably not rational to use high PEEP levels and or apply, for example, recruitment maneuvers. Then I would say that in COVID-19, there are two things which are still very difficult to understand. The first one is that we don't really know, at least for what I believe, the relationship between what happens before intubation and how we see the patients in the ICU, because you know that we've seen many patients with, let's say, barotrauma, for example, and I don't know if the degree of consolidation, for example, is related on how many days a patient has been managed with non-invasive ventilation before the ICU. That's one point. And the second point is that sometimes, even in patients with compliant lungs, even in patients in whom you would not expect a good effect, you would not apply high level of PEEP, you still see an important effect of increasing levels of PEEP and even prompt positioning on oxygenation. And some of these patients are really severely hypoxemic at the beginning. So sometimes I see, even in my ICU, patients with a, let's say, higher PEEP level than you would apply based on the potential for recruitment and so on, but sometimes they help you to keep, let's say, a viable oxygen saturation. It's the same for prompt positioning. It's probably related to, again, redistribution of ventilation and perfusion, and I agree with Luigi that a major point in this disease, which is more prominent than ARDS, it's still present in ARDS, but in classical ARDS, but it's more prominent in COVID-19, is the vascular side of the disease, which also explain probably the high dead space fraction that Liz was mentioning too. So it's challenging because in some of these patients, you still see an effect that someone would say it's a cosmetic effect on gas exchange. But sometimes, you know, when you are during the night, staying with a patient with 90% of oxygen saturation instead of 80, it's more, I would say, reassuring, even if you know that it's only cosmetic. So it's probably more complex again than what we were used to.
Okay, Armand,
yeah. If I may use what you just said, but I saw Luigi raising his finger, so perhaps he can go first.
Well, I was just going to say that one of the things about you mentioned about the L and H phenotypes, that was meant to be a means of communication, and just to draw the attention that perhaps if we apply strictly some of the rules like 6 mils per kilo or a PEEP to a FiO2 table, there might be some patients who might not respond very well. And that was, at that time, that was intended to be a way of communicating a certain patient characteristics, which you might call phenotypes, or you might call it just a constellation of symptoms and mechanical characteristics. But then afterwards, I mean, you can see some of the papers that come out, even in general ARDS, in mixed etiology ARDS, where the idea was that tidal volume should be scaled for compliance. So the idea of driving pressure. And in fact, reanalysis of all trials of the low tidal volume versus the high tidal volume have clearly shown that one of the important characteristics is the baseline lung elastance. And patients who have low lung elastance, then the tidal volume, it can be a little bit more flexible because the driving pressure remains low. And only when the lung volume goes down and the elastance increases, then is where the driving pressure really makes a huge difference between low and high tidal volume. So there's a lot of data that came out since the pandemic. So I would like just to reiterate that the idea of L and H was only a means of communication, just to say, don't think just in terms of crude tidal volume, but consider compliance, consider the mechanism of hypoxemia and the recruitability, and adapt the ventilator perhaps based on lung volume and compliance and the driving pressure. That was the main reason for highlighting this two severe, spectrum of a long spectrum of disease. So I hope that it makes a little bit more sense now.
So we're coming back a little bit to the point that Leo made early in the beginning, that we should understand more, and it is clear that we understand much more now of the situation and the pathophysiology that takes place in the lungs, including the hemodynamic, the microthrombosis, as you mentioned. And if I may say so, if we have all this in mind, does it have consequences for the goals that we set during our ventilation strategy? Would it mean, for instance, that you would accept lower PO2s than you would accept in other patients? Would you strive for an even lower tidal volumes, or what is your opinion on that? So specifically aiming at the goals that you set. Huh?
Oh, for me. So, yeah, I would say that the strategy is very similar. It's just we need to consider that perhaps driving pressure to me is more important, because with one parameter, you can think of patients at the extreme of gas volume, so patients with preserved compliance or low compliance. You can have one rule for both of them, which is the driving pressure, so the scaling of the tidal volume to the lung compliance. And I agree with you. I mean, if we think that the hypoxemia in COVID-19 is in excess to what you would expect from the lung volume, then perhaps you can target your levels a little bit down to avoid excessive PEEP, which will influence your dead space ventilation. And some of the dead space ventilation might be a combination of the anatomical factors, the microvasculature that is impaired with microthrombosis, but it might also be consequence of the treatment. So using a lot of PEEP in patients who have altered VQ mismatch, but not a lot of recruitable lung, can increase your dead space. And there are data to support that. So there is data that show how using excessive tidal volume or excessive PEEP in COVID-19 does alter proxy of dead space ventilation, such as ventilatory ratio, for example. So I would use compliance as a really, and the physiology that Leo talked about, I think is very important. And if you have common rules, then it doesn't matter what the etiology is, because you're treating that individual lung.
I think there are some questions coming, but I think we are answering them to a certain degree, and I think we will answer them when we move our discussion further. I think, if you don't mind, I would like to go a little bit to what I think it was Giacomo mentioning before intubation. Of course, we are very happy if we can keep the patient without intubating. And we use all our means with mostly with high flow oxygenation or oxygen therapy or with non-invasive ventilation. It is in our experience also that some people get on with it and get well with it, but we also have considerable amount of patients who need to be eventually intubated, and this period is also sometimes very long. I mean, after a week they still need to be intubated, and it took us about 30-35 years to learn that late intubation was also a contributor to mortality. I'm very much in suspicion that sometimes we are losing very valuable time, because you see that these people who are intubated a week later have a very difficult ventilation situation. I'm very much interested in all of you what you think, and maybe we can start with Lise. She didn't speak the last couple of minutes.
Practically, this is, of course, the difficult questions at the bedside, because we all have seen patients who were not intubated and who finally had a good evolution. And we also have seen patients who were finally intubated with very poor compliance when they finally were intubated. And in my opinion, the key point is to try to understand whether a given patient is at risk for patient self-inflicted lung injury when he is not intubated or not. And basically, I think that assessing the work of breathing of the patient very practically by clinical exam, for example, is the key point. If you have a patient under high flow nasal oxygen or under CPAP or NIV who remains very tachypneic and has high tidal volumes and has signs of respiratory distress, probably that this patient should not be kept without intubation. And for me, the key point is clinical exam to try to decide.
Okay. Can you comment on that, Giacomo?
Yeah. I agree with Lisa. First of all, that we, especially in non-intubated patients, we are probably overlooking the PF ratio or the degree of hypoxemia, and I would value more respiratory rate, signs of distress, or signs of excessive work of breathing, rather than the severity of hypoxemia itself, if it's, of course, within reasonable values. So I agree with Liz that the point is the work of breathing the patient is doing. But I would like to raise another point, which is very important to me. I mean, Liz said, okay, we've all seen patients who have recovered with prolonged periods of mechanical ventilation without intubation. And I remind you that in the ARMA trial, the 6 versus 12 ml per kilo, not all the patients ventilated with 12 ml per kilo died. So what I'm saying is that what we have been doing during the pandemic, and sometimes what we have been forced to do during the pandemic, should not become the rule, because we have kept patients on non-invasive ventilation, on CPAP, prone positioning, high FiO2, high PEEP level in the emergency department, which is something that can be in some way justified if you do not have beds or ventilators available, but it should not become the standard of care. A patient, I would be very, very careful in treating a patient with ARDS if it's classical COVID-19, no matter what. I mean, acute hypoxemic respiratory failure with bilateral infiltrates outside the ICU or outside without careful monitoring. And I still believe that in normal times, you can do a trial of non-invasive approach, but after not a long period of time, if this approach fails, it's probably better to go to invasive ventilation, even if we have seen patients on CPAP for 10 days and they're recovering.
Okay, thank you. Leo, would you like to put on some more comments on that?
Yeah, this is a very important topic, and I think we should mention two important trials in this field, and they are both by Roberto Tonelli from Italy. And the first one is the trial where he measured while patients were not invasively ventilated, but on non-invasive ventilator, non-invasive ventilation, where he assessed the work of breathing, or basically changes in esophageal pressure. And those patients with the highest swings in esophageal pressure, so the highest work of breathing, were much more likely to be invasively ventilated, to be intubated. So this is some evidence for self-inflicted lung injury. And that same group recently published a study in the Blue Journal where they compared COVID patients to non-COVID patients on non-invasive ventilation with a similar PF ratio, similar baseline characteristics. And interestingly, they found that the COVID patients had a lower respiratory effort despite the same PF ratio. So if we accept this from a physiological point of view, and I'm a little bit careful here, then perhaps we can delay intubation in COVID patients a little bit more compared to the non-COVID hypoxemia patients. I think these are very important studies, important to read. And what I basically learned from it is that it is important in one way or another to monitor the respiratory effort in these patients. But these are two strong papers that at least suggest the existence of the self-inflicted lung injury and how important it could be in these specific patients, and to decide the moment for intubation.
But Leo, is then hypoxemia with a high respiratory drive versus a low respiratory drive, is that different?
Yes, I would think if the respiratory drive of the patient is low, I would feel comfortable of delaying intubation a little bit more compared to the patient with a similar level of hypoxemia, but with a high breathing effort. Those patients with a high breathing effort, when respiratory muscles are actually putting a large stress on the lungs, I think these studies show are much more likely to fail in the end, and probably more likely to have more severe lung injury. The problem is, so how are we going to monitor the respiratory drive in these patients? I mean, the Tonelli paper very nicely put in esophageal balloons in all these patients. But I think we have to be honest, very few hospitals are doing that in normal clinical care. And as Lisa suggested, perhaps the respiratory rate is a good estimation of respiratory drive, but we know that this is not always true. So you might want to look at tidal volumes. But ideally, I think where we should be moving in the future is a better monitoring of the respiratory drive. And these papers show that it indeed has clinical implications.
You do not fear harm in the rest of the body due to the hypoxia?
That's an important point. And then we have to decide about the limits of hypoxia. I would say if we keep the lower levels of the reference values, if we keep the saturation above 90%, I think that should be fine. I think we should not go below 90%. Okay. Yeah. On the steep part of the oxygen dissociation curve, there's some data to suggest that it might have these frequent desaturations, might have impact on cognitive outcome in the long term. So I would not take that risk. But if we're talking about 90%, 92%, I think I would feel comfortable when the respiratory effort, respiratory drive is not too high. And I think that's supported by these papers.
Okay. Luigi, do you have any additional comments on this, or can we go to prone positioning? Your choice.
Well, if you don't mind, I would love just a couple of comments. because I completely agree with the importance of measuring and following up over time the effort. But just a couple of comments. One is to when we compare COVID-19 and non-COVID-19 population, Leo mentioned the Tonelli's 2 papers in the Blue Journal. One of the things that we should consider is that the lung volume in these 2 groups is different. So although the stress is much less than the COVID-19, so the effort that these patients make in terms of delta esophageal pressure is lower, the total strain of the lung is the same. So and at the end, you know, some of the effects on patient self-induced lung injury is a strain related. So we need to consider the stress-strain relationship of the lung volume in these patients to interpret those 2 studies. And the second point, very briefly, to say that respiratory rate is clearly very important, but is a very, I just want to say, it's a late sign, isn't it? So the first thing, as Leo was saying, the tidal volume would be quite good to measure. And we've got evidence from ARDS that actually measuring tidal volume can predict failure of non-invasive ventilation because respiratory rate is a late compensatory mechanism. And the last bit is that dyspnea is clearly not very prevalent, particularly in the first wave. I mean, I remember the study from the Chinese population and the French population later on. Only 18 to 30% of the population had overt dyspnea, so they complained of having difficulty in breathing. So I think those considerations are to take in mind when we assess the patient on non-invasive support.
I think we can go to the proning of the patient, and we have actually 2 situations here. One has become, especially during COVID-19, very trendy, the awake proning. Maybe we can start there, and then I would like to go to the intubated patients, something like when to start, when to stop. Where shall we begin? I see it clockwise, Lisa, on the upper left part of the screen. Maybe you can start, Lisa.
Yeah, for intubated patients, in my opinion, the answer is relatively clear. We know that proning is efficient to improve survival in standard ARDS patients, and we know that this technique is nearly without any risk when we have some experience doing the proning. Then for those 2 reasons, I would say that in COVID-19 patients, we have to try, at least for those who are very severely hypoxemic when they are intubated. We should keep proning long enough. In the PROSERVA study, it was 16 hours, and I would say that probably we should do the same with COVID-19 patients. And for how long? Up a clear improvement in oxygenation, I think. And it's important to underline also that proning is used to improve oxygenation, but that the main effect of proning is probably that it's reducing lung stress and strain during mechanical ventilation. And with this strategy, we can lower the ventilator-induced lung injuries. And for me, it's relatively clear we have to use proning in intubated COVID-19 patients who are very hypoxemic.
Okay.
And the recent studies on COVID-19 tend to confirm this approach, I think.
Okay. And Luigi, can you comment on that, and also for awake proning?
Yes, I agree with Liz. I think in the incubator there's good evidence that is the right strategy to do. Now we've recently published a study where we look at ARDS and COVID ARDS in 7 centers, and what we found is 2 things, which has also been confirmed from other studies. The time to prone positioning is very important. So the earlier the better. Certainly within the first 24 hours is our threshold. And the second one is that the change in PF ratio actually predicts outcome. So having a patient who responds to prone position has got a positive aspect in terms of the outcome. And there are 2 or 3 studies now that confirm the same data, large studies. And the second one was about the awake patients. I mean, of course, we have done it quite a lot, because what we want to do is making sure the patient is not particularly hypoxemic and buy some time so that the steroids, the antiviral, the immunomodulators can have some effect on the underlying disease. There is not much evidence at the moment that the response in terms of prone positioning in awake is either sustained or can prevent intubation. So I would use it as a way of managing hypoxemia while we can test and we give all the other drugs to the patient. But keeping it long-term awake, I'm not quite sure whether it's the right strategy, but obviously monitoring the patient is still the key. That's my 2 points. Yeah.
Okay, anything to add?
Yeah.
From Leo, or, yeah?
Yes, if I may, I think we should refer to the Ehrman trial here that was published in Lancet Respiratory Medicine some time ago, right? Where patients were randomized between awake prone and standard of care, and that the primary endpoint, defined as death or intubation at 28 days, favors awake proning. That was 40% versus 46%. So I think there is some evidence that awake proning works. And to be very honest, I would not have expected it, because the rationale for proning in patients on controlled ventilation is different. It is not just to improve oxygenation, it's actually to improve the respiratory mechanics. And on forehand, I would think that in a patient spontaneously breathing, using the diaphragm, where there's probably not too much atelectasis and not too much consolidation, I would not have expected that awake proning would improve the outcome. To be honest, this was to me quite surprising, and I'm not sure, Joseph, if you want to go into too much detail of this trial, but it is remarkable to note that the benefit was mostly from one of these sites, from New Mexico. And for awake proning to be successful, patients had to be in prone position for at least 8 hours a day, which is quite a long time. So I think it's an interesting point. The trials also demonstrated, and there's also the Coppo trial from Monza, Italy, that actually demonstrated it is safe.
Okay,
and there is some evidence that there is benefit, but again, if you go back to physiology, I'm quite surprised that it works. So I would be eager to hear the opinion of the others about this.
It was clear. I see that we have only 4 more minutes. There is one more issue that I would like to ask to Giacomo, and that is about switching from controlled to ventilation to assisted ventilation, because we know that this can be a challenge sometimes, and we have a lot of failures there, and we have to go back again to the controlled ventilation. Can you say what are the challenges expecting us there, and what can we do about it?
Well, it's a very difficult question, because it's really one of the most challenging problems we have to face with these patients, because those patients they need a prolonged period of ventilation. I suspect that they stay in controlled mechanical ventilation and even paralyzed for more than the classical, let's say, 48 hours. And then I think that the timing of switching from controlled ventilation to assisted spontaneous breathing is really crucial, because there are some patients where you find the right moment and they start a good, let's say, assisted spontaneous breathing, and those patients they may be weaned from ventilation quite quickly. Other patients where they keep you try and they fail, and then you try again and then they fail. Then they need prolonged ventilation. They are at higher risk for infectious complications, and then everything becomes really challenging. One problem is sedation. We've had many patients that when you try to wake them up, they have delirium or agitation and so on. So it's not so easy to manage sedation, and this has a huge impact on the breathing pattern for sure. And another problem is management of secretions. Some of them have a huge volume of secretions, and this is another challenge that sometimes explains failure of switching to spontaneous breathing. And some of them, especially those with compliant lungs, they tend to develop high tidal volumes during pressure support ventilation, and in those patients you don't really know what to do if you have to accept those tidal volumes, because maybe PO1 is low and driving pressure even measured during spontaneous breathing is acceptable, or if you want to go back to controlled ventilation. So it's difficult. I would recommend anyway trying to a trial of spontaneous breathing once PEEP level is not excessive and oxygenation is acceptable, and like every day, because really you have to find the right moment, and if you find the right moment, then it's important for your patient.
The time is up. I thank you very, very much. Maybe I can put a few things that we have been talking the last 45 minutes. The important things that I have picked up is, of course, the heterogeneity. Every patient is different, that we have to understand the physiology before we are doing certain things, maybe pathophysiology. We should not forget the hemodynamics, not only in COVID-19, but also in all ARDS patients. I think the oxygenation has also a circulation component, especially in COVID-19 patients. We should not forget the vascular aspects and the high dead space with these patients. And we have developed certain methods, and we should not forget that they may be justified when we are faced with 20 patients per day, but we need to scrutinize them in normal, calmer periods and see if they are the standards, because now we have said that they are not the standards. We have also mentioned that high esophageal pressure measurement is a good indicator in deciding whether the patients are more likely to be intubated. We also mentioned that there is a difference between COVID and non-COVID patients in terms of stress-strain relationship, and we have also mentioned that tidal volume should be measured with spontaneously breathing patients on, for example, then high-flow oxygen therapy. We said that we should apply prone position as early as possible, keep the patient in the prone at least 16 hours according to the literature until there is a clear improvement seen. And we have also mentioned that there is some evidence that awake proning works for reduced mortality. That's not real evidence so far, but it's also widely used methodology. And lastly, we have said that switching from controlled ventilation to assisted ventilation is a complex situation. It depends on the sedation of the patient, the delirium which is developed to the secretions, and the compliance, high tidal volumes that you see with a compliant lung, and we have the dilemma whether it is giving more harm to the lung when they ventilate spontaneously or not. I think these were the things that we have mentioned mentioned so far. I would like to thank you all again as speakers and my co-chairman Armand, and I wish you a nice day further, and hope to see you again in another meeting to discuss these things further. Thank you.
Thank you very much.
Thanks. Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Innovation drives breakthroughs in healthcare every day the world over. Thankfully so, because as the world urbanizes and ages, and as lifestyle disease grows at serious rates, the need for healthcare innovations that support quality of life has never been greater. This kind of life-changing innovation is what we live for here at Fisher & Paykel Healthcare. We're invested in problem-solving that changes clinical practice for the better, reduces healthcare costs, and ensures better patient outcomes. There are two words that mean everything to us: care and design. We care passionately about improving lives. Care focuses and inspires our people to put patients first, to purposefully keep innovating and simplifying until we create an original solution that answers a human need. Design enables our researchers, scientists, engineers, and designers to apply their inherent curiosity and desire to do meaningful work.
welcome back in the studio. I am very excited to chair this session with Elie Azoulay, the president-elect of the Society. Hi, Elie.
Hi, Maurizio. Hello, everyone.
And we are excited because this year we started a new guideline committee with the idea to provide more important guidelines at the bedside. And one of the first topics that we decided to have was really ultrasounds. And I have to say we had appointed a fantastic task force led by Chiara Roba and Antoine Villar-Baron. And I'm very excited now to see the results of this work, which is being accepted in our journal Intensive Care Medicine. So with great pleasure, I would like to invite Chiara Roba, an intensivist based in San Martino Hospital in Genova, in Italy, and also the future chair of the Neurointensive Care section of our society, to present the consensus. And then there will be plenty of time for questions, and don't forget to put your questions on the chat. We will be together with Chiara, with Elie, and also with Adrian Wong to answer all your questions and comments.
Thank you very much for the opportunity to be here and present you the results of this very important consensus, which has been commissioned by the ESICM, and that included a huge number of experts, and that provided a huge number of statements on a topic which I believe is of extreme importance for the ICU clinicians. So the use of basic skill, of ultrasound basic skill for the evaluation of critically ill patients. This is the agenda for the next 20 minutes. So why the need of doing such a consensus? Critical care ultrasonography is an essential component of the management and evaluation of the patients in the ICU, but at present, it's not actually clear which are the skills and the competencies which are required to the intensivist for a head-to-toe evaluation of ICU patients. And so the aim of this consensus was basically to provide a list of recommendations regarding what the intensivist should know regarding the basic skills on ultrasound for the evaluation of and the management of ICU patients. Which patients? We considered as a target population patients admitted to a mixed general neuro ICU, including trauma, neurofacilities, and including medical and surgical population, but excluding major surgery, cardiac and non-cardiac surgery. This is probably the most important slide of my presentation. I was lucky enough to have an incredibly high-level co-chair with Antoine Villar-Baron, a very expert methodologist, Daniele Poole, and Adrian Wong, who was again still part of the steering committee and who helped with images and with the videos. And then we created a panel of experts from all over the world with different expertise in different subgroups and in different organs with according to their research and clinical skills and experience. And so we had one group who looked after and who produced the statement regarding the brain, one group who produced the statement of the lung, one group for the heart, one group for the abdomen ultrasound, and one group for the vessel ultrasound, and one group who looked after and performed the systematic review regarding the use of a teaching program, the presence of teaching programs and of training of ultrasound in the intensive care unit. So the panel, divided in this group, produced a number of statements which were then approved by the rest of the panel, and then they went under votation according to a modified Delphi method. And according to this, we obtained a different grade of recommendation. Strong recommendation when the agreement was above 85%, between 75 and 85% weak recommendation, and below 75 no recommendation. And we produced a total of 74 statements, 7 for the brain, the 20 for lung and for the heart and abdomen, and 7 for vascular ultrasound. And we were very happy with the results because we obtained strong agreement in 66.2%, in 8 cases 10% of weak agreement in favor, 3 weak agreement against, and no consensus just in few cases, less than the 20% of a statement. So starting from the brain, this was probably the most contrasting part of the consensus, probably because it's where we have to put a major effort in terms of research and training. We obtained seven statements. The first demand which was explored was the use of brain ultrasound for the evaluation of intracranial hypertension, and we obtained a weak agreement regarding the use of pulsatility index and the evaluation of qualitative waveform analysis to assess non-invasive ICP, but no consensus were obtained regarding the use of the optic nerve sheath diameter for the evaluation of increased ICP. And this was because it was considered probably too advanced and too specific for a general ICU physician. And this was exactly the same issue that we had in the other demands regarding the brain ultrasonography, like brain dead, vasospasm, evaluation of ischemic stroke, evaluation of cranial ultrasound for intracerebral pathology. No consensus was obtained in these demands, again, because this was considered by part of the panel as too advanced to be included as basic skill. And the panel had obtained a weak recommendation against the use of the autoregulation as basic skill, which was probably due to the technical difficulties and for the lack of important clinical applications at patients' bedside for this type of skill. Regarding the thorax, we obtained a huge number of strong agreement. We divided this topic in 5 different demands. So pneumothorax, pleural effusion, respiratory failure, airway ultrasound, and diaphragm ultrasound. Regarding the pneumothorax, basically the panel agreed that a combination of factors like the presence of lung sliding, lung pulse, B lines, etc., should be considered as factors that must be part of a basic skill for intensivists for the evaluation of a pneumothorax, and so the same for the presence and evaluation and identification of a lung point. And still strong recommendation was obtained regarding the use of lung ultrasound for the indication of pneumothorax drainage and to evaluate the location of pneumothorax drainage. Just a weak recommendation was obtained regarding the evaluation of a topographic projection of a lung point over the chest for the semi-quantification of extension of a pneumothorax. All strong statements and agreement were obtained for pleural effusion. So lung ultrasound is even more sensitive than the chest X-ray for the evaluation of small pleural effusions. And it also allows a good quantification of effusion volume. So strong recommendation regarding the use of ultrasound for the evaluation of the size, of location of pleural effusion, of the evaluation of the presence of complicated effusion, and for the evaluation of the indication position for drainage or evaluation of complication in case of the use of drainage of pleural effusion. So this should be definitely a clinical situation where lung ultrasound should be used in the general ICU. Respiratory failure, even in this case, we obtain strong recommendation regarding some components. For example, for the evaluation of interstitial syndrome and for the evaluation of lung consolidation, lung ultrasound was considered by the expert as a valid tool to improve the differential diagnosis of lung parenchymal disease, impairing lung aeration, and also in the use of ultrasound findings to improve the accuracy in the differential diagnosis of acute respiratory failure and for the diagnosis of pulmonary embolism. But no recommendation was obtained regarding the use of lung ultrasound for the evaluation of the loss of variation in the anterior fields, for the distinguishment of focal and non-focal pattern, and to guide and to set the ventilatory strategies in patients with ARDS, as this is considered too advanced skill. Airway ultrasound, despite some literature exists regarding airway ultrasound, the panel provided a weak recommendation against the use of airway ultrasound, probably because of the lack of a standardized technique and for the presence of other clinical findings which can actually help in the evaluation of the position of the tube and to evaluate a successful or not intubation. And regarding the diaphragm, weak recommendation regarding the estimation of diaphragmatic excursion and no recommendation regarding the use of diaphragmatic thickening fraction, which was considered by part of the panel as a too advanced tool and not supported by enough literature. Heart, again, in this case, 5 different demands. The first one was the evaluation of left ventricular systolic failure. The panel felt that a basic recognition of normal and abnormal echographic findings for the evaluation of global or regional wall abnormalities should be skills for, should be considered basic skills for the intensivist. The panel felt that no clarity, so no consensus was obtained regarding the use of transesophageal echocardiography as a basic skill, and most of the panel, at least half of the panel considered that transesophageal echocardiography should be part of the more advanced skill programs. Right ventricular failure, similarly to the left ventricular failure demands, the panel felt that the detection of right ventricular failure should be of great importance in the evaluation of patients admitted to the ICU with cardiopulmonary failure, and that the ultrasound evaluation of right ventricular failure should be important to inform diagnosis and prognosis of heart and lung interaction, and that these are all skills that should be easily achieved by a basic bedside ultrasound assessment. And therefore, we obtained 4 strong recommendations regarding the evaluation of right ventricular failure according to different criteria, to different clinical conditions. Pericardial effusion, similarly, the panel felt that the detection of exclusion of pericardial effusion should be an essential skill for intensivists, as well as the evaluation of tamponade, as well as the evaluation of the inferior vena cava to inform plausibility of tamponade physiology, and no recommendation was obtained regarding the use again of transesophageal echocardiography in the evaluation of pericardial effusion and the post-procedural drainage of pericardial effusion. Again, the same reason was that this was considered too advanced. Evaluation of severe hypovolemia, again, in this case, in cases of shock, of mixed shot, intensivists should have an understanding of the imaging features of hypovolemic shock, and this should be especially for used in clinical condition of more occult or chronic case of volume loss rather than in very obvious acute volume loss and acute shock. And the last domain for the heart group was the use of the evaluation of left-sided valvulopathy. Basic echocardiography can identify and should be part of best tips for intensivists major issues, major abnormalities of the mitral and aortic valve, which may provide clinical diagnostic information in patients with cardiopulmonary failure. With, however, the use of color Doppler for the evaluation of valvulopathy, which should be considered as well as basic skill for intensivists. Regarding the abdomen, the use of ultrasound for aortic syndromes has been encouraged and obtained one strong agreement. Bedside abdominal ultrasound has a very good accuracy for the detection of aortic abdominal aneurysm, so strong recommendation regarding the use of ultrasound in this clinical context, and 2 strong recommendations regarding the assessment of kidney and the urinary tract, and in particular for the evaluation of the presence or absence of hydronephrosis or bladder overdistension, but no recommendation was obtained regarding the use of a renal Doppler resistive index, which is a promising tool, but it hasn't been yet extensively validated in relatively inexperienced operators. And then regarding the non-traumatic acute abdomen, some skills regarding the use of ultrasound for the detection of intramural gas to rule in the diagnosis of non-traumatic acute abdomen definitely need further evidence and more advanced skills. But some skills, like for example the evaluation with a clinical, considering also the clinical context, but the evaluation of free fluid in the peritoneal cavity for the identification of non-traumatic acute abdomen have been considered by the panel as a basic skill for intensivists. And regarding the traumatic acute abdomen, well, we all know that abdominal ultrasound is a component, a fundamental component of the FAST, and so the panel agreed that basically the evaluation of free fluid, blood should be basic skill. Should be considered as basic skill for intensivists, integrated with a clinical evaluation and as an integral component of trauma resuscitation. Weak agreement was also obtained regarding against the use of RDRI of interlobal arteries, which has been previously considered in the previous demand, because even in this case, although this could be an important factor, an important sign of hemorrhagic shock and hypovolemic shock, this is still considered too advanced skill. And other applications which should be considered in both acute traumatic and non-traumatic skills have been then evaluated, but in most cases the presence of free fluid and the presence of big effusion in the characteristic of the effusion and the use of ultrasound as tool to help in the evaluation and in the treatment of the effusion should be considered as basic skill in both traumatic and non-traumatic acute abdomen. And regarding the vessel, this was probably the domain where we obtained the most of the agreement. The two major demands were the vessel cannulation and the deep venous thrombosis. Regarding vessel cannulation, strong agreement was obtained regarding the possible use of ultrasound in the cannulation, in the arterial cannulation and in the venous cannulation in case of multiple fail attempt, in case of when the arterial pulse is not palpable, and to guide and to assess, to detect the size, the position and the pathesis of the target vessels, as shown here in the figure, and for a continuous visualization of the needle tip during its trajectory in and out of plane, to avoid complications and to avoid mistakes and errors in the cannulation of the vessels. So a number of 6 strong agreements, strong recommendation regarding the use of ultrasound for vessel cannulation. And finally, one skill, one recommendation, strong recommendation regarding the use of ultrasound for deep venous thrombosis. In fact, the compression technique, when applied from the common femoral vein and at the groin of the popliteal vein, has demonstrated to be accurate in the diagnosis of deep venous thrombosis, obviously considered together with the clinical context, but it has high sensitivity and specificity, and therefore it should be considered a basic skill for intensivists. So all strong agreement regarding the vessel cannulation, probably because it's also the demand where we have the majority of evidence. So in conclusion, I think that we were able to provide with this consensus a large number of statements. We try to cover as much as possible all the clinical context of the target population that should be considered for ultrasound basic skill, and that intensively should possess and acquire for the evaluation of critically ill patients. In most cases, when consensus was not obtained, the reason was that these skills were not considered basics but they require an advanced teaching program. It's very important that, that to clarify that this document should not be read as a potential medical legal document, so it should be considered as a guide for the intensivist to acquire competencies, and it should be considered, we believe, as a core for any courses and training program, at least those endorsed by ASICM. Of course, there are some limitations. The principal one is the lack of a systematic review and of a literature, but the experts were selected according to the amount of papers and the literature that they have provided, and they have anyway performed a huge revision of the literature before performing the skill. I believe that this is going to be just the first step. In fact, important questions still have to be addressed regarding this topic, and it's very important that we don't stop here, because we gave some answers, but there are still a lot of questions which arise from this consensus, and this should lead to the development of future research and training program. And I will be very happy to continue to work with ASICM and with the panel to provide more evidence and to provide more training and educational program on this topic. And I thank you. I thank you for your attention. I thank ASICM for this great opportunity. And once again, thank you very much to the panel and to my colleagues for helping me and for providing such an incredible work that I hope will be useful for the clinicians who work in the intensive care unit.
Thank you, Chiara, and congratulations, first of all, on this very important work. I would like to call you back on stage and also to welcome Adrian Wong, the chair of the Social Media and Digital Content Committee at ASIC. Hi, Adrian. Hi, Chiara.
Hi, Maurizio. Hi, Eli.
Hello. So we have lots of questions coming from the chat and also through social media. But maybe I can start with a question first, maybe to Adrian. Adrian, what is different about this guideline? You are on mute.
You should have learned by now. What I think is different about these guidelines, as you say, it's the ESICM has adopted a new approach in developing these guidelines, more of a top-down approach. But one of the key driving factors for selecting these guidelines is the fact that it came from a survey of members from our clinical training committee who identified this void in terms of how to train and what to train with regards to ultrasound. So we addressed that gap, and I think the ESICM is in a unique position because we've always had a commitment to education, and that's shown by what we've done during the last 2 years above everything else. We've got a clinical training committee, we've got the academy, etc. I feel very strongly that these guidelines, as Chiara said, is just the start. So we've defined the competencies, and the ESICM are in a unique position that we can actually support colleagues from across Europe with the resources, the trainings to actually achieve these competencies. I'm not saying it's be easy, but at least it's a start. And that's what makes this difference.
Thank you, Adrian. But I mean, I'm the president of the society. I shouldn't ask the difficult question about the guideline that we have to produce. But if I want to play devil's advocate, Chiara, how did you come to consensus to something where there is basically no patient-centered outcomes? How did you decide what was important and what was not important to stay in the consensus?
So, well, it's not an easy question because we had a lot of discussion about this. I think that thanks to Daniele Pool, who is a very experienced methodology, we decided to structure the consensus as following. So we selected very, very experienced experts. All of them, if you see the names that I've showed you in the slides, they are really well-known experts and physicians and researchers on this field.
So they knew perfectly the literature, but especially they also had a huge clinical experience, which I think is the main component that has led to the development of the statements. So again, we didn't do a systematic review of the literature, but the revision of the literature was still extensive, and all these experts were well aware of what we have in our hands in terms of evidence on this topic. And according to this, but especially according to their clinical practice and their experience, they provided a proposal of statements. And then we reviewed the statements all together, because I think that it's very important to have the point of view of the super specialized expert in brain or heart, but it's also very important to have the feedback of all the other panelists, which are experts in ultrasound, but not super specialists in one only organ. And with this process, we were able to select the initial statements. And then we had to go through 3 rounds. So for some topics, it was very easy to achieve the consensus, because it's basically our clinical practice and it reflects our clinical needs. For some others, we had a lot of discussion. So this was basically the methodology. If I have to answer quickly to your question, I would say that we decided the decisions were made mainly relying and according to the experience of the expert, and that's why I think that in these guidelines is fundamental the choice of a panel and of the methodologist.
Thank you, Chiara.
Thank you very much, Chiara, and thank you very much, Adrian. I have a question for both of you, so let me start by Chiara. So we are evaluating and providing guidance about a device, and this device is often considered as an alternative to clinical examination when we are going to the diagnostic workup, but you are referring to it as part of the initial clinical assessment. So this makes an important change not only for education, but also for assessing diagnosis, that when patients come to the ICU, normally they don't have any diagnosis, and so we don't have a gold standard to which we should compare it. So my question to you is, how do you consider that ultrasound should be either a standalone strategy, so you are putting the stethoscope out, you are not getting into your hands, you are doing everything with the echo, or do you see it as part of the initial diagnostic workup?
Absolutely, the second one. I mean, if you see, I had just 20 minutes to go through all the statements, so I didn't have the time to specify it in the presentation. But for all the organs, there is also at least one statement which describes the need of integrating the ultrasound evaluation with clinical evaluation and with other types of imaging and tools. What I always say to my fellows is that the ultrasound machine has to become another stethoscope, another stethoscope from the head to the toes. So it has to help us, of course, and it's a very important tool, and it has the ability of being non-invasive, bedside, so that's why we all love ultrasound. But don't forget, we should not forget that we are physicians, that we are doctors, and that we have to trust on our clinical judgment, on the patient's evaluation. So we have to integrate it with the ultrasound, but the primary care of the patient is our eyes, our hands, and our evaluation.
Thank you very much, Chiara. Adrian, I have a question for you regarding a technology for which we are not the appropriate specialist. We are clinicians, we are ICU specialists, we are not radiologists. So would you take out ultrasound from the radiology department and perform them in the ICU by ICU clinicians? Or do you think that we should rely on the negative predictive value, considering that when the echo doesn't provide any help or any new diagnosis, we stay like that, or when there is something, so we ask for confirming. So that comes to evaluate the financial burden of echo. We've seen during the COVID time, some hospitals were doing routine CTs for patients with severe COVID to evaluate, to rule out thromboembolism, but some others did not, and the outcomes were not so different. So how do you see the evolution for that? Because we need to consider the device, the time that it is taking, and the probability of making an inappropriate diagnosis, like, for example, thrombosis, getting to anticoagulants, having side effects. So what do you think should be the next step to reassure something that is now in our ICUs and would be very, very hard to take out?
I think that's a very, very good question, Ellie, and it's actually one that we as a committee for task force address, which is we are not trying to be radiologists, we're not trying to replace specialist cardiologists or anything like that. We are trying to be the best intensivists possible for the patients that we look after on our intensive care units. So in terms of what we do, and we define what we think is reasonable to be able to do in these guidelines, we were also very clear, as Chiara mentioned, what we are not able to do or what we shouldn't do. Within all these things, I don't think ultrasound replaces the clinical intuition, the clinical ability of the intensivist by the bedside treating the patient in front of her or him. Ultrasound gives an extra layer of information to be integrated into that whole picture. And within that picture, the questions can be very, very simple, such as, is there a pericardial effusion in this septic patient that's making him hypotensive? That's a very, very easy question to answer. Is the reason why this patient is very, very hypoxic with very poor gas exchange or failing to wean from the ventilator because he or she has a very large pleural effusion? Again, it's a very, very easy diagnosis to make by the bedside. It doesn't necessarily need a transfer of a patient down from an ITU into the radiology department. And also, I think we need to give ourselves a bit more credit in terms of what we do. We look after really sick patients on our intensive care unit. We try to keep up to date. We look after patients to the best of our ability within the team that we have. So within the different modalities of ultrasound, there are some techniques that are perhaps more specialist to us. We have become the experts within that specialty. So for example, if you take brain ultrasonography, I would wager a good amount of money that not all radiologists would be able to perform TCDs as well as, say, Chiara can or Professor Chiario can, and yet they are not radiologists. And I think we need to move away from the mindset that an ultrasound equals radiology. It's about competencies, and we all want the same thing. We want the best for our patients, and it's about the competencies who can do that scan.
Thank you, Adrian. I'm very happy with your answer because you are starting by a clinical question and addressing it through clinical examination and echo, including the rest.
So we get a lot of comments on the chat, mainly compliments, and said that this is an important work. By the way, this will be published very, very soon on intensive care medicine, because I know people are already looking on the internet trying to find where it is. But maybe I have another question for both of you. You mentioned this as basic ultrasound skills, but this is basic if you know how to do it. If you have to learn how to do it, it can still be very complicated. What's next? How do I achieve these skills if I read this paper and you're telling me that these are basic skills that basically every intensivist should have?
Thank you, Maurizio. I can start if you want, Adrian. As I was saying at the end of the presentation, I'm sure and I really hope that this will be just the beginning. So if I try to think and as being in the shoes of someone who will read the paper when it will be published on ICM, I would say, okay, great consensus. Now I know what I should know to be a good intensivist. Now how can I achieve these skills? So I think it's our responsibility as leaders of this consensus to keep moving on the education and on the research component. We also performed, as mentioned, a very good systematic review of the literature regarding the competencies, the skills, and the training programs. And what we found out is that there is a lack in terms of number and high quality levels and standardized teachings on ultrasound. So now we know what we have to teach. So I think that the next step must be absolutely to provide to the readers and to the ICU physicians with instruments to achieve these skills. Courses, for example, books, educational material, etc. Obviously, with Adrian, we are already starting to think and to talk about this, because I have to be honest, the panel was very excited to be part of this consensus, and there was a lot of interest, and I'm sure that when the paper will be published, it will raise a lot of interest in the ICU community. So I hope, I think that this is going to be the pathway that we have to run.
Thank you. And Adrian, do you want to comment on this?
Yeah, I agree very strongly that the guidelines that we produce here is just the first step. And as I said when we first started this conversation, was that the ESICM is completely committed to education and educational resources. For those of you who attended yesterday's General Assembly, you would have heard that Frankie Duska, who's the chair of the Clinical Training Committee of the ESICM, has already committed, and we are going to have a course on these competencies at our next Congress. In the meantime, that we've already got an academy, an e-learning academy, and there will be learning resources, because ultimately we all feel very strongly that these guidelines are just the first step. It will evolve, and the society was committed to delivering the educational content to support colleagues who want to upskill or learn these skills.
And when I get these basic skills, how do I get the more advanced ones? Is it just something that I do alone, or do you think there is a role for something more structured, like proper courses, diplomas, and so on?
I think once you get the core skill, I hope that the desire to improve and get better and learn more will just keep you going. And as a society, an example, we've already have EDEC, our echocardiography diploma, and that was taken into consideration when we put all these learning feelings and platforms together, that we see this as the start. And if you then decide, right, I want to be more of an echocardiography because I look after lots of sick, complicated cardiothoracic patients, then EDEC, perhaps. And I think the same could be said about more advanced skills in neurocritical care, trauma critical care, so on and so forth. It is in a way, it's the foundation, and we expect it to change and evolve as things progress.
Thank you.
Thank you, Adrian. I have a question for Chiara. You have been looking at the literature like I think no one else, and you and your group should be commended for that, because you are going to bring us something that is easy, and the knowledge transfer will be amazing. So I have a question for you. Echo is considered as a very safe procedure with no side effect, with no at least identified side effect. So what will be your highlights? Should we pay attention to not being so sure? So, for example, did you have in mind situations where we need to be very careful when the echo is normal or when the echo is abnormal? Where do you see the limits of the technique, and what are your recommendations? What is your guidance for using and safely using the technique?
So my recommendation is that we need to understand that ultrasound is an easy, we always say it's an easy, available and easy technique, which is, I think, okay as a statement, but we also need to understand that we need training, because putting a probe in the four windows to see the heart, or to putting a probe on the lung is not difficult. But what is difficult is the interpretation of the findings that we get. And that is not that easy to achieve. We need to be very serious, because we take important clinical decision on what we see sometimes. Of course, we integrate with clinical and our other imaging context and characteristics, but we still make some decision based on the ultrasound. So we need, it's our responsibility to be sure that what we are seeing is something on which we are sure about. So I give you an example. Once I have started this consensus, I felt the responsibility of learning more, and I subscribed to the EDEC, because I realized that I needed more training, more security on what I was doing. So my suggestion is, take all the learning and educational opportunity that you have, and stay at the patient's bedside. Look for a mentor, a tutor, even not formal, but someone who has experience, and do as many ultrasounds as possible. We know that there is an inter-observer variability, but we also know that the possibility of mistake is reduced according to the amount of experience and the number of ultrasound examinations that we do. So it's all in our hands.
Thank you, Chiara. I have another provocative questions for Adrian, if I may, and we have the time. It's about, where I remember when we were younger, the Swan-Gus catheter was, mandatory when you had to deal with a septic shock, or with a shock where you had to optimize the patients. So let's say that tomorrow there's a trial showing no clinical benefit from echo. What you would be missing? What would be the clinical situation where you could not provide the same level of care without echo?
I think that, first of all, I'll be completely honest, if you look at the literature in terms of ultrasound and how it affects patient outcomes, at best you would say it's variable. There's never been a trial of ultrasound that says if you use ultrasound, you would definitely improve patient outcome by X amount. And part of that, I think, if you take a step back and look at the skill required of using ultrasound, there is image acquisition, interpretation of the image, and ultimately integration into the clinical picture. And I'll come back to that point, is the ultrasound is just a tool. And if you don't know how to use it, then it won't help. In fact, it may even harm the patient. So let's take another example. So if you come to see the septic patient, and you basically do your assessment, clinical assessment, you give antibiotics if the patient is incredibly shocked, you might consider fluid resuscitation, et cetera, et cetera. And I think now that we know that septic cardiomyopathy or myocardial dysfunction because of sepsis is a real entity, and perhaps we can identify it more easily because echocardiography is more available, we are able to say, well, maybe I should stop giving fluids to address the hypertension. Maybe it's not the fact that this patient is hypovolemic that is causing this patient to be hypotensive. Maybe it's the heart that's the problem. That would be a very, very easy thing to do with bedside echocardiography. Perhaps the patient that comes in, collapsed, uncertain etiology, maybe stabbed, maybe run over by a car, you're not really sure, you put the probe on, and you see pericardial tamponade as an example. A very, very quick diagnosis and life-saving diagnosis in that situation.
Thank you, Adrian. And I think, if there is a clinical problem, it's always good to have extra information to find out what the problem is. But sometimes I've seen that we can get too fixated on images, on numbers, and we run the risk to treat images without a clinical problem. How do you come up with recommendations in your paper? Do you say something on when to do an examination? Should you do it all the time with your clinical examination? So how do you decide, basically, when you have to look for something? And what if you find something but you have no clinical problems? Chiara, maybe?
Well, We basically didn't go into this detail in the consensus, also because we had already more than 70 statements, so we just focused on the skill required. And we generally said, I think in the discussion of the paper, when according to the clinician's need and to patient's conditions, you have the need to do an ultrasound evaluation, this is what you need to see, this is the skill that you need to achieve. So this is not something that has been addressed by the consensus, but I think it's a very important point, which maybe could open or pave the way to or a specific discussion, a specific consensus on that. So when to decide which is the role in our clinical practice of the ultrasound, or could be dedicated during the teaching program and the educational program.
What do you do in your practice, Chiara?
So I generally start basically with a clinical assessment. If the clinical assessment triggers me some issues, some questions, I use the ultrasound. In any case, when I have an admission in the ICU, I generally do a head-to-toe ultrasound evaluation, basic one, and then it's the clinical picture of a patient that drives me in a more accurate ultrasound evaluation, and then it's the ultrasound evaluation that helps me to trigger for more advanced imaging. So this is a bit what Adrian was saying before. It's not a substitute of a CT scan. It's not a substitute of a CT head, and we should not, at present, we don't have the evidence to say that we can replace a CT scan with ultrasound, but it can really help us in the discrimination of those patients who are at risk and need further evaluation, and the patients who are not at risk for complications. So that's the reason my reason making at the bedside.
Maurizio, if I may, Ellie, if I may, I think it's really important that whenever we perform an ultrasound scan, and as part of the strategy we deploy when developing this consensus, is that before you even put the ultrasound probe, there is a question that you are trying to answer from a clinical perspective already. So, for example, before you even put the echo probe on to examine the heart, perhaps the question you are asking is this patient hypotensive because the LV is impaired? Is this patient hypotensive or shocked because there are pericardial effusion? So there is a clinical reason why you are performing the scans anyway, and you're trying to answer a clinical question. Now, it's actually very, very good and important to say, well, that's my clinical question, but I don't know, I'm not sure. Then you rely on the fact that you are a clinician, and if you don't know something, you pull in all the other bits of information and treat the patient in front of you, not the image, not the number. And if you still don't know, you phone a friend, someone who can perform advanced echocardiography, say. And I think that's really, really important to get out there.
Thank you. So if I can wrap up, it's always clinical examination first, always seeing if there is a clinical problem, but basic ultrasound skill, head to toes, can really help in that situation. So thank you very much for your work. Thank you for being with us today, and we look forward to read the full paper very soon. Thank you.
Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. So hello and welcome back for the last groundbreaking with intensive care medicine. This is the grand finale. I am very pleased to be here again with Giuseppe Citerio, the editor-in-chief. Hello, Giuseppe.
Hi, Maurizio. Thank you very much. And I'm happy to see that the journal has been present many times during the Congress, presenting some randomized control trial in these days.
It's been very exciting, and seeing so much research and trials published in intensive care, it's really fantastic for the community, and thank you also for all the work, because I know it's a lot of work from your editorial board to manage all of this.
Thank you also to the society's support, because I think the journal is feeling to be part of a community of the European Society of Intensive Care, and we are happy to be part of it.
So, without losing any more time, the first trial released this afternoon. It's a pleasure to invite Craig Dale, an associate professor at Lawrence Bloomer Faculty of Nursing, University of Toronto, scientist at Sunnybrook Health Sciences in Toronto, and also an editor of the journal Advanced Nursing, with a trial on the use of chlorhexidine. So, Craig, the stage is yours.
Hello, colleagues. My name is Craig Dale, and on behalf of my co-principal investigator, Brian Cuthbertson, I'm very pleased to present on the effect of oral chlorhexidine de-adoption and implementation of an oral care bundle on mortality in mechanically ventilated patients in the intensive care unit. This is a multi-center stepped wedge cluster randomized control trial, and I'd like to thank the organizers of the ESICM Lives 2021 and the moderators of today's session for this opportunity. We have no actual or potential conflicts of interest in relation to this program or presentation to disclose, and our study funding was provided by the Canadian Lung Association and the Network for Canadian Oral Health and Research. I'd like to thank the Coral investigator team for their important contributions to this study. I'd also like to thank the multiple site leaders and champions who made this study possible in each participating unit. The background to our study today concerns intubated and mechanically ventilated ICU patients being at risk for developing infection-related ventilator-associated complications, or IVACs, such as ventilator-associated pneumonia or VAP. VAP is reported to affect between 5 to 40% of all patients receiving mechanical ventilation and is associated with increased mortality, somewhere between 1 to 10%, as well as greater duration of mechanical ventilation and costs of treatment. This makes it an important problem to continue to focus on. Processes of care to prevent VAP often target oral health dysfunction. Inadequate salivary flow associated with critical illness and oral intubation contribute to painful oral health deterioration during treatment, as well as abnormal oropharyngeal colonization with bacteria. Over the last few decades, we've seen sustained emphasis through professional societies on preventative oral care to reduce bacterial overgrowth and its aspiration. Initial concerns about the association between ventilator-associated pneumonia and adverse patient outcomes led to the introduction of the VAP bundle. This bundle was intended to consolidate multiple treatments for VAP into one care package to be systematically implemented in daily practice. Here on the screen, you can see a list of common bundle prevention strategies, many of which you'll be very familiar with, And of course, one of these includes oral chlorhexidine rinse to control oral bacterial overgrowth. Oral chlorhexidine rinse has been extensively studied in randomized controlled trials. Meta-analysis of open-label studies suggest lower VAP rates through its use. However, meta-analysis of double-blind studies demonstrates no impact on VAP. Although the evidence supporting chlorhexidine oral care is mixed, cross-sectional surveys demonstrate up to 70% of ICUs in Europe and North America have adopted daily oral care with chlorhexidine as a simple, low-cost approach to VAP prophylaxis. Notwithstanding its high use in practice, recent publications have challenged our presumptions about the safety and efficacy of daily chlorhexidine oral care. Concerns include an unexpectedly high rate of oral lesions in patients exposed to 2% chlorhexidine rinse, and evidence of reduced VAP pathogen susceptibility to chlorhexidine, including E. coli. These disadvantages may increase procedural oral pain due to inflammation and disruption of the integrity of the oral mucosa, and possibly contribute to an increased risk of oral systemic infection with antibiotic-resistant organisms. Most serious among the concerns reported in the literature is an unexpected signal of excess mortality. This signal appears in more than one meta-analysis. For example, Price and colleagues conducted a network meta-analysis including 11 studies, which you see in the forest plot before you, and this demonstrates use of chlorhexidine prophylaxis is associated with an increase in mortality in adults with an odds ratio of 1.25. A variety of mechanisms have been proposed regarding the contribution of chlorhexidine to excess mortality, including the aforementioned mucosal disruption and acute pulmonary toxic effects, which may predispose patients to infection or respiratory failure, respectively. The additional burden of such complications could negatively impact mortality, contributing to the signal. In response to these concerns, many of our colleagues in Toronto, Canada, became interested in the adoption of chlorhexidine oral care to mitigate the associated or potential risks. De-adoption is defined as the scientific discontinuation of an ineffective or potentially harmful or low-value clinical practice. Research in de-adoption shows that routine practices indicated for removal can persist in the intensive care unit despite evidence of limited benefit or potential harm. Recommended strategies to address this persistent use include a rigorous de-adoption trial that removes the particular intervention, for example, chlorhexidine oral care, whilst advancing an alternative. This could be, in this case, a standardized oral care bundle that's consistent with ethical and evidence-based standards. In this instance, outcomes of concern, that might be mortality or vivax rates, could then be measured and reported to stakeholders to address lingering uncertainties regarding the effect of de-adoption. We took this under our belts and decided that this was perhaps the best approach to address the concerns around chlorhexidine. Our hypothesis in the CORAL study was that de-adoption of chlorhexidine prophylaxis and implementation of a standardized oral care bundle would reduce mortality, IVAX, procedural pain, whilst improving oral health status of our patients. Our research questions included, number one, what are the effects of oral chlorhexidine de-adoption on ICU mortality? 2, what is the change in IVAC rates, oral health dysfunction scores, and procedural oral pain following the de-adoption of oral chlorhexidine in the introduction of an oral care bundle? And 3, what is the fidelity with the oral care bundle? The move to adopt chlorhexidine across multiple ICUs led us to consider a stepped wedge cluster randomized control design. Rationale for such a design includes the existing intention of participating clusters to de-adopt. This was in addition to the benefit of providing education to smaller groups or clusters at predefined time points, which is much more efficient and feasible. the avoidance of contamination between intervention and control groups in parallel randomized controlled trial designs, and it would also alleviate ethical concerns about withholding of the intervention or persistent use of chlorhexidine in particular units. In terms of methods, our step-wedge trial design recruited 6 participating ICUs in Toronto, Canada, and randomization of units to 6 sequential steps was computer generated by the study statistician. And clusters agreed to participate with the understanding that the date of the rollover to the intervention would only be known approximately 2 months prior. We included an embedded process evaluation to understand the fidelity of the intervention and provide a clear description of our implementation processes. The table on the right of your screen illustrates the study's 14-month recruitment period. The white boxes in the table demonstrate the control period. Starting on the left, all clusters defined as individual ICUs commenced the study with a 2-month control period comprising 0.12% chlorhexidine oral care. This concentration of chlorhexidine was standard of care in most units for over 10 years. Clusters subsequently rolled over into the intervention, which is signified by gray boxes every 2 months, by de-adopting chlorhexidine and implementing a standardized oral care bundle. We estimated that 6 clusters, averaging 50 ventilated patients per month for 14 months, would provide a total of 40 to 100 patients, assuming an intercluster correlation of 0.001, would provide about 80% power to detect an absolute reduction in mortality of 5% from a baseline of 26%. We utilized a local registry that continuously collects de-identified patient demographic, clinical, and patient outcomes to determine IVAC rates and ICU mortality. Independent assessors of mortality and IVAC outcomes were blinded to the intervention. With respect to the oral care delivery intervention, the standing medical orders in all study units during the control period maintained 0.12% chlorhexidine oral care. The nursing protocol in tandem with this during the control periods were generally individualized to each patient's needs and variably included toothbrushing, deep oral suctioning, and mouth-lip moisturization on each shift. The intervention, in contrast, comprised the adoption of chlorhexidine unless it was prescribed for an oral infection. And this was achieved by pharmacists removing the product from the ICU stock, as well as removing it from the standard medical order set. We introduced standardized oral care bundles specifying the frequency of each bundle component. In addition, we asked nurses to visually assess the oral cavity once per shift. To accomplish this intervention, we designed an integrated knowledge translation approach, and this included technical video instruction on oral care delivery of the intervention bundle, as well as a patient-family touchpoint video on the importance of oral care delivery. We provided point-of-care instruction on oral care and supportive feedback to frontline staff. We provided a template medical order set for oral care, and that specified the oral care changes that you can see here, which include toothbrushing every 12 hours, deep oral suctioning every 4 in PRN, mouth-lip moisturization every 4 hours in PRN, as well as the oral assessment every 12 hours. Finally, we used random audit and feedback to address bundle compliance or fidelity, and used that data to generate monthly audit reports for each unit. The primary study outcome of ICU mortality was analyzed using a generalized linear mixed model with binary distribution and logic link with random intercept to account for clustering of patients within sites and adjusting for secular trends with time and days from the start of the study as a linear effect. Due to the small number of clusters, we adjusted for age, sex, Apache 2 predicted mortality, and operative status at ICU admission. Our secondary outcomes included IVACs. Those meeting IVAC criteria were included in time to IVAC evaluations, which were analyzed using a fine gray model to account for competing risk of death and adjusting for the same covariates as for mortality. Oral health status or dysfunction was analyzed using a linear mixed model, and based on prior research demonstrating procedural oral pain during routine mouth care, we dichotomized observational pain scores to determine absence of procedural pain and adjusted the analysis with the same covariates as the oral health scores. A Cox proportional hazard model is used for post-hoc analysis of time to extubation among survivors adjusting for the same career rates as IVACs. With respect to study results, here are our patient characteristics. We recruited 3,260 patients with 1,560 in the control period. As a reminder, this group comprised chlorhexidine oil care. And we had 1,700 patients in the intervention group, which received non-chlorhexidine oil care bundle. Patients were similar in both study periods with respect to age and sex. However, as is common in cluster trials, we observed differences in demographic groups between control and intervention periods with respect to Apache 2 score, uplift status, and the number of comorbidities. After adjusting for differences in baseline characteristics, we found no significant difference in ICU mortality between control and intervention periods. The ICC for ICU mortality was 0.013, and there was no significant secular time trend. Time to IVACs and time to extubation among survivors did not differ, and procedural oral pain was not significantly changed. However, oral health scores improved in the intervention period. Monitoring of intervention fidelity and over 340 discrete oral care encounters demonstrated successful de-adoption of chlorhexidine in the intervention period. We observed significant increases in the delivery of all oral care bundle components between control and intervention periods, with the exception of oral suctioning, which was high at baseline. So in this stepwise cluster randomized control trial recruiting 3,260 mechanically ventilated patients across 6 adult ICUs in Toronto, Canada, we observed no ICU mortality benefit of an intervention comprising the adoption of oral chlorhexidine and implementation of an oral care bundle. Our final sample size fell short of the participant number anticipated in our sample size calculation, and therefore we had insufficient power to detect a mortality difference. Other outcomes, including time to IVACs, time to extubation in ICU survivors, and oral procedural pain, were similar between control and intervention periods. However, oral health scores improved in the intervention period, albeit at a level below the minimally clinically important difference for this metric. Nonetheless, this is an important finding. Our process evaluation provides clinicians and policymakers with clear information about implementation strategies, thereby strengthening and potentially replication opportunities and potentially assuaging uncertainties about the negative consequences of de-adopting chlorhexidine. Given our results, it may be reasonable for ICUs to focus on improvements in oral care delivery until further evidence regarding chlorhexidine oral care becomes available. I'd like to thank you again for the opportunity to present the CORAL study results, and we look forward to your questions. Thanks very much.
Thank you very much, Craig, for a very nice presentation, and we invite you back on stage now to answer to the questions and comments from the audience. I remind you all that you can use the chat. I see we have many people connected, and feel free to put questions or comments, and we will try to answer them all. But before we start, I would like to ask Giuseppe. Giuseppe, you see a large randomized controlled trial on chlorhexidine, the adoption. How was it for you when you received the paper, and how was the editorial process for this paper?
Yeah, we saw a paper on a large number of patients with a very practical question, because as Craig said, chlorhexidine became a standard of care, and we have a lot of doubt about chlorhexidine now, and they decide to de-adopt something that has been adopted in the bundle. So we were curious about the result, and I think also the community needed to understand if we can stop using chlorhexidine for oral care in our patient. And if I can start asking something to Craig, I think that there is a very important multidisciplinary study, and we are happy about it. And I was surprised about the cost of the trial, how much it cost.
Yeah, thank you for that question, Giuseppe. That's an important one. And to start off, I'd like to note that Brian is here with us today too, so I'm hoping he can join our live discussion. The cost was one that was possible with a low cost due to the collaborative health sciences network to which we belong. And I think in part because aside from investigator costs, we were able to gather enough support and use existing repositories of data to lower the costs of this trial. I would say the highest costs were probably in evaluating the fidelity of the intervention. We put independent trained assessors into the ICU, both on daytime and nighttime. And so that was considerable work, and that's where most of the costs were borne. So without the collaborative network and in a research-intensive environment, this would not be possible. And I suppose it might be difficult to replicate for other centers around the world.
I think some questions are coming, and some are about the concentration of chlorhexidine, and probably you have to explain which concentration did you use, because I think it was lower than other study. And we can start from this question because they ask, what do you think about chlorhexidine 2%?
Yes. To clarify, this is correct.
Hi, Brian. We were waiting for you. Nice to see you.
I was waiting for you. Nice to see you.
Yes, so let me actually welcome you on stage, because I thought there was a problem with the connection. Also, the senior author of the paper is known to all the intensive care community, but just a very brief introduction. He's the chief of the Department of Critical Care Medicine at Sunnybrook Health Sciences Center, a senior scientist, very long CV in research. I think he needs very little extra introductions. We're delighted to have you here and to participate in this panel discussion, Brian.
Thank you.
Craig, maybe you can carry on with your answer to the question, and maybe, Brian, you can weigh in.
Sure. Thank you for the question. The concentration of chlorhexidine at 0.12% is a long-standing one here in Toronto, Canada, and I would anticipate in most of North America, which may contrast with higher use in many centers in Europe, particularly 2% chlorhexidine, which might be applied to patients that are deemed at high risk for VAP. So we have not used 2% chlorhexidine in our centers, so that would explain the starting point for this study. I suppose we were really taken with the publication by Plantinga and colleagues around the lesions around 2% chlorhexidine. And, you know, our patients, regardless, have told us that chlorhexidine does manifest in symptoms for them, discomfort and stinging, probably because of the alcohol base in many formulations. So we knew there was potential for tissue disruption. And so, however, we don't have local experience with 2% or the gel formulation.
Okay, Brian, do you want to comment on this?
Yeah, I think it's unlikely that there's going to be a significant change to this result based on a higher concentration. And if there is, the effects and the side effects may increase. So the side effects profile here is the concern, and that's why we did this trial. So I think the only safe thing to assume right now is there's not evidence to support the ongoing use of this without further evidence. And I don't think believing you use a higher or indeed a lower concentration will actually, it's not safe to assume that.
We are receiving a lot of questions because it's an interesting study design, because the exposure in a way is removing something that is standard practice. And they're asking, did you find any lesions in the control group in this case?
Oral lesions.
There are some, but not many that we observed. And so the scoring system that we used would take those up and create a composite score. So they're difficult to retrieve, but not many, I would say. So that might also be important to note. And as Brian suggests, you know, the difference in the concentration probably wouldn't necessarily manifest necessarily in a composite oral health score, but we did not see many lesions.
And you've completed this work, and the question is, why didn't you compare with other alternative to oral chlorhexidine instead of the adoption of the chlorhexidine altogether?
I'll have a bash at that one, Craig, if you want. The meta-analysis signal was actually one for harm, a weird one for reduction in VAP and increase in mortality. Hard to explain. One possible explanation is chlorhexidine is toxic. Although we have not shown that specifically, we have also failed to show benefit. So we were very keen to actually test it against nothing. And we also believe, particularly coming out of Craig's research, that this was harming oral care, and we think we have indeed been shown to be correct because the oral health scores improve without a negative effect on the VAP, the IVAC, or the mortality outcome. So we wanted to test this against high quality oral care, but not a VAP prevention strategy.
Very good. And how do you interpret the results now in your practice? Again, it's an interesting study design, the adoption of something against standard. I mean, you didn't see any benefits in de-adopting, but are you carrying on using chlorhexidine, or how do you interpret the results? Are you demonstrating that actually it's something that we don't use, or I cannot interpret the results that way?
Well, I think you bring up a good point about interpretation, and clinicians will need to make a decision about moving forward if they're currently using chlorhexidine, and we might not entirely resolve that dilemma for them. But although this was not a comparative trial in the sense of head-to-head, I don't think overall, when we look back at the evidence, that we see enormous benefit for chlorhexidine in terms of its intended use. And I think from a patient-oriented perspective, we're not seeing outcomes including time to extubation or being improved. So, we have not continued on with chlorhexidine. It's been removed and stays de-adopted in our units. So I think for those units around the world who are considering this or have already done so, this might help to answer some questions around what would happen. And I think we've seen that our patients are not worse for wear in this de-adoption process.
Thank you. Very useful comment.
We have other comments here coming. So one comment is partially already discussed by Brian, and a participant, Paul, asked if, considering the potential benefit mainly in post-cardiac surgery patient and the possible harm according to meta-analysis that has been quoted, why didn't you test two drugs, the chlorhexidine versus another product for reducing the incidence?
They answered this already.
Of AP. Yeah, partially.
Yeah, I think we did answer that one. We were very keen to test this against no intervention for the VAP. Remember, the evidence for this was never good. There was a lot of bundles and a lot of energy and institutions like IHI who were pushing this very hard, but the evidence was not ever that great. And in fact, as I say, if you look at the meta-analysis, there was evidence of excess mortality. We had to see if this still had a place in practice. Right now, we believe it does not.
So, Brian, it's very interesting, and again, I come back to the design of the study and removing a part of the bundle. Can you tell me, is there something else you're looking next now on the bundle about maybe removing, or are you looking at other trials in removing something that has become standard practice? And also following on that, how do you explain that for years we build up evidence on something and then suddenly it seems that it makes no difference anymore? As the quality of care got so much better, then we don't need that intervention?
The fact is that we had highly confounded research about the impact of VAP, including its mortality. The mortality is nothing like what was quoted in some of the original literature, which was quoting 10–20% mortality. There was no attribution there. The actual attribution is about 1%. This is not the public health scourge that we made it out to be in the early 2000s. I'm not saying it's not important, but I think I would say, I know Craig will agree with me, focus on the oral health of your patients right now. I'm not relating this to VAP, I'm relating this to comfort, lack of pain, lack of symptoms, etc. There's a great opportunity to improve their oral health. That's really important. VAP is not unimportant, but it's not nearly as big an issue as it was, or thought to be.
going to the conclusion of this talk, I would like to ask both of you how the result could be generalized. I saw that many units did participate in Toronto, different units, so can we generalize this finding to all the ICU community or only in some settings?
Well, I would say that our results are generalizable to adult settings with a broad case mix. And that was part of our design. The participating units had subspecialty populations mixed in. So I think that is important. And yeah, I think part of the advantage of our design is the, the integrated process evaluation. And so there are tools there that enable other units to follow suit and have a clear understanding of how to do this.
Thank you. Can you elaborate a bit more on the subgroups? Do you think that could be a subgroup of patients where maybe outcomes could be different and there may still be a role to keep the chlorhexidine in the bundle?
Yeah, we don't have power for that, do we, Craig, in terms of, as always with any subgroup, of course. The cardiac surgical group's the obvious one. We don't have power for that. They have a lower risk of VAT based on the limited exposure to ventilation, etc. So I think it's unlikely there's a subgroup here, but we don't have the exploratory power to look at that specifically.
Okay, thank you very much. I think we've answered the majority of questions. There were coming lots of comments and again, lots of compliments for your study. I'm very fascinated by the design of the study, really, and a little bit going against some of the dogmas that maybe we're bringing forward in therapy. So thank you very much, and congratulations on a very nice randomized controlled trial, very creative research question, and well done conducted study.
Thank you.
So, Giuseppe, time to move on to our next and last trial from intensive care medicine. Do you want to say something about it?
Yeah, let's move on. And the next paper is a randomized controlled trial with two drugs, tocilizumab and remdesivir, in patients with severe COVID-19 pneumonia. And is a randomized controlled trial, and unfortunately the first author of the paper from Houston is not able to join us, and so the result will be presented by Dr. Olson from California. She is part of a company that did sponsorize the study, so we want to disclose this potential conflict of interest, but we will see the presentation in a while and then we can discuss with her later on. Please.
My name is Julie Olson, and I will be presenting the REMDACTA study, a study of tocilizumab and remdesivir in patients with severe COVID-19 pneumonia. I'm presenting this study on behalf of our investigators and our study team because our lead investigator, Dr. Yvonne Rosas, is not available to give the presentation. In terms of my disclosures, I am an employee of Roche Genentech, and I served as the lead medical monitor for this study. Tocilizumab plus dexamethasone is now recommended for patients hospitalized with COVID-19 associated rapid respiratory decompensation. But studies of tocilizumab in patients with severe COVID-19 pneumonia have demonstrated mixed results. Remdesivir has been shown to provide clinical benefit in patients with moderate and severe COVID-19. Now, back when this study was designed in 2020, there was still a lot of uncertainty around the best approach to treating COVID-19 pneumonia. And we hypothesized that combining an antiviral therapy with an immunomodulator would be more effective than antiviral therapy alone. The objective of this study was therefore to evaluate whether tocilizumab plus remdesivir would provide greater benefit than remdesivir alone in patients with severe COVID-19 pneumonia. Our primary endpoint was time for randomization to hospital discharge or ready for discharge, which we defined as a category 1, assessed by the investigator on a 7-category ordinal scale of clinical status, and that was assessed as time to hospital discharge or ready for discharge to day 28. In terms of the patient population, we enrolled patients at least 12 years of age, hospitalized with severe COVID-19 pneumonia, and enrollment took place between June of 2020 and March of 2021. And we only enrolled adults. We did not enroll any adolescents. Patients were required to have a positive PCR test result within 7 days of randomization, pneumonia confirmed by chest X-ray or CT scan, and hypoxemia requiring more than 6 liters of supplemental oxygen. Patients were randomized 2-to-1 to receive blinded treatment with tocilizumab plus remdesivir or placebo plus remdesivir. We did stratify randomization by geographic region and also by a 2-level factor based on clinical status at screening, so that we grouped ordinal skill categories 4 to 5 together versus category 6, and that's again on the 7-category ordinal scale. Remdesivir was administered IV, and that was then followed by a single IV dose of tocilizumab 8 milligrams per kilo up to a maximum of 800 milligrams, or placebo, and that was given on day 1. Patients were followed through day 60, but as I already mentioned, the primary endpoint was assessed at day 28, and again, that was time to hospital discharge or ready for discharge. I want to first share our enrollment by country, and this is for all patients. In general, enrollment in all the countries was balanced between the treatment arms. The majority of our patients were enrolled in the United States, but we also enrolled in Brazil, Russia, and Spain. And we had 434 patients randomly assigned to the tocilizumab plus remdesivir arm, and 215 patients assigned to the placebo and remdesivir arm. Now this shows disposition to day 28, and the most common reason for discontinuation from the study was death. So for the tocilizumab and remdesivir arm, we had 18% of patients who died on day 28 or prior to day 28. And we had 19.5% of patients in the placebo arm who died up to day 28. In terms of the non-safety discontinuations, the most common was loss to follow-up, but we did put a lot of effort into minimizing the number of patients who were lost to follow-up, and that was 2.5% for the study overall. This summarizes the analyses population, and that's just to clarify why the numbers differ a little bit. We did have a total of 9 patients that did not receive tocilizumab or placebo as planned per the protocol, and our modified intent to treat population therefore includes 430 patients in the tocilizumab arm and 210 patients in the placebo arm. For the safety evaluable population, we have 431 patients in the tocilizumab arm and 211 patients in the placebo arm, and that's because of 2 patients who were assigned to receive tocilizumab but did not receive the active tocilizumab treatment. They were included in the placebo arm for the purpose of the safety analysis. So again, this slide is just to clarify why the numbers differ a little bit for the different patient populations. For baseline demographics, the treatment groups were generally well balanced, and there are some small differences, but really not any differences that would be expected to impact the efficacy analyses. So looking at gender, age, ethnicity, and race, the groups were generally well balanced. For baseline clinical characteristics, so this is now the modified intent to treat population. Again, the 2 treatment arms were generally well balanced. The tocilizumab arm did have a slightly higher proportion of patients with a baseline ordinal score of 5. So that was 9.1% in the tocilizumab arm versus 4.3% in the placebo arm. And the tocilizumab arm also had a slightly lower proportion of patients with baseline systemic corticosteroid use. So for baseline, it was 83% of patients in the tocilizumab arm and 86% of patients in the placebo arm. But again, a small difference that seems unlikely to impact the efficacy results. In terms of the important comorbidities that have been identified for COVID, the groups were generally balanced. So that's on the bottom of the slide here, where we listed the numbers for diabetes, heart disease, and hypertension. And the groups were also balanced with respect to time since the first COVID-19 symptom. Now, this is reason for study treatment discontinuation, so coming off treatment versus discontinuation from the study itself that I showed earlier. Now, discontinuation for tocilizumab and placebo really means that that one dose was not given. And 98.6% of patients received treatment as planned per protocol, so that's listed as completed study treatment here. The most common reason for not receiving tocilizumab or placebo as planned was either safety related, so the patient progressed and it was felt by the investigator that it was not safe to give the blinded tocilizumab, or it was related to protocol violation or patient decision. So patient was randomized for the study, but then either the patient decided they didn't want to participate, or it was recognized that the patient did not meet all eligibility criteria. For remdesivir, 59% of patients completed study treatment, which sounds low, but the most common reason for patients not completing remdesivir was actually discharge from the hospital. So it was a good reason in a sense that the patients were doing much better and would discharge from the hospital. And per protocol, patients were not required to complete the 10-day treatment of remdesivir and could be discharged prior to the 10 days if they were stable and appropriate for discharge from the hospital. We did have 3.7% of patients who discontinued remdesivir due to death, and 11.1% of patients overall discontinued remdesivir due to an adverse event. Now, for the primary endpoint, time to hospital discharge or ready to discharge to day 28, the primary endpoint was not met. The median time was 14 days for both tocilizumab and placebo. The Cox proportional hazard ratio was 0.97 with a p-value of 0.74. I'm sharing here a number of subgroup analyses looking at demographics. And although there are some differences between the different subgroups, we do not see any specific subgroup that seem to derive greater or less benefit with tocilizumab treatment, and they generally look fairly similar. And also it's important to acknowledge that there are some very small subgroups here. Looking at subgroup analyses now by corticosteroid use, mechanical ventilation, and baseline ordinal score, it does appear that patients who were not on corticosteroids at baseline did worse with tocilizumab, as well as patients who were on mechanical ventilation at baseline and patients with ordinal score of 5 at baseline, which were patients who required mechanical ventilation but not additional organ support. So again, there is a suggestion here that those patients had worse outcome with tocilizumab treatment, but again, difficult to interpret because the sample sizes are small. Moving now to our secondary endpoint of time to mechanical ventilation or death to day 28, we did not see a difference between the tocilizumab and placebo arm. The median time was non-evaluable, and that's simply because we didn't have enough event to report a time to. But the Cox proportional hazards ratio was 0.98 with a p-value of 0.9. And now for time to death up to day 28. Again, the median time was non-evaluable, similar reason in that we just did not have enough events to report a time to, but the Cox proportional hazard ratio was 0.95 with a p-value of 0.79. And then in the table at the bottom of the slide here, I'm sharing the mortality, the actual percent of patients or proportion of patients at day 28 and day 60. For the tocilizumab arm, and I shared this also in the safety slide, 18.1% of patients in the tocilizumab arm died by day 28 versus 19.5% in the placebo arm. So that's a weighted difference of -1.3 with a p-value of 0.69. And for mortality at day 60, it's 22.6% of patients in the tocilizumab arm versus 25.7% of patients in placebo. And that's -3 for the weighted difference and a p-value of 0.39. Now moving to the safety overview, I apologize, this is a very busy slide, but we provided the overall safety overview here, as well as the list of adverse events of special interest that have been identified for tocilizumab. Overall, the safety profile looked balanced across the treatment arms, and there were no new safety signals. And for the adverse events of special interest, the events here were consistent with the known safety profile of tocilizumab and remdesivir. So I already shared the proportions for deaths in the previous slide. We had a very small number of patients who discontinued the study because of an adverse event, although I previously shared that a certain proportion of patients did discontinue study treatment because of an adverse event, and that was 10.7% versus 13.1% for tocilizumab versus the placebo arm. I will share more detail on infections on the next slide, but to note that we did not see an imbalance in bleeding events, stroke, or hepatic events, which of course is very important for the specific patient population. Now for the category of adverse events and serious infection and infestation, the most common serious infections were progression of underlying COVID-19 pneumonia. Per protocol, investigators did have to report COVID-19 progression as a serious adverse event if it resulted in death. And the other event terms were septic shock, pneumonia, sepsis, and bacterial pneumonia. Again, I'm listing just the most common event terms here, and we did not see any important imbalances between the tocilizumab and the placebo arm. In conclusion, tocilizumab and remdesivir treatment did not shorten time to hospital discharge or ready for discharge to day 28 compared with placebo plus remdesivir in patients with severe COVID-19 pneumonia, but it's also important to acknowledge that most of these patients were receiving systemic corticosteroids in addition to the protocol prescribed treatments. And serious infections were not more frequent with tocilizumab treatment, and no new safety signals were identified. And I'd like to end by saying thank you to our investigators, our study coordinators, and patients who participated in the study. Thank you for your attention.
Thank you, Dr. Olson, for a very interesting presentation, and I would like to welcome you back to answer questions and comments that are coming also from the audience. But before that, I would like to ask Giuseppe again to make a comment from an editorial perspective on this trial.
Okay, thank you, Maurizio. We discuss a lot about this trial internally in the journal because I think there are some points that we need to highlight, because we searched for more than 1 year the cure for the disease, and we tested, the trialists tested a lot of drugs, and at the end, when this paper did arrive, the standard of care was a little bit changed compared to what was at the beginning of this trial. And we consider also that if the negative result that has been presented today by the speaker, where the final outcome of this paper, the findings has been inserted also in the meta-analysis of WHO about the interleukin receptor antagonist. So we wanted to offer the possibility to have information about this trial, because it was not published till these days. And I would like also to have your comment, Julie, about what is the meaning of the trial today, knowing that the care did change over the last 18 months.
Yes, thank you very much. And let me just confirm that you can hear me.
Yeah, we can hear you well.
Perfect. Yeah, thank you for this opportunity to comment on the trial. I mean, one part to start with certainly is that the safety information gained from this trial is still very valuable. So naturally, there will be questions about the safety associated with giving tocilizumab in patients who are critically ill and on corticosteroid background therapy. And so it's very much encouraging that we did not see a difference in terms of the safety profile with tocilizumab versus placebo. I do think this trial also adds important information in terms of potential treatment benefit, but there are some limitations in terms of the patient population that we enrolled. So I don't know if you want to discuss that now or which part we should focus on.
Please carry on.
Maybe you can comment now on the population.
Yeah, well, I think, you know, in retrospect, you know, it would have been probably more helpful to focus more on a patient population similar to REMAP-CAP, meaning patients with the evidence of recent deterioration or rapid progression, and patients who have been recently hospitalized or recently moved to the ICU. So for this trial, I think it's very important to note that we did not require evidence of progression, and we didn't have any eligibility criteria related to you know, how recently the patients have been hospitalized, recent progression or deterioration. And I do think that is a major difference between our study and some of the other studies that did suggest a benefit with tocilizumab. And in retrospect, you know, we feel that that is the right patient population to focus on, the patients who are showing evidence of deterioration. And again, that was not a requirement for enrollment in the study.
Thank you. We have a lot of questions and comments also on the study design. For instance, why did you choose day 28 as an endpoint? Because severe cases are more likely to be still in the ICU at day 28. Did you look also for longer term outcomes, and are you doing some follow-up on that?
Yeah, so that's a great question. So, you know, we also considered looking at day 14. And so the day 28 is sort of a balancing act between trying to look early, but absolutely, as the person who's asking the question is alluding to, it may actually take longer than day 28 to see benefit in patients who are intubated and critically ill. So we decided to look at day 28 because we felt that this should be sufficient time to show a difference between the treatment groups. But we did follow patients to day 60. And I did share in one of the slides the mortality difference at day 28 and at day 60. And we did actually see a bigger difference in mortality at day 60 compared to day 28. And so that was a difference of -3% in favor of tocilizumab treatment. So absolutely, as the person is alluding to, you know, there are differences that we see at day 60 that were not observed at day 28.
And did you monitor any immunological variables to start tocilizumab, or this was a pragmatic approach just on severe COVID-19 patients?
It was very much based on clinical variables observed by the investigators.
And all of your patients has been exposed to corticosteroid, I think.
Yeah, it wasn't all patients, but it was greater than 80% in both groups. So it was the large majority of patients did receive corticosteroids.
Okay. I may ask a difficult question. We have to remind the audience that you have a conflict in the sense that you are an employee for Genentech. The first author is not here today, but you are kindly answering the questions. But if I look at this study, this trial, I would say that tocilizumab does not seem to work in severe COVID-19 patients and therefore shouldn't really be recommended. It's quite an expensive drug and not available everywhere. What's your view from what you can tell me about this?
Yeah, I think I touched on that already. And it really, our view is that tocilizumab should not be given to everybody with COVID-19 pneumonia. And that the focus really should be in line with some of the guidance, including the emergency use authorization that FDA has endorsed now, as well as the data coming out of REMAP-CAP. So focusing on patients with evidence of progression and recent decline. And absolutely, we're not proposing that tocilizumab should be given to everybody, focusing on patients with evidence of progression instead.
And if I understand correctly, you didn't have any difference in secondary infections between the two groups. Is this something that is being surprising you where you saw the results?
No, I wouldn't say that we're necessarily surprised by the results. Again, it's a single dose. There was an option to give a second dose if the investigator felt that it was warranted. But again, in this patient population, a single dose did not show any differences between the treatment groups. And I think it's important to note that I do think there was a thorough assessment by our investigators before they decided to enroll patients. So patients with evidence of infection at baseline were not eligible for the trial. And I do think all of our investigators did a great job of assessing patients to make sure that they were appropriate to enroll, so they were not being dosed with tocilizumab in the setting of active infection.
Okay, I think that we touch the main point of this article, and also the fact that probably selecting a more severe population or selecting a different criteria, the result and could be different. But this is life, and when we started during a pandemic, a trial, probably we want to try to find a solution, to find drugs for the patients, and sometimes we design the trial looking back in a way we would have preferred to do it differently, as you say to us.
And if I can just add to that, it's also very important that we see during this pandemic, seeing these negative trials being published in a timely fashion, because it's very important, specifically when we get confounding information, and that's very important to make the right decisions about treatment guidance. So thank you very much, Dr. Olson, and I would like to thank also Giuseppe for the time that you had with us in this Congress and all the research that with intensive care medicine you have brought these days. I'm going to break now this session, but we have a 10 minutes break, and then join me again, because I will be joined by Chris Seymour, Associate Editor of JAMA, for the grand finale of the Hot Topics.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. Hello and welcome back for our last session live, and I'm very, very happy to see Chris Seymour. Chris is an associate editor for critical care at JAMA. He's also a professor of critical care of University of Pittsburgh School of Medicine. He's a member in clinical research investigation, systems modeling and acute illness, CRISMA there. And we know all the research that Chris has been doing. And again, thank you very much to the JAMA family for being with us also this year, Chris.
Thank you so very much for having us join today. It's always fantastic to collaborate with ESICM and your leadership. So today's session is an exciting one for us. We have a new paper recently accepted at JAMA, and Professor Anders Perner will be presenting. This manuscript is entitled Effect of Dexamethasone 12 milligrams versus 6 milligrams on the number of days alive without life support in adults with COVID-19 and severe hypoxemia, called the COVID Steroid 2 randomized trial. Thank you all for joining.
So Anders, the stage is yours.
Hello, my name is Anders Perner. On behalf of the COVID Steroid 2 trial, I'm very honored and proud to present the results of the trial assessing dexamethasone 12 versus 6 milligrams for patients with COVID and severe hypoxia. The trial was done in 26 hospitals in Denmark, India, Sweden, and Switzerland as a collaborative initiative. It was funded by the Novo Nordisk Foundation and supported by Rigshospitalet. So obviously COVID-19 is still a global health challenge. These are just the number of weekly cases updated this week and the number of weekly deaths. And there's still globally a high burden from COVID-19. So early on, the use of dexamethasone was shown in the recovery trial to improve mortality on the left there in all hospitalized patients with COVID-19, and on the right, particularly so in those who were mechanically ventilated. At that time, we ran the first part of this trial, which was hydrocortisone versus placebo, which we obviously stopped once we knew the results of the recovery trial, as we had a group of sites and the full trial set up to continue to do a steroid trial. We asked out among the hospitals interested to participate what their use of corticosteroids was in COVID-19 with severe hypoxia, so after recovery. And as you see here, the vast majority of clinicians at those sites would use steroids for these patients. We also asked them, which trial would you prefer doing if we continue a steroid trial in these patients? And as you see here, most clinicians at the sites would do dexamethasone 6 versus 12 milligrams. And that became the COVID Steroid 2 trial, assessing the potential benefit. So the hypothesis was that the use of the higher dose would increase the number of days alive without life support, and that this may result in improved survival. Obviously, there could be harm associated with a higher dose, and this could lead to severe adverse reactions to steroids, which on the other hand could increase mortality in these patients, and therefore we felt there was an equipoise to do this trial. As I said, it's an international trial, parallel group, stratified, blinded, randomized trial. We enrolled 1,000 patients with severe hypoxemia to either 12 milligram or 6 milligram dexamethasone for up to 10 days. Patients were adults, had confirmed COVID-19, were in hospital, and used either invasive mechanical ventilation, non-invasive, or continuous CPAP for hypoxia, or 10 liters of oxygen on an open system more and more. And this was a pragmatic definition for the enrollment of patients with severe hypoxia. The trial was blinded, so trial staff prepared the trial medication from shelf drug at the pharmacy at the hospitals and delivered syringes with 5 milliliters of saline containing either 6 or 12 milligrams of dexamethasone to the clinical staff. This is the trial set up in the PICOT format, just to highlight the outcomes. So primary outcome was days alive without life support at day 28, and the secondary outcomes reported here is days alive without life support at day 90, days alive out of hospital, and mortality at day 90, and the occurrence of severe adverse reactions and mortality at day 28. Day 180 and quality of life will be reported later. This is the timeline of the trial. We've finished enrollment in 9 months. In those 9 months, we screened 1,414 patients, excluded some mainly due to patients have received steroids for COVID-19 for 5 days or more. Other patients had indications for higher dose steroid, and some patients could not consent. We randomized 1,000, as said, and analyzed 97% at day 90. So half of the patients were enrolled in Denmark, 1/3 in India, and the rest in Sweden and Switzerland. Most patients were enrolled in an intensive care unit, some in a normal hospital ward, fewer in an emergency department or HCU. The time from symptoms to hospitalizations was equal in the two groups, 7 days, and also equal days from hospitalization to randomizations was observed in the two groups being 2 days. The patients were, I guess, as expected, 65 years of age, mainly males, weighing 80 kilos. They had the known coexistent illnesses, being diabetes, ischemic heart disease or heart failure, and chronic obstructive pulmonary disease. So this is data on the use of oxygen at baseline. Half of the patients were on an open system, receiving median 23 liters of oxygen on that. A quarter was on non-invasive or CPAP with a FiO2 of 60% median, and 20% were invasively mechanically ventilated with an FiO2 of median 60. Of the co-interventions used at baseline, patients had received a median of 1 day of dexamethasone before randomization. The majority received remdesivir, and 10% received an IL-6 inhibitor. This is data on the use of trial medication during trial. We gave dexamethasone for median 7 days in the two groups, and only 2% in each group had open label steroid use during trial. As said, the primary outcome was days alive without life support at day 28, and these are the median days in the two groups, so 22 days alive without life support in the 12 milligram group and 20.5 days in the 6 milligram group. The primary analysis was one of the adjusted mean differences between the two groups, being 1.3 days with a confidence interval from 0.0 up to 2.6 days and a p-value of 6.6%. We tested the primary outcome in a number of pre-planned subgroup analysis listed here, and there was no statistically significant heterogeneity in either of these subgroups listed here. We also set days alive without life support at day 90. And here the adjusted mean difference was 4.4 days, favoring the 12 milligram group, but now the lower confidence interval crossed 0. Days alive without out of hospital at 90 days. So the median difference there look quite large, but the adjusted mean difference is 4 days. Again, the lower confidence interval crossed 0 because of multiple testing. We used 99% confidence intervals for the secondary outcome measures. These are the survival curves in the two groups, and the landmark mortality outcome was death at day 28, 27% in the 12 milligram group, 32% in the 6 milligram group, giving an adjusted absolute difference of 5%, with a 99% confidence interval ranging from -11. That's a fairly large mortality difference, up to 2% positive, so a slight increase in mortality. The same goes for 90-day mortality, 32 in the 12 milligram group versus 38 in the 6 milligram group. Again, an adjusted absolute difference of 5%, confidence interval ranging from a large mortality reduction with 12 milligram to a slight increase in mortality. Serious adverse reactions was a pre-planned outcome measure that was registered daily in the first 28 days. So these are the numbers of patients with one or more serious adverse reactions in the first 28 days. So 11% in the 12 milligram group, 13% in the 6 milligram group, adjusted mean difference of -2%. The specific reactions registers were these: septic shock, invasive fungal infection, and severe GI bleeding. We also obviously reported the spontaneous reporting of SAEs by the investigators, and if you add those to the serious adverse reactions, 21% had either a SAR or a SAE in the 12 milligram group versus 25% in the 6 milligram group. So to conclude, we did, I think it's fair to say, a high quality trial. So it's blinded, randomized trial, few violations. The vast majority of patients followed up, and we had 90-day follow-up. We enrolled patients in both Europe and in India, obviously representing different patients, risk factors, practice patterns, and healthcare system, which should increase the generalizability of the result. The sort of narrow statistical conclusion is that dexamethasone 12 versus 6 milligram did not lead to a statistical significant more days alive without life support at 28 days. There are some issues to discuss. I think overall there's little doubt that there's benefit from additional anti-inflammatory effect on top of that of 6 milligrams of dexamethasone, as has been shown with the use of IL-6 and JAK inhibitors. We think that the results of our trial are most compatible with an overall benefit of 12 versus 6 milligram based on the confidence intervals of most of the outcomes, and in particular of the primary outcome. We'll provide a pre-planned Bayesian analysis of these results. We collaborate with other trial groups to do a prospective meta-analysis on this question, and we'll obviously also provide the outcome data at day 180, being mortality and quality of life at a later stage. This was an amazing undertaking, I think. Big thanks to many people So the staff at the CRIC and the George Institute, both in Sydney and New Delhi, obviously all site investigators and research staff, patients and relatives, the clinical staffs who accepted a trial under very difficult circumstances, all sort of the auxiliary staffing, so monitors, those funding, doing all the legal business, ethics committee, medicines agency who approved the trial very fast, again, under difficult circumstances. I'm also happy, honored and proud to announce that the trial result report has been accepted as a publication in JAMA with this title. Thank you very much. I'll be happy now to discuss the result of the trial.
Thank you very much, Anders. And first of all, congratulations to you and all the research team and all the investigators. A massive undertaking, a trial of this magnitude, and during a pandemic, again, bringing further evidence on top of some great trials that we've seen recently. We are starting to receive some questions here in the chat and from social media, but maybe, Chris, you want to make a comment from an editorial perspective on the study?
Sure. So congratulations. Of course, I'd like to give mine to Anders and all of his research team. This is another example of a incredible effort during the pandemic to conduct a very high quality, rigorous trial, which we think is a really important clinical question. That first slide that we saw there about asking the clinicians and stakeholders where they would like the trial to pivot, I think is remarkable and helped place these findings firmly at the bedside. We've all been at the bedside and asked, should our patients receive a higher dose of steroids? Should they receive glucocorticoids for a longer duration? And are there potential risks for secondary infections? And so in that regard, this is very important data, and we're excited to share it with you today.
So if I can ask maybe the first question, we're receiving some from the audience, I think they're on the same line. Why did you choose to compare 6 and 12 and, for instance, not dexamethasone versus metriprednisolone, for instance?
I guess the short answer is that was what the clinician wanted in our survey. The more elaborated answer is that at least my personal expectations was that this present trial had the highest chance of showing benefit. The potential differences between different use of steroids would, in my opinion, again, likely require a much larger trial. In addition, at least some of us thought that the use of 6 milligrams of dexamethasone in the recovery trial was a fairly low dose, and that the steroid trials that ran at that time, all of them, at least in the ICU patients, used a higher dose. So I think there was many good points to why we did a higher dose trial.
Okay, and you say that there is no statistical difference, but the Kaplan-Meier curves are very interesting to see, and you are planning an a priori Bayesian analysis there. And in this sense, do you think that, how do you explain that there was no difference in secondary infections, for instance, between the two groups, or serious adverse events that almost seems higher in the 6 milligrams versus 12?
Yeah, I think that's very interesting, but sort of goes along the way with other steroid trials in the intensive care setting, those in septic shock and ARDS, and in general showing that at these doses in a reasonably short time, used in a short time period, they appear pretty safe. Some of the side effects that we look for clinically are syndromic, and steroids could potentially dampen some of this syndromic diagnosis, and therefore we potentially see less. But it's quite interesting, I think.
And again, down that line, do you think, of course it's only an hypothesis, but do you think that you would see a larger effect with a bigger population, or by increasing the separation of the exposures with a higher dose of steroids?
I think with a larger population, the effect would be statistically significant, I guess, as long as the point estimates remain the same. We did a lot of sensitivity analysis, and sort of the p-values in those sensitivity analysis fluctuate between 4% and 10%. So I think we're pretty close to sort of claiming statistical significance, and probably a larger trial would have shown this. That there is potential issue with the use of IL-6 inhibitors, which obviously only really took off in the later state of the trial, and only 100 patients were enrolled. And if anything, the point estimate of those who had an IL-6 inhibitor was neutral, or maybe even going the other way. So that's an alternative explanation.
Okay, thank you, Anders. Chris, do you want to ask a question?
Yeah, so the point you just brought up, Anders, I think is one on many of our minds, is how much sort of immune modulation is the right amount, not only at the beginning of sort of the COVID pneumonia, but even towards the tail end. And so, again, these are exploratory analyses, they're subgroups, and it was a small patient on IL-6 inhibitors. But if we're at the bedside of a patient who's already received TOSI, is a 12 milligram dose appropriate, or should this be reserved for patients that don't have tocilizumab or baricitinib already on board?
That's a very difficult question to answer, because our trial data cannot answer that directly. The sort of uncertain indications by that subgroup, as you will see in the publication once it is out, is that those who had received TOSI at baseline could have had a different intervention effect, but it was far from statistical significant because of the low power. I think it makes some kind of sense, and I think now guideline committee members and clinicians should discuss these data, and we will get more knowledge from the prospective meta-analysis and on the longer-term outcomes. Until then, I at least consider the use of the high-dose steroids. I would probably be less reluctant to do so in patients who had already received TOSI. But that's, speculations.
Sure. Thank you, Anders. We're getting some questions. Some questions are linked. Do you think it would make more sense to adjust the dose according to body weight? And linked to that, did you do any subgroup analysis, for instance, on BMI?
Yeah, we have already been asked that enough times to sort of have made the decision that we'll do that post hoc analysis. We choose to use a fixed dose because Recovery had used a fixed dose, and actually all other steroid trials done at the time of Recovery used fixed doses. But it's a good point, and we will look into it in the post hoc analysis.
Okay, and other comments and questions. We've seen some use which was against actually protocols of steroids sometimes at home, even before patients were admitted to the hospital. And unfortunately, it's a practice that is being reported worldwide. Do you have any data on that, on your group of patients, if patients were exposed to steroids before the study, basically?
No, so we had use of steroids in the days before. We didn't. I guess we can't pull data on where they were located. We haven't analyzed that. And medium, the steroid exposure was only 1 day, and the patients had been admitted for median 2 days. So if there is any, it's minor. I think, but we haven't looked into the details.
Thank you. Chris?
Yeah, I would actually be interested in your thoughts, Anders, to share a little more detail about how you characterized secondary infections. So it's an important risk of course, the more immune modulation we give, and suppression we give, that there'll be secondary bacterial infections. So I'm wondering if you could describe how you identified those in the trial, and your thoughts about that.
So we asked every day for investigators to register any new episode of septic shock. So that was our sort of main infectious criteria. And also we asked about invasive fungal infection being defined as either growth of fungi from a sterile site or positive markers, so candida DNA, for instance. Again, ask for that every day to try to improve the quality of these data. I said, in addition, there were on the side the standard more spontaneous reporting of SAEs, but again, from what we saw, there was no marked difference, and if anything, the occurrence of infections were lower in the higher dose group, which is a bit surprising.
And I guess it's a question that keeps coming. It's a clinical dilemma. After 10 days, a patient that does not improve, what should we do? Should we carry on with steroids or not? Clearly, this study was not made to answer that research question, but do you have in the follow-up any group of patients that actually had an extended period, maybe with a protocol violation? I don't know. And do you think it's something that we should explore?
It should definitely be explored, and we will. For the patients we have access, where we have access to their files and the authority to look into it, we will look for that. We didn't register it after day 10. We didn't register the use of steroids, so we don't have the data in the trial database. But we will try and look in the data sources that we have, because it's very important now.
Okay, and then I think I can summarize some of the questions. I think you alluded to already a little bit, but maybe you can state it even more clearly. How's your practice at the moment? What do you do?
So we wait for basically for the infectious disease docs and the ICU community to update the guidelines. For now, I think that some of us at least place tocilizumab and higher dose steroids sort of equally. So if there are any patient's characteristics, or if toci is unavailable, I at least personally, and I think also many of my colleagues would use the higher dose steroids instead. If toci is available, I think many would do that.
I guess it's one of the difficult things during a pandemic, accumulating evidence, and also often we have to test one drug at a time, even if there are some examples like RIMAP-CAP where you may try to see different domains. We have 2 minutes and a half to go. Chris, comments or questions from your side?
Yeah, so this is maybe a little bit informal, but I like to ask expert trialists like yourself, Anders, what would you have done differently? So in the design of the trial, during a pandemic, looking back, what changes might you have made, either to the population, the intervention, or outcome, et cetera?
I think we've learned a lot from RIMAP-CAP, and I think it may be the last time that I design a frequencistic trial, because I'm really annoyed about this discussion about the p-value, so that these results, which we think are important, are clouded by this p-value of 6.6% for the primary outcome. So either stated clearly in the protocol that we will not make inferences based on p-values but only on confidence intervals, or been doing from the start a Bayesian sort of framework, and potentially, as they do in RIMAP-CAP, stop at some specific marker for benefit, futility, or harm.
Oh, thank you. Maybe, Chris, from an editorial perspective, is that the type of studies that you are seeing coming more and more to JAMA?
I think so. I mean, it's definitely a difficult nuance when there's a clinical effect that we think we see, but statistically, the numbers don't line up. Of course, the response adaptive randomization and the study designs that Anders have described have gained a lot of traction during the pandemic because of their ability perhaps to find answers quicker, and certainly look forward to more of those in our field.
Okay, I think it's time to move on, but before that, Anders, again, thank you very much for presenting the results for the first time here. It's been a real honor for us, and congratulations again to you for leading this very important research, and I'm sure it will not be the last one that we see from your group during the pandemic.
Yeah, I think you should thank the investigators, patients, relatives, and clinicians as well. That's what I would do. Thanks a million for the discussion and the opportunity.
Thank you. Okay, Chris, up to you for the next study. I think you are on.
Yeah, thank you, Richard. Yes, so next, our next paper is from Professor Angelique Dement, and she's here to discuss her manuscript that was recently released in JAMA addressing high and low oxygen targets in patients with systemic inflammation. Professor Dement, take it away.
Good afternoon. My name is Angelique Dement. I'm an intensivist at the Amsterdam University Medical Center's location VU Medical Center in the Netherlands. And I'm very honored to present to you today the results of our trial investigating the effect of 2 different oxygenation targets in critically ill patients. We were very grateful and very proud that after a very thorough review process, our manuscript was accepted for publication in JAMA. I have no conflicts of interest, and our trial would not have been possible without the funding of the Netherlands Organization for Health Research and Development. Since 2008, several observational studies investigated the impact of oxygenation on mortality, and all these studies showed a U-shaped relation between PaO2 levels and mortality, and the nadir of these curves appears to be in the mild hyperoxemic range. So all of us are well aware of the potential risks of hypoxia, which can lead to pulmonary hypertension, but also to tissue hypoxia. In the last decade, many physicians are also increasingly aware of potential negative effects of hyperoxia, which can lead to systemic vasoconstriction, increased oxidative stress, and also pulmonary toxicity. And whereas it's not always possible to prevent or treat hypoxia for the treating physicians, it is always possible to prevent hyperoxia because it's a direct result of superfluous administration of oxygen by the attending physicians or nurses. And the achieved PaO2 levels are very relevant because the difference between PaO2 in the arteries and in the cells is the direct driving force for oxygen diffusion. And we know that small increases in SpO2 levels coincide with large increases in PaO2 levels. Since these observational studies, there also have been performed several RCTs, and I will come back to these trials later during the discussion. And our trial differed from these other trials because our trial was PaO2 guided, whereas many of the other trials were SpO2 guided. We had an upper limit of applied FiO2 of 0.6, so we did not increase the FiO2 above this level just to achieve the oxygen targets, but only on clinical indication. And furthermore, we focused on patients with SIRS, and these patients might have potential benefit from the hyperoxia-induced systemic vasoconstriction because of the SIRS-induced vasoplegia. So the aim of our trial was to investigate whether a low normal PaO2 target could lead to improved organ function in critically ill patients with SIRS. We included 400 patients, and all these patients had at least 2 or more positive SIRS criteria and an expected stay of more than 48 hours. We included patients in 4 different locations in the Netherlands. We aimed in the low normal group at a PO2 target of 8 to 12, whereas we aimed in the high normal group at a PO2 range between 14 and 18. We used a novel primary endpoint, the SOFA rank score. This is a ranking based on the non-respiratory cumulative daily delta score up to day 14. Discharge was counted from the day of discharge forward as a score of 0, whereas death was counted from the day of death forward as a maximum score of 20. And the resulting cumulative daily delta score was used to rank all the participants from fast organ failure improvement, so the lowest, most negative scores, to worsening organ failure and death, the highest, most positive scores. I will give you now several examples of the calculation of this primary endpoint. For example, patient A. This patient survived till day 14 with early improvement of organ dysfunction. We can see here the daily SOFA scores. Subsequently, we subtracted the baseline SOFA score from the daily SOFA scores, and we added all these scores up together, which led to a SOFA rank score of -58. Patient B survived till day 14 with stable organ dysfunction. We can see here that we subtracted baseline SOFA scores from the daily SOFA scores, and the cumulative score was 2. Patient C survived till day 14 with increasing organ dysfunction. This led to a SOFA rank score of 35. And finally, patient D, he died on day 8. So from day 8, he had a daily SOFA score of 20, which was the maximum non-respiratory SOFA score. And we subtracted the baseline SOFA scores from these scores, and this led to a cumulative score of 131. Subsequently, we ranked all the included patients, and we compared both groups with the Wilkinson rank sum test. So the SOFA rank score captures the treatment effect on mortality and organ dysfunction, whereas it avoids competing risks and survivorship bias. So it answers the question which group is better off. However, the value of SOFA rank is not directly clinically interpretable. So what are the results of our trial? We achieved a statistically significant difference in PaO2. So the median PaO2 difference in the high normal group was 1.9 kilopascal higher compared to the low normal group. With regard to our primary endpoint, we saw that in the low normal PaO2 target group, these patients had more organ dysfunction and or faster deterioration, as you can see here based on the SOFA rank score. And however, the difference with the high normal group was not statistically significant with a p-value of 0.06. With regard to other endpoints, there was not a statistically significant difference between other SOFA-based scores. And in addition, there was not a statistically significant difference in duration of mechanical ventilation, in ventilator-free days, or length of ICU stay. And also with regard to to mortality, there was not a statistically significant difference. Our patients in the low normal group had significantly more mild hypoxemic periods, 1.9% compared to 1.2%. There was not a significant difference in severe hypoxemic periods. So recently, there was a very interesting meta-analysis published, which was performed by Chen et al. He included all the important RCTs performed in the last decade. And he divided these RCTs in studies in which patients with severe hypoxemia were excluded, and in studies in which patients with severe hypoxemia were included. The studies which excluded these patients were mostly the older trials. So as we can see here, in these trials, there was a lower mortality in the conservative group. However, in the more recent trial in which these patients were included, there was not a statistically significant difference in mortality. In our trial, we excluded patients with severe hypoxemia. However, we did not find a significant difference, but if there was a difference, it was in the opposite direction compared to the studies of Asfar and Girardis. And there was also another very interesting meta-analysis performed by Zhao et al. They divided all the RCTs in 4 groups. They did not include the most recent hot ICU study. The far conservative goal was defined as PO2 values of 55 to 70, the conservative goal 70 to 90, the moderate goal 90 to 150, and the liberal goal more than 150. And as we can see here, the survival curves were better for the conservative and moderate goal compared to the far conservative and the liberal goal. So in our trial, we showed improved resolution of non-respiratory organ failure in the high normal group compared to the low normal group, but this difference was not statistically significant. The opposite trend compared to the other trials from Girardis and Asfar might be caused because we focused on patients with SIRS and hyperoxemia-induced systemic vasoconstriction might have counterbalanced cis-induced vasoplegia. In addition, we limited FiO2 levels to 0.6, which might have minimized potential pulmonary toxicity. So the strength of our study was that we used a novel primary endpoint, the SOFA rank score. And in addition, the participating centers were both academic and non-academic hospitals. And all these sites were frequently monitored by independent quality officers. Limitations of our study was that short episodes of higher FiO2 were allowed during interventions, and in addition, the PaO2 levels before inclusion, these both factors might have attenuated treatment contrast. Furthermore, because our FiO2 was not increased above 0.6 only on clinical indications, and because of this, the median PaO2 value in the high normal group was below the target range. So, in conclusion, among critically ill patients with SIRS, treatment with low normal PO2 target did not result in a statistically significant reduction of organ dysfunction. The effect of hyperoxemia is likely smaller than has been hypothesized, or it is present only at more extreme values of hyperoxemia or only in subgroups. So with this, I would like to thank our research group at location VUMC and all the other participating hospitals. And I would like especially thank Harry Gelissen, who performed a lot of work for this trial, and also Harm-Jan de Groot, who conceptualized our primary endpoint. Thank you for your attention.
Angelique, thank you very much for your presentation and congratulations on a very important study and a great publication in JAMA. I think, Chris, we are joined by Martin Urner, an intensivist at the Medical Surgical ICU at the Toronto General Hospital and an expert on advanced methods for causal inference in longitudinal data mechanically ventilated patients. Hi, Martin. I think you're on mute. Now we can hear you. It's okay.
Thank you very much for having me.
I think, Chris, maybe we can start with a comment from Martin on the study.
That would be great. He wrote a fantastic editorial with Carolyn Calfee and Eddie Fan, which was published simultaneously with the paper. So absolutely, Martin.
Okay, I briefly try to share my screen. Do you see my screen?
No.
Now?
Not yet. Now we can. Yes, now it's good.
Perfect. So thank you very much for having me and for allowing me to give a comment about this fantastic trial. As Professor Deman already mentioned, it all started with a large observational study from the young involving 36,000 patients reporting a U-shaped relationship between PaO2 and in-hospital mortality. And to give some context, subsequently a series of randomized controlled trials started aiming at finding optimal targets for treatment with supplemental oxygen. Potentially harmful effects of hyperoxemia and hyperoxia on mortality have been supported by the oxygen ICU, by the high-pressed OS, and at least in the subgroup analysis in the ICU ROX trial. So tolibral was associated with a higher mortality. On the other hand, the local 2 trial demonstrated that too low oxygen targets were associated with mesenteric ischemia, so too conservative might be harmful as well. The last big trial, the hot ICU trial, did not show differences in terms of 90-day mortality or adverse events. And as illustrated below, and Professor Deman mentioned that there is some uncertainty which physiological variable should be the target for oxygen treatment. And we are currently awaiting the results from the UK ROX and the Mega ROX trial, enrolling 16,500 and 40,000 patients, powered to detect 1.5 absolute risk difference in mortality, and this is the context, the bigger context of the trial. And I think this trial is particularly interesting for 2 reasons. The authors use strategies to address small effect sizes, a very common problem in critical care trials, and these 2 strategies are first enrichment. They selected patients with SIRS who particularly benefit from the hypothesized vasoconstrictive and antimicrobial effects of supplemental oxygen. And furthermore, they also introduced a novel primary outcome, this SOFA rank score, which is a surrogate outcome and has been calculated based on daily delta non-respiratory SOFA scores. What are the characteristics of a good surrogate outcome variable? It needs to be easily measurable, treatment responsive, and consistently associated with a patient important outcome like mortality. The limitations, the SOFA rank score, the outcome in this trial is not straightforward to interpret. It's very hard to know what the value of -30 actually means. And also it's a change score. It basically consists from, the SOFA score itself consists from very different components. And the SOFA rank score basically combines with the same way the change in platelets with very different events like discharge or deaths. And finally, during the COVID-19 pandemic, we learned that the SOFA score itself did not predict the outcome of our patients that well, which somehow raises questions about the treatment responsiveness of the surrogate outcome. This paper has also been published in JAMA. Nevertheless, it's a very elegant trial because it illustrates how 2 concepts, enrichment and surrogate outcomes, might be used to approach this problem of small effect sizes in critical care trials. And Professor Deman and colleagues definitely showed us a very innovative way to move the field forward. And with regard to the optimal treatment strategy with supplemental oxygen, I think we probably have to wait for the results of the UK ROPS and the MEGA ROPS trial. Thank you very much.
Thank you, Martin, and thank you all. And I think we have some questions coming up from the audience. I am reading the first one, Angelique. There is a question about PO2 and saturation. Why did you choose one instead of saturation, considering that the saturation is more important regarding oxygen transport to the cell? Maybe you can comment on that and a bit more on the biological plausibility of your hypothesis.
Okay. First, I would like to emphasize it's Dr. Deman, not Professor Deman, so that's good to know. Second, I would like to thank both Professor Seymour and also Professor Erner for their very thorough review process and a very nice editorial. I would like to come back on the slides later, but first I will answer the question about PO2 and SpO2. Well, as you all know, is the oxygen dissociation curve has an S shape, and therefore small differences in SpO2 can coincide with large differences in PO2. And PO2, the difference between the PO2 value in the arteries and the tissue is actually the driving force for oxygen diffusion. Furthermore, SpO2 is sometimes cannot be properly measured in patients with hypoperfusion, and also there can be racial differences in Black patients. Sometimes the SpO2 values are not reliable, and there is a higher number of hypoxic periods which go undetected in Black patients. So that's for the SpO2 and the PO2, but if it's all right, I would like to come back to the slides of Martin Erner. Is it possible to share the screen again? Could you go back on the slide for reliable outcome parameter?
Yes, try to go back in a second. This one, or?
I think we need to see your screen shared first.
Do you see the screen?
Well, anyhow, as you mentioned, a good surrogate endpoint must be easily to measure. It has to be treatment responsive, and also it should be consistently and strongly associated with a patient-important outcome, such as mortality. However, Harm-Jan de Groot, my colleague who conceptualized the primary outcome of SOFA-RANK, performed a very interesting study in 2017 in critical care, and he evaluated 87 RCTs and investigated the association of several SOFA-RANK outcome measures with mortality. And he showed that especially delta SOFA, even more than a fixed day SOFA score, was strongly associated and also consistently associated with mortality. In addition, as most of the ICUs already register the SOFA scores, I think our outcome parameter is a very good surrogate outcome parameter because it's easy to measure, it's already been registered, and it's treatment responsive because he showed in a study that treatment effects on delta SOFA score were reliably and consistently associated with mortality in RCTs. And I think therefore it's one of the reasons that we actually chose for SOFA-RANK as a surrogate outcome parameter. And one of the pitfalls of SOFA is that patients who die early before, for example, the fixed day SOFA or delta SOFA score, when the delta is measured on after 72 hours, when they die before 72 hours,
then you have to compensate for these patients. For example, in the Citrus Ali study, these patients were just left out of the primary analysis, which was a huge pitfall. So I think we thought about this primary endpoint very thorough, and I think it has less pitfalls than you might think.
Thank you. Angelique, there is a practical question. How does this reflect to your practice, these results? How do you bring them to your bedside practice?
Well, at this moment, we mostly aim for normal values, for normal PO2 values, and we definitely avoid the far conservative range, but we also avoid very high PO2 values. So I think between 70 and 140 millimeters of mercury, about the same as the meta-analysis of Zhao et al.
Thank you. Chris, maybe from an editorial perspective, I'm becoming more confused because we started to see treatments separation, and we used to think that maybe conservative was better, and then we do large trials and it's going back to normal, to where it was. What's happening? Is it just that the quality of care is getting better in general? Before, in the previous sessions, we had presented a study about debundling chlorhexidine from VAP bundles and without really any effects there. Any comment on this?
Well, I think we're seeing an interesting evolution of the data around this topic. Martin has nicely gone through some of the prior trials, and we have some very large trials forthcoming. At JAMA, we were interested in this paper in part because it keeps our conversation going, and again shows us that we don't really have all the nuance around the best titration of oxygen. I think we were very intrigued by the use of PaO2 to target the protocols, as well as reasonable separation between the two arms in terms of the treatment strategy. SOFA rank, it's hard for clinicians. We've had a nice discussion here about its role as a surrogate, and we look forward to results that will come from larger trials in the future.
Yeah. Okay. Anyway, it's reassuring to know that being normal is okay as a target, but can you maybe elaborate based on what you're seeing, and maybe are you planning further analysis to see if there could be any subgroup of patients where you would consider exploring further research questions or further trials with a conservative or more liberal?
Well, I think it's important. We already had 2 invitations for meta-analysis, and I think it's important that all these trials will be analyzed in meta-analysis, and maybe also on using individual patient data. I think that would be very interesting, and evaluating all the subgroups from all the trials together. However, which is a big problem is that many trials use different oxygenation targets. So it's very difficult to compare several groups. In the meta-analysis of Zhao et al., they did a very nice effort to divide these patients in 4 different groups. But for example, in the meta-analysis of Chu et al., they just analyzed low with high oxygenation targets, and sometimes the patients which were in the study in the high group had actually targets which were low in another study. So, well, I think it would be great if we have a more homogeneous oxygenation targets so that we can compare the different trials.
Thank you, Angelica. Martin, maybe you want to make a comment there?
Yeah, I think the SOFA rank score, HIV doctors basically have the CD4 count, and this trial is remarkable because it basically has the ambitious idea to bring the intensivists their CD4 count as the SOFA rank score, and I think we first need to see in future trials whether interventions on this SOFA rank score actually transform into better outcomes. And in the meanwhile, we probably should not overtreat patients and aim for aim for a normalization of all levels.
Thank you, Martin. Angelique, thank you so much. Congratulations again on this very important research to you and to all the research team, and thank you for being with us today.
Thank you very much. Thank you all.
Chris, last but not least, our next paper and next study to discuss.
Yes, so we'll finish today this fantastic session with data from South America. In fact, this is going to be a discussion of the BASICS trial, effects of balanced solutions versus saline, of two different infusion speeds on outcome of critically ill patients. And Fernando Zampieri will be presenting these data. Welcome, Fernando.
Hello, thank you very much for the opportunity to present the results of the BASICS trial here at Alliance. My name is Fernando Zampieri. I'm a critical care physician from São Paulo, Brazil. It is a pleasure to be here with you today. So I'm going to go through the results of the BASICS trial. As my conflicts of interest and acknowledgement, the BASICS trial was funded by the Brazilian Ministry of Health, but he received logistics support from Baxter Hospitalar that supplied the fluids and the logistics for the trial, but that was not otherwise involved in trial design, analysis, and this report the results. My other conflicts of interest are reported in this slide, and I'd like to thank very much all patients, their families, and all the sites that believed in such a large trial, and HCOR team for their outstanding support running this clinical trial. So BASICS was designed to answer two different relevant questions regarding fluid therapy in critically ill patients, mostly whether balanced solutions would result in important and meaningful clinical benefits for ICU patients regarding especially mortality and acute kidney injury, and also whether different infusion rates when patients needed fluid challenges would result also in meaningful outcomes regarding mortality and other secondary endpoints. So reasons for this was before BASICS we had some evidence from other large cluster trials, but no individually randomized trials checking whether the balanced solutions would provide a meaningful benefit. So one was a split trial, which was neutral for a need for renal replacement therapy, and the other was a SMART trial, which provided a positive result favoring balanced solutions when using a composite endpoint of mortality, need for renal replacement therapy, or doubling of creatinine at 30 days. So, but we did not have any large individually randomized trial, and BASICS was made to fill this gap. Additionally, we had no information regarding whether different infusion speeds would be meaningful for critically ill patients. There's a huge variation in care here. And we know from the FIT trial from Caitlin Maitland that was published more than 10 years ago that assessed whether bolus versus non-bolus would make a difference for children with sepsis. This trial provided results that suggested that use of fluid bolus was related to more cardiovascular collapse and cardiovascular death in children with sepsis. So, of course, this calls for a more, let's say, profound understanding on the reasons why fluid therapy can affect outcome, and fluid composition is one part, is a part of it, but how we infuse fluids, especially infusion rate, may also be important to determine outcomes in this population. So BASICS was a blinded, at least for fluid type, not for infusion rate, factorial multicenter individually randomized clinical trial in Brazil, where we randomized 11,000 patients to receive either Plasma-Lyte 148, which is a balanced solution, or saline for all fluid therapy in the ICU. I'm going to go through this in the next slides, and to receive either a fast or a slow infusion rate when patients needed fluid bolus. And by fast or control, we mean 999 mLs per hour, which means half a liter would be given in half an hour for these patients, which was the standard of care in Brazil and was pretty common according to the FINIS study. And a lower infusion rate, which we hypothesized that would be beneficial for patients, that was defined as a third of that, because slower speeds than 332 will probably not be seen as a full challenge. And of course, we had to create a gradient between the two different speeds. Of course, this arm was not blinded. We included, the study was designed to include a large number of critically ill patients, so we included all patients that were admitted to the ICU and were expected to require at least one fluid expansion, one fluid dose, that were not expected to be discharged the day after ICU admission, and that had at least one risk factor for poor outcome or for acute kidney injury, including age, need for vasopressors or mechanical ventilation or non-ventilation, sepsis, AKI at baseline, liver failure, etc. And we excluded patients that were already using renal replacement therapy or that were admitted to the ICU specifically to do or to receive renal replacement therapy. We excluded patients that had very severe electrolyte abnormalities, like very low sodium or very high sodium, and patients where the physician was not compromised with a full code practice, or patients that were previously enrolled in the trial. So this is a flow chart for BASIC. So the attending physician indicated fluid. So if it was fluid for a fluid challenge, then the patient received the assigned fluid, and binding was made using 6 different letters. And the patient received the study fluid at the assigned infusion speed. If the fluid was for maintenance, then the patient received the study fluid in the desired volume for maintenance. The use of other fluids were free. And for dilutions, if the patients required to receive a dilution that was above 100 mLs, and the drug was compatible with both saline and plasma-like, then the patient received the drug in the study fluid. Otherwise, the patient received the drug in the standard user fluid, and all dilutions up to 100 mLs were free, and we encourage using of glucose whenever possible. So this was how the fluids were supplied. So it was absolutely identical bags, a 500 mLs bag that was supplied by Baxter. And we had 6 letters from A to F, half were plasma-like, half were normal saline. We did not know which were which, neither did the sites. And when the study finished, we queried the sites to know if they could guess which letter were which, and they could not. So it was almost, they were almost as good as flipping a coin for each fluid group. So the primary endpoint for the trial was 90-day mortality, and this was obtained through a central blinded assessment at age score. And the primary analysis was a fluidity model adjusted for age, admission type, SOFA score, and enrolling site at ICU admission. We had several secondary endpoints, including need for renal replacement therapy up to 90 days, recurrence of AKI using KDIGO greater or equal than 2 at grades 3 and 7, SOFA score and its components, and mechanical ventilation 3 days, and several tertiary exploratory endpoints as ICU mortality or hospital mortality. We had prepared several subgroup analyses, including patients with or without sepsis, with or without TBI, with or without acute kidney injury at enrollment, surgical versus non-surgical patients according to a PASH-2 score, and according to whether the patient got more or less than 1 liter of saline before enrollment, because use of fluids before enrollment could affect the results of the trial. The trial was designed to have close to 90% power to detect a 3.5 absolute relative risk reduction from 35 to 31.5 with an alpha of 0.05. We did not consider interaction between the 2 interventions in the trial, but we were nevertheless well powered to detect a meaningful interaction in this study. So the results for the fluid type. So we randomized 11,052 patients, and for the fluid type here, we had some post-randomization exclusions, which were mostly due to removal of the consent from the patients, where we allowed on the basis that patients could be consent after enrollment, but some patients refused to participate, and then we ended up with 5,230 patients in one arm and 5,290 patients in the other arm. We had a minor loss of a follow-up, so 50 patients in one arm and 10 patients were allowed to follow up in the other arm. Patients were around 60 years old, so close to half the patients were surgical patients. They had a SOFA score of around 4 at enrollment. Around 19% had sepsis, 5% had TBI, 60% had hypotension or were using vasopressors. One thing that is important, around 70% of all patients got some fluid before enrollment, but it was around 1 liter, median use of fluid. And the use of the food study was pretty good in the first day. So it was around 80% of all fluids patients got in the first day, and 65 in the second day were the study fluids. And we had, of course, some contamination from open crystallized and other fluids. And this resulted in a gradient of chloride of around 3 max per liter, which is very similar to the results of the SMART trial. For the primary endpoint basics, we had a neutral result. So the curves here are almost overlapping. So there were no detectable differences between plasma-like and normal saline regarding 90 days mortality. When you go for the subgroups, so most subgroups were also neutral, except for the TBI subgroup, where we could not rule out an important harm for plasma-like in these populations with a hazard ratio close to 1.48 with wide confidence intervals, the small subgroup, but nevertheless a very concerning aspect of the trial. We also found no difference regarding our key, let's say, secondary endpoints, especially acute renal failure, need for dialysis or AKI, and we explored in the paper and the supplementary material several definitions. So there are no absolutely detectable difference regarding dialysis or AKI. And now for the results for the infusion rate. So this flow chart is pretty similar. We ended up with also 5,200 something patients in each arm in this trial. Adherence to fluid bolus was very good. So most of the patients received all the fluid bolus in the assigned speed. So it was around 90% and over 95% for almost all days where we checked it, adherence to the treatment. And around 75%, let's say 3/4 of all fluids the patients got the first day were given as a fluid bolus. And of course, these decreased over time in days 2, 3, and 7. And that makes sense. We all know that most of the fluid bolus occurs early in critical care and not after several days. Regarding the primary endpoint, which was similar to the other arm, we also had a neutral result here with our hazard ratio of 1.03 for infusion speeds. And we had absolutely no difference. We could not find any difference, let's say, in all subgroups that were assessed. Of course, in the infusion rate, we had, and in the balanced solution group, of course, it was a very large trial, and we had several secondary endpoints, and some of them turned out to be, let's say, positive, with a 95% confidence interval that did not include the unit. For example, in infusion rate, patients that got a slower infusion speed were less prone to require vasopressors at day 3, but not at day 7, and they also were less frequently had a PO2 over VO2 ratio below 200 when they were mechanically ventilated at day 3, which might be considered irrelevant by some, but all these differences vanished at day 7, and they were not associated with any other patient-centered outcome here. So in brief, for the fluid type, we had neutral results for the primary endpoint, no detectable effects on AKI or need for renal replacement therapy. We had a very important signal of harm for patients with TBI, and all the other secondary endpoints, and we had several in the paper, had unclear clinical meaning, but none of them actually favored balanced solutions in this trial. And for the infusion rates, we had a neutral results for the primary endpoint, and we had some, let's say, positive results that favored infusion speed, but they are, of course, of uncertain clinical significance, and they are very marginal because they occurred at day 3, but they were not sustained at day 7. But this is just to say that perhaps we should also consider running further trials on this and understanding a little bit better how we do and how fast we give fluids to the patient, perhaps even earlier or before ICU admission. So I would like to thank you very much for the opportunity to present the trial. I'm free for questions. Thank you very much.
Thank you very much, Fernando. Congratulations again on a very important study. 2 studies actually in one, and really fantastic results. And welcome Craig Coppersmith, a friend of our society and also a past president of the Society of Critical Care Medicine. Maybe, Chris, we can start with a comment from Craig on this study.
Yeah, so Professor Cooper-Smith also published a fantastic editorial with his colleagues at Emory University with the BASICS trials, one editorial piece for both trials. Craig, why don't you let us know your thoughts?
Thank you, and I'm honored to be here. And I do want to give credit to my co-editorialist, Michael Connor, who's both an intensivist and a nephrologist at Emory. So this is a great study. I want to start out with the fact that this is a great study. There's over 10,000 patients in the study, and it's in 75 different ICUs. The capacity to do a 75 ICU, 10,000 patient study is remarkable. And before I say anything else, I want to congratulate the investigators on really doing a remarkable study. And I think it gives us a lot of information within the context of patients who got modest amounts of fluid resuscitation. I don't think it gives us as much information on patients who require large amounts of fluid resuscitation. So as Professor Zampieri talked about, the amount of fluids that patients got on average in the first day was 1.2 liters. And over the course of 3 days was 2.9 liters. So if we take the two studies separately, on the slower versus faster infusion rate, despite the fact that half the patients were surgical patients, only 1 liter or 1.2 liters of fluid was given in the first day. And I think the study shows that if you're giving a relatively small to modest amount of fluid, that even though there's theoretical benefits for either giving slower or faster fluids, it doesn't make any difference towards outcomes. This doesn't tell us what we might see in a patient who requires a large volume of resuscitation. I'm not talking about a hemorrhagic shock patient here, but if we have a post-surgical patient with very, very large insensible losses and continued ongoing insensible losses who needs 5 liters or 7 liters for the first day, I'm not sure the study tells us whether a slow versus a fast rate makes a difference. But for somebody who needs a modest amount of fluid, it does, and there's no difference. As far as the type of fluids, we already talked about the SPLIT trial and the SMART trial, which were previously different. One showing a benefit for balanced crystalloids, one showing no difference in balanced crystalloids. And this showed no difference. Again, I think it gets back to the point of importance. Totally, over the course of 3 days, a little bit under 3 liters of fluid given, so an average of less than a liter of fluid a day. 2/3 of the patients got fluid prior to enrollment in the study, and 1/3 of the patients got over a liter of fluid prior to enrollment in the study, which obviously can dilute out the study impact. And Professor Zampieri showed that there is a difference in the chloride levels between the basic balanced saline, the balanced solution and the saline group, but it was modest. And that goes along with the fact that it was a modest amount of fluid that was given. And so what I would conclude from this is if somebody gives a modest amount of fluid, a liter a day for a couple of days, does it make a difference? Absolutely not. There was no difference at all. Again, when somebody who would need a larger amount of fluid, where you might expect to see the difference in chloride levels, where you might expect to see the hyperchloremic metabolic acidosis in patients who receive normal saline, might there be a difference? There might. The study really wasn't designed to show that. And although, again, I want to, congratulate because this truly was an extraordinary study, it's really not possible to do this without patients getting fluids in advance unless you also randomize a patient the second they get during the emergency room or on the floor. And because 2/3 of patients got fluid before they were enrolled and 1/3 of patients got a fluid, more than a liter of fluid before they were enrolled, that can easily dilute out the effect. The last thing I'd like to say before we move to the panel discussion is, while there were numerous secondary endpoints, I do want to reiterate what Professor Zampieri said about the traumatic brain injury data comparing normal saline to balanced crystalloids. Understanding that a secondary endpoint is not the primary endpoint and it might be construed as being hypothesis generating, there was a very clear signal towards a mortality increase in patients who received balanced crystalloids as opposed to normal saline. And even though it was a secondary endpoint, it was a very significant, it didn't cross midline, it didn't come across the midline. And I would say that that would certainly, in my own practice, I would not give somebody balanced crystalloids with a TBI, understanding that a further well-done study might need to be done. I think this was convincing enough as we've discussed statistics in the last two talks, that this would suggest to me that we should be giving preferentially normal saline over balanced crystalloids in patients with TBI. And with that, again, I'd just like to congratulate the authors for a fantastic study, and perhaps we can discuss it as a group.
Thank you, Craig. Very insightful comments. We have a lot of comments coming from the chat. Maybe the first one I'm reading relates to what Craig said about traumatic brain injury. Fernando, can you comment, in this group of patients, were patients giving normal saline or hypertonic saline something to increase the osmolarity anyway on top of the study fluids?
Yeah, so thank you very much for an opportunity to present the trial. So what we have in basics, regarding data we have in basics, we have only fluid use in the baseline before randomization, and then fluid use in the ICU. We did not collect data on hypertonic saline and other things, so it was allowed to use in all groups, so it was allowed, but we don't have actually data on how many patients use the hypertonic saline to correct the abnormalities. But the TBI signal here is very important, as Professor Coppersmith mentioned, and it's aligned, if you have a look into the results in the SMART trial, all the point estimates for TBI group favored saline, actually, so it was not significant as we have discussed before, but it favors saline, and basics, again, say that it's probably not safe to give to TBI patients. And that's so concerning. For example, the PLAS investigators did not even actually allow the enrollment of TBI patients in the trial because they were concerned about safety. And now we can say that they were probably right to do so. But by the time basics was designed, it was not, clear and we did not have a clear answer for that. And of course, plasma light actually has a normal osmolarity, right? So over 290. So there were no reasons to believe that specifically plasma light would be associated with worse outcomes there. Perhaps that's different for lactate and ringer, of course. But again, I don't even know if now we have equipoise to run another trial on that very specific subgroup. So perhaps it's time to wait for the IPDMA we are planning with all the trials. And that's ongoing now, so perhaps we have to wait for all data to be branded and to see what comes out of it before moving on that. But that's one of the most interesting findings in basics, and perhaps the most practice-changing findings in the trial.
Thank you, Fernando. Chris, comments, questions?
Sure. So congrats again, Fernando, to the BRICnet, to the basic trial investigators, and for all the work that went into this trial. At JAMA, we're certainly excited to have this data. We know we worked with you for quite some time to make it happen, and we had a great discussion. Is this one paper or two? But certainly these are two separate scientific questions and deserve to be presented individually. I was wondering, Fernando, if you could comment on some of the theme that Craig had brought up about large volume fluid. Given the large sample size that was studied, was there sort of folks at the end of the distribution that did get larger volumes? And what did you see in treatment effects in those?
Yeah, so what I can say, so the first thing, it's very hard to predict how much fluid a patient is going to get when he's admitted, right? So we are planning to do some kind of a matched propensity score analysis where we would match patients that would be predicted to receive a large amount of fluids and then run a secondary analysis. But actually, so far, no model can actually predict very well how much fluid a patient is going to get. So the greatest determinant is, of course, the site and probably the attending physician, right? Because there are so many individual variation in practice for fluid therapy. So we have data on that, but we have to be very cautious when we assess that data because it's a post-randomization variable, right? So patients must be alive to receive fluids. And then, of course, in the first day, we have some deaths, and we can count that or compensate for that. But that's one of the secondary analysis that's going on. We also have one secondary analysis that we are working on whether baseline fluid use and admission type, fluid use before enrollment, of course, and admission type could modulate the effects of the interventions in the trial. And this is being made and it's almost ready for publication. And we have some very interesting facts mentioning that perhaps, baseline food use may have an effect on the intervention. And this has been seen in SMART, right? So in SMART, patients with sepsis, for example, when they received balanced solutions in the emergency department and then balanced solutions in the ICU, they had a lower mortality than when they crossed over to a different group. So these are the two secondary analyses we are working on, and we hope to have data on that soon. Of course, they are post-hoc analysis, and of course, they have several limitations. But dealing with that specific point that Dr. Coppersmith mentioned is very hard from a technical perspective because patient must be alive, and there is a wide variations, and sometimes sites that use more fluids, they have a worse performance overall for several reasons, for example, right? So it's very hard to find a proper model adjustment there that can provide, a fair interpretation of what's going on.
And thank you, Fernando. There is a question about the study design. I mean, great study, they say, but with such a large number of patients, there was no signal to interrupt the study for futility before?
Yeah, so as far as we discussed with the DMC, no. So the DMC did not recommend interrupting the trial. We had 3 interim analyses for the study and 1 extra safety analysis with 1,000 patients before for the infusion rates, just for safety. But we had 3 interim analyses, and in none of the scenarios the DMC came up with interrupting the trial for futility, right? So that was actually not planned in the trial design. So the DMC, of course, is free to suggest that, but that was not planned during the DMC charter. Of course, interrupting the trial has several issues, and of course, we can only provide some such interesting and good data on the subgroups because we reached the end. So it was not designed to be interrupted, and the DMC never suggested to interrupt the trial, so that's why we went further, right?
Okay, and we have some questions also on the infusion rate study. As you know, I wouldn't consider a fluid challenge either the 300 or the 1 liter in that sense, but just 2 different infusion rates. But can you comment a little bit more on the hemodynamic effects that you're seeing short term?
Yeah, so this is a very good point. So, right, so when Vegas was designed, we had a lot of discussions on whether we should or not allow food bowls, right? So, if I could go back to 2016, I would say, well, let's do, one group is not getting bowls and the other is getting bowls, for example. But at the time, I believe that there was no equipoise for that, right? So, no one would accept a very large trial that would not allow food bowls, at least in a sense. Then our idea was to mimic, let's say, the 5th trial for adults. Of course, we came up with 500 over half an hour because of the FINIS study, which was a standard of care. And then we had to select another infusion rate that had to be a little bit arbitrary, and of course, we got 1/3 of that because it was easier for sites to remember, and because some sites would still consider that a food challenge, right? But that's, of course, there's a major limitation in the interpretation of data. What we have that Flavia Machado and team ran is a second-level sub-study on around 120 patients where we have hemodynamics during the food challenge. We do not have cardiac output for all patients. But what I would say regarding blood pressure is that we have seen what others have seen already, that probably, the effects of the food challenges are very short-lived and they are kind of unpredictable. But what I can say, having let's say a peek at the data, and we are following the analysis plan, is that probably we're going to see, regardless of infusion speed, that blood pressure goes a little bit up, but then it goes down again after the food challenge is finished, right? So I don't actually believe, and we will publish data on that the 333 was, let's say, not a food bolus in the sense that no patients would have a benefit on cardiac output or blood pressure. So that actually may have happened in the subgroup. But of course, this brings, let's say, the idea of this arm was more to bring out the discussion, right? So we have to rethink again on how fast or slow we give fluids to patients. So that's a very important point, as would be temperature of the fluids or other markers. So we have to be very careful not only to focus on type of fluid, but all the process of fluid therapy. So even if the BASICS trial, this arm of BASICS trial is remembered for by saying, well, it was a trial that assessed that, and it opened the path for understanding better, the flags of fluid accumulation, etc., particularly in patients, and whether it can, let's say, inform de-resuscitation trials, for example, or other resuscitation trials. That would be a very good legacy for this trial. Of course, it's not definitive.
Anyway, Fernando, great congratulations to you and all the Brazilian Research Network. What you're doing is really amazing, and again, another fantastic trial. Craig, thank you very much for being with us. And Chris, I think it's about time, unfortunately, to close this fantastic session. Maybe one last comment from you.
Just my congratulations to the investigators, and thanks on behalf of JAMA. For your collaboration and a wonderful session. So thanks to everyone.
Thank you all, and thank you for being with us at Lives Digital 2021. Thank you. Digital 2021, our annual Congress, is now over, even though you will be able to access all content that was streamed live during these days in our video library. Thank you for these exciting days and for your wonderful contribution and the interaction and energy that you brought. It really made a difference. This was the second digital edition of our Congress. We decided to hold it digitally again because we wanted everybody, wherever they were in the world and whatever travel restrictions are in place, to have access to the latest advances in intensive care. The availability of vaccinations now in some parts of the world had made it possible to lift some of the travel restrictions. This will allow us in 2022 to resume face-to-face events. We are very excited about it, but we are well aware that the pandemic is not over yet. We will carry on asking and promoting fair access to vaccinations all over the world. We will also take every step to support ICU teams with access to research and education so that ICU patients and families get the best care. We will do so by using all our resources and media channels and collaborating with international institutions. So, if in 2022 you will be unable to travel for whichever reason, do not worry. The Society will be there for you. We will always find ways to bring you the most relevant and up-to-date research and education in intensive care. And importantly, a way for you to connect with the rest of the global intensive care community. So stay tuned in the following months and remember that together we are intensive care.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.